Hello. Good morning, everyone. So, Gujarat Orthopedic Association and Indian Orthopedic Association welcomes all the delegates and faculties from in Rajkot. Uh, it is time to start our program for the next 6-7 hours, and I would like to invite our first speaker, Dr. Ketan Thakar Sahib, who is the okay, yes, sorry. Dr. Shrinivas Rao Sahib, who will give the welcome message and begin the program. Everybody please take the seat, and as we are planning to begin the lecture soon.
Hello. They say well begun is half done, so let's start at the beginning. Friends, colleagues, and all of you gentlemen, good morning to all of you. I'm honored to welcome you to the Knee Preservation by HTO workshop conducted by the Knee Preservation Subcommittee of the Indian Orthopedic Association and organized by the Gujarat Orthopedic Association. As the president of this esteemed organization, I am delighted to see a gathering of dedicated professionals committed to advancing the field of orthopedics. In an era dominated by knee replacements, our focus on osteotomy is a breath of fresh air, a testament to our commitment to exploring alternatives and preserving the natural function of the knee. With over 3 lakh knee replacements taking place in India annually, the urgency to consider alternatives becomes paramount. Reports indicate that 40% of surgeries in our country could potentially be avoided, and among them, knee replacement holds a prominent position along with cardiopulmonary bypass, cardiac bypass and hysterectomy. The significance of our collective efforts to save the knee cannot be overstated. Today, we embark on a journey to delve into the intricacies of osteotomy, a procedure that offers hope and a viable alternate to knee replacement. By coming together, sharing knowledge, and embracing innovative approaches, we strive to make a lasting impact on the landscape of orthopedic care. I extend my heartfelt gratitude to all the distinguished speakers, delegates, and the sponsors who have contributed to making this workshop a reality. Let us engage in meaningful discussions, exchange valuable insights, and pave the way for a future where preserving the knee is not just an option, but a priority. Thank you.
I welcome Dr. Ketan Thakkar Sahib to deliver his first lecture on the history and development of high tibial osteotomy. Thank you, Dr. Ketan Sahib.
Good morning, everybody. I first of all take this opportunity to thank the Knee Preservation Subcommittee of the Indian Orthopedic Association, who has given this opportunity to Gujarat Orthopedic Association through Dr. Rastogi sir, who's the chairman, the president of that subcommittee, who's here with us. A big round of applause for him. and Dr. Dinesh Thakkar, who sort of works in tandem with him throughout the country, and they hold such workshops for the betterment of the people. Okay, so I have been entrusted with the responsibility of talking about the history of high tibial osteotomy. Now, till this time when the replacements have taken over, the situation regarding the high tibial osteotomy was like Ek Tha Tiger. It was a sort of getting a forgotten entity. Thanks to all the efforts done by Dr. Rastogi sir and Dr. Dinesh Thakkar and their team, it is now coming back to the fore and saying that Tiger abhi bhi zinda hai. So, एक problem છે નિલેશભાઈ. એની મેળે જાય છે. એની મેળે ચેન્જ થાય છે. ચેન્જ નથી થતી, ફ્લિકર થાય છે એકચ્યુઅલી. ચેન્જ થતી હતી સર. केबल ला ने, केबल चेंज करना. Okay, so after a little bit of glitches and gimmickry with the technology, let us go back to the slides. So Carl Sagan, who was a very famous astronomer, he went on to say that you have to know the past to understand the present. Obviously, it goes without saying for any other topic. Osteotomy developed from the 19th to the 21st century. Of course, it was well known before that as well, but what was the game changer? What actually changed people's mindset towards osteotomies was the introduction of anesthesia, a lot of surgical techniques which meant that we were saving on blood. Of course, the technique of asepsis, which was introduced in the 19th century by Lord Lister, and then the detection of radiography, again, way back in 1889 by William Röntgen. What were the indications in the past? They were not actually being carried out for the purpose that we are doing right now. So if there was a severe genu valgum, post-traumatic deformities, rickets was a major concern in those times, and of course many other congenital bowing deformities and traumatic deformities. Now the way in which it was being done was basically osteoclasia. We being orthopedic surgeons who have been trained can know the principles regarding osteoclasia, and this was done manually, as we were also taught to do when we were students. And then find a press. Then the osteoclasia apparatus was developed by Lawrence. This was how it looked like. The first modern osteotomy in literature was talked about by John Rhea Barton, who performed a subtroch osteotomy for flexion adduction deformity of the hip way back in 1826. The aim was to develop a pseudo-arthrosis, and the operation very astonishingly was done without any anesthesia, and of course no, and it was like doing a 100-meter sprint or something like that. It was done in 7 minutes flat. Bone healing was avoided by daily mobilization. In 1835, Barton performed a supracondylar wedge osteotomy, which again was seen post-trauma. These were the people who worked more on osteotomies. performed osteotomies in different indications, and they were successful in those times. Hein prepared an osteotomy which was used to do osteotomies in those times, and he made a stab wound straight to the bone on inner aspect of the tibia, and then he devised a particular kind of a saw. Billroth chisel was another instrument which was devised in those times and which was done for malunited tibial fractures. Sir William McEwen went in to do the first antiseptic osteotomy in 1875. Now, I am a little bit unsure because Lord Lister sort of did this in a similar time. What our textbooks have been sort of teaching us is maybe the first fracture surgery which was carried out was also done by Lord Lister by a fracture of the olecranon. In 1880, Sir William McEwen published a first book on which was exclusively on osteotomies. Just imagine during those times, he had published an entire book. And then, of course, we come to the more popular, more famous, more known. I mean, all of us have passed through that Coventry staples and the way of doing osteotomy through staples. So it sort of went on for a long time before we started indulging into the plates, which became a more stabilized form of osteotomy fixation and further healing. What happened was, during that time in 80s and 90s, joint replacements came up in a big time, and that's why this suddenly started having a dip. So it was like a case of the osteotomy is in the mode of hum chhod chale mehfil ko. But in 21st century, they have come back with a vengeance, the osteotomies. It is like kabhi alvida na kehna for these kind of surgeries. So we had new implant designs. We had, of course, the help of the C-arm image intensifier, the power saws, and of course, a lot of new investigation modalities which helped us to make better planning, which is what we are going to see today, that a lot of pre-planning and all those maneuvers that we do before the surgery are much more helpful in doing a more successful surgery, which was what the criteria at that time. So the whole idea, the whole emphasis is to save, because we are talking about saving nature, we are talking about saving trees, we are talking about saving the tiger, and the third one, people in Saurashtra know that we are talking about save tomato also. In that case, it is better that we talk of saving the knees as well. And the other thing which came around was with the replacements, people were getting unhappy कि पाल्टी मार के बैठ नहीं सकते हैं, Indian toilet use नहीं कर पा रहे हैं. So many such things which were the demands of day-to-day patients, especially in India, and that is where like people were telling that even after doing replacements, I cannot sit down. What's the big idea? Why am I undertaking this? So that is where the thing came in कि करो ज़्यादा का इरादा और ये दिल मांगे more. We wanted more out of a surgery which would give you results which were more functional. So these were the kind of needs or necessities that people wanted in our kind of Indian kind of setup. We are not like living a Western kind of culture and lifestyle big time. So people in the villages or in the smaller towns, they wanted to remain not just active, but they wanted to go for farming, which is where they need to sit, squat and sit cross-legged and all that stuff. People want to do yoga, which is the big new health funda. People wanted, different cultures or different religions wanted sastang dandvat, niche let ke, yeah, people wanted to do namaz, or the Jain people wanted to do khamasnas. All these were possible only if we think beyond the replacements. All this led us to rethink our strategies, and it came back to the same thing that we really needed HTO much more than we really thought it was needed in the past. So we are back to the future. We want an action replay of the osteotomies. I'm sure that they are going to help us more and more, and I'm not telling that, of course, there are different indications. Talking about arthroplasties, we sort of feel that they are reincarnations because you are getting a new knee-like. But then, in our Hindu culture and mythology, we talk about salvation also. Moksha pan madvo joiye. So uske liye we need HTO. We want to live with the same knees. We need that. So as I told you, history seems to be repeating itself, and the prodigal has become a prodigy now. We are coming back to Ghar Aaya Mera Pardesi regarding, I'm talking about the HTOs. So ultimately it boils down to the fact that replacements have their own set of indications. We are very sure there are certain indications where replacement is the only choice. No doubt on that. We are not taking anything away from the replacements. But at the same time, there are so many indications, so many cases who genuinely deserve to get a HTO done rather than jumping onto replacement, thinking that to be the only choice. And that is where I really admire Dumbledore, who said that it is never about the abilities. I know that all of you here are very, very respected and very senior, and all of you know how to do an replacement. I mean, that's through the jigs and everything, it has become a very simple kind of thing. But at the same time, doing an osteotomy is not very difficult. That is what the respected and esteemed colleagues here and the seniors are going to deal with us. So let us dwell into those aspects, and let us understand that the choices are important. Abilities, we know we all of them have for either osteotomies or for the replacements. Thank you very much for patient hearing.
Thank you very much, Dr. Ketan Thakar Sahib. Now I would like to request Dr. Avinash Maru sir to deliver his talk on overview of high tibial osteotomy.
Yeah, good morning, my HTO friends. In 2019, I had been to USA for a deformity course, and there was a pre-conference workshop on preservation of the knee joint, and that was cancelled because there are no delegates. And I can understand there are a few people here. Are you justifying, or I don't know what is the message today? Either there are too many marriages or not interested in this topic. Marriages, okay. We protect the topic. No, but I am in for osteotomy. I'll tell you something about my basics of deformity and its correction. And if I am, it'll take 1 or 2 minutes. Full के? So this is how we stand, either in attention or in ease. This is how our limbs are properly aligned every time. God made. You appreciate there is some valgus at the femoral level and there is some varus at the tibial level. So any osteoarthritic changes, if we try to reconstruct it, we should try to achieve this, which is not possible. This is how we stand on one leg stance. It's 3 degrees of varus overall. This is the best position to walk fast and run fast. This is God given. There are 2 aspects of MCOA deformity. Bone deformities, femur varus, valgus, torsion, with or without pro-recurvatum or recurvatum. Tibia varus, with or without torsion, with or without pro-recurvatum, recurvatum. And joint deformities. What are the joint deformities? There is MCL laxity, LCL laxity, plate 2 depression, patella mallet trekking, and flexion contracture. These are the things which you have to consider for osteotomy. If you see the correction of the any deformity, if cora is a different place than the cut, then you have translation. And this was done by Jackson and Waugh in 1961. This was the osteotomy. You appreciate how the translation is there and how much the bone is not aligned that properly. And then there is some problem with the bone healing, so osteotomy was pushed to the superior part, above the tibial tubercle. And you appreciate how it has been done. It's a wedge closing osteotomy. There was bone which was removed above the tibial tubercle area, and the correction was achieved. So this is how you get the translation of the deformity, either proximally or distally at any place. Everybody knows about this thing, Fujisawa point or Fujisawa area. It's almost 32 and a half area of each compartment of the knee, medial or lateral. If you consider 0 to lateral, this is 100%, this is 100%. This is where the Fujisawa point is there. And then the whole area of that area is Fujisawa area. Now this you have to understand this. If there is no loss, only varus, this is the Fujisawa line which goes at the 0 degree. If there is 1/3 of the loss, your correction should be little more laterally, medial 1/3 of the Fujisawa area. If it is 2/3 loss, then your correction should be middle 2/3 of the area of the Fujisawa point. And if your total bone-to-bone contact is there, then you have to correct the alignment to the lateral 1/3 of the Fujisawa area. This is what I have mentioned about it. So the best results are obtained when HTO is obtained when mechanical axis pass through the 30 to 40% lateral plateau region. We call it Fujisawa point, right? That we have covered it. This also we have covered it. Now, how the load-bearing affects the alignment and how it is transmitted in the native person. In the normally aligned knee, 2 degrees varus, that is, I am talking about basic thing. The middle compartment bears 75% of the weight. When the mechanical passes through the center of the knee, the middle compartment bears 67% of the weight. If it is moved in 4 degrees valgus, the load is 50% medial and 50% lateral. If it is moved to 6 degrees valgus, then the load is 40% medial and 60% lateral. Most of us, you all will be doing it regularly. 2 degrees to 6 degrees valgus for the treatment of MCO is ideal. This was established by Coventry, Fujisawa, and all the other authors. Results deteriorate when you got valgus more than 6 degrees. So what are the pitfalls of closed wedge upper tibial osteotomy? Conversion to Coventry or any closed wedge osteotomy has poor results because bone resected is proximal to the tibial tuberosity and it moves closer to the joint line and you lose some bone. Whereas the principle of replacement is that you must have more bone. What you lost is your revision is very difficult in such cases. Patella may ride proximally, creating pseudo-patella alta. Pseudo because patellar tendon is abnormally long in patella alta, but here it is normal of normal length. If patella may not ride proximally, suppose you do an osteotomy and you fix it in, splint it in extension, then patellar tendon and retinacle can tether with the bone. And then what happens? It is an extension, right? This is pseudo-patella baha according to insult-salvati ratio, pseudo because tibial tuberosity to patella distance decreases, but patella to femur in extension remains same. This we have to consider it. This is how it happens. length of tendon remains same, but Patel alta, it can become Patel alta, pseudo. Here pseudo baha. If you do the restoration of the knee joint by replacement, the ratios are restored automatically. You can appreciate what is happening with closed bed osteotomy. It's just in picture. This truncation, this medial displacement, weight bearing line is not aligned properly. Cora is more proximal and you are doing the osteotomy inferior, little lower. Now in this scenario where there is ligamentous laxity, lateral side, and you correct the alignment, so what happens then? When patient starts walking one leg stance, it opens up laterally. This is what it happens. You can see it. So when you do an osteotomy, you have to see the ligaments, very important. And when you do closed wedge osteotomy, I mean, Dr. Rana, Dr. Ketan had prepared their own method of osteotomy. They used to cut the fibula while doing closed wedge osteotomy. And they just left the ligament like that. I don't know how you are doing it, but I'm a proponent of open wedge osteotomy, but then you will create a lot of lateral laxity, and results are not good. Now we have some cases to demonstrate. 55-year-old female, complaint of knee pain, diagnosed as usual, AMCOA. Plan was medial wedge HTO with fixator and gradual correction of deformity. This was her alignment view. It was 10 degrees of deformity. This was the X-ray, standing. And this is the first image after surgery, open wedge osteotomy with a fixator. This is the final X-ray. For the other side, she did not prefer osteotomy because we had some pintat infection in that patient. And she says, I don't want HTO. So we had to recourse to this treatment because of her other knee. This was done before 3 months, and this osteotomy is now 2 years, 2.5 years. A 47-year-old female, same knee pain, enteromedial OA with 10 degrees of varus. Planned medial open wedge osteotomy with tomofix and acute correction. This was acute correction. This is pre-op X-ray. This is how we fixed it up. And this is interim follow-up. This is the final follow-up with alignment view. This is 0 degree alignment, 0 degree, because she had no loss of cartilage. It is lucky that you achieve this, otherwise it's difficult to get the same line every time, because eyes can see some limited things on table. And this is a sure shot, I mean, one shot surgery is a bullet which is fired, you have no chance to retrieve it. With fixator, you can still do fine tuning. But she wanted a plate only. She refused for fixator. Now, these patients developed common perineal palsy and which recovered after 9 months. Medial surgery, medial side, still weak. I don't know how it was damaged, but that is how it is. A trauma case with varus. Very young female and severe varus and there was lateral thrust. It was 20 degrees of proximal tibia varus. This is how the pre-operative X-ray was there. Sorry, this is how the alignment was there. You can see the alignment, 20 degrees. This is how we corrected it. In this patient, our own fixator assembly became too short, so we had to ask for a separate type of assembly from Pitkar people. And they were ready to provide this. It was a long assembly. We had to correct more. Unfortunately, she didn't come up for follow-up because of her pregnancy. So we don't have a last X-ray. Now this is again a trauma patient, 36-year-old male patient. Tibial plateau fracture with metaphyseal extension with bipolar plate was fixed. Treated with varus and anterior angulation. Plan was removal of implant and medial wedge opening osteotomy and fixator, gradual correction. These are the first pre-operative, at the time of accident, the X-ray was there. This is how it was fixed. This is courtesy, my friend Dr. Shyam Goyal, he has given me this. We had operated together after that. This is how it is at the end of the union with varus and anterior angulation. This is how we did it. This is how we opened it up. Only thing is that we couldn't correct the slope here. You can see we couldn't correct the slope. I don't know what will happen. The patient just come before a few days. He says, I cannot bring it this way. Now you can stand only in recovery time. You cannot stand in 0 degree position. Am I right? In recovery time, you don't get tired. You cannot stand like this. 5 minutes, you have a problem. This is the final X-ray before just 3 days. What is the take-home message? Instead of one osteotomy for all cases of MCM, it's only one pattern of osteotomy. You have to choose. It's a la carte approach. You cannot do that. I'll do this and I'll do that. Identify the cause of malalignment using MAT. That we'll do in this workshop. Decide whether you need femoral or tibial osteotomy. Identify level of cora because you cannot go far from cora. Choose type of osteotomy. Which type of? Closed wedge, open wedge, barrel vault, or smiley, or weeping osteotomy. What do you want? Did you have correction because that patient we had no fixator of that size available, so we had to order it. So you planned properly. Choose a type of fixation. What do you want to do? And sometimes patient will decide your type of fixation. They say we don't want it. We tell them that this is what is going to remain outside, and you have to stay with this for 105 days or whatever it is. So give them a choice. And you must know both the system of fixation. You cannot stick the, I'll do this. Ascertain how much is medial thigh fat, which is very important. I'll tell you, if a patient has a waddling gait in your clinic when they come to you and there is a varus, don't operate them for HTO. You'll regret it. This is my own experience in my family. Thank you very much.
So Dr. Maru also wants to show one of the case that he has done recently. So it will take 2 minutes and then we start with the next lecture.
Good morning all. Myself Dr. Rahul Patel. I am presenting just a small case. This is just an overview of HTO, how you approach for the young arthritic knee. This is a case of 32-year-old female having a knee pain since 2 years. And she tried everything. She did physiotherapy, lifestyle modification, all pain management modalities, but ultimately there is no relief. Here is the X-ray. So there is no virus or little virus, 3 to 4 degree virus. So what is the cause of pain? How will you find the cause of pain? Yes, 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 sir, yes, yes. Yes, yes. How will you approach? There is no laxity. There is a medial joint line tenderness only. Okay, go for MRI. Yes, sir. We did MRI and alignment X-ray. Okay. So on MRI we found there's ghost sign. That tells about the posterior on medial meniscus root tear. So there is some subchondral bone edema. There is some cartilage, partial cartilage loss, and ACL mucoid degeneration. There is a root tear. Scanogram. This is scanogram. And these are the values. There is almost 4 degree of virus. LDFA, MPTA, all are within normal limit. And it is identical to other knee. And in another knee, there is no pain, absolutely no pain. This side has pain since 2 years. So what will you do, sir? Okay. Okay. Meniscus, okay. 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 32.
32 years.
Yes.
So, if she cannot tolerate, obviously, we can go for the HTO.
HTO.
Very small correction it will require.
Okay.
And with or without root repair. Usually, I encounter this kind of patients.
Okay.
And in that particular, our philosophy is that as such, arthroscopists, those who are doing arthroscopy can do root repair and whatever the treatment required for the posterior horn of medial meniscal tear.
Okay.
But without HTO, posterior root repair doesn't work. Actually, that has been proven.
Okay.
So
only HTO works.
we do reverse actually. I do reverse. I do HTO, and if required, then arthroscopy. We can call arthroscopy, no doubt, but still only HTO can solve the problem most of the time.
Now,
arthroscopy, we can plan, but I don't recommend. No, mostly it doesn't require. That's why. Most of the time it doesn't require. It is a degenerative tear. If we go for a established osteoarthritis medial compartment, there will be a lot of degenerative tear in medial meniscus. We don't do anything for that. No, in young patient, there is no harm in doing root repair. No, but without osteotomy, it doesn't work. Without osteotomy, it doesn't work. Only. That is the reason, because arthroscopists, obviously, we can call arthroscopists, they can do root repair, and after that, we can do HTO in the same sitting. But even Dr. Mangal and we discuss in detail, even our group on knee preservation is going on with more than 600 members. So in that also, he has suggested do HTO. Most of the patient will not require any arthroscopy, but if required, that option remains open. That's why we can avoid arthroscopy and HTO, because it's not easy to do arthroscopy and HTO, because it requires a lot of physiotherapy post-operatively. Because I have faced that. Yeah, that is the reason.
HTO is must.
Do you try to correct the cartilage damage by closing osteotomy?
No. Offload, just offload. Just offload.
What does to the joint? What does the cartilage? I
I don't. No, but In this patient it's okay. Otherwise, initially I started doing HTO. It was my dictum to call arthroscopist, do arthroscopy, check the lateral compartment, but genuine arthroscopist, doctor, so many, even including Anand Joshi in Ahmedabad, Deepak Goel, Sanjay Trivedi, everybody has said that Dinesh, it doesn't require. If you are calling, we will come and do that thing. So if required, we can do it later on. Some mechanical symptoms is there. So genuinely they refuse. So even I purchase arthroscope to learn, to do every time. But after experience, I found that it is useless exercise.
No.
Excuse me, we are running out of time, so we can debate and discuss this within the tea time or in the lunch time, because this is a never-ending debate.
We will.
So we
will do it
move
last
forward
also.
with the case, right? So I would request Rahul to just finish the case fast.
This was the ACL, arthroscopic finding. This is a medial femoral condyle damage. This is a root tear. So we did the both, root repair with HTO. Medial open wedge, Tibial osteotomy. This is a root repair. And this is the post-op X-ray. So, take-home message. So HTO is an answer for medial compartment osteoarthritis, but you have to calculate the other concomitant pathology, like ligamentous instability, meniscus tear. Radial tear particularly is very detrimental for the joint. Thank you very much.
Thank you very much, Dr. Rahul and Dr. Maru, sir. I would request Dr. Navin Thakkar, sir, to give us his thoughts on pre-operative planning of upper tibial osteotomy.
ચાલુ જો મારો માઇક ચાલુ થઈ ગયો નથી કર્યું ચાલુ ના ના એના કરીશ થઈ જશે તો શાંતિ રાખ ના ઓડિયો હશે હા ઓડિયો હશે પણ એસટીએમ આવી જશે ને નહીં એ પેલી બાજુ જવું પડશે. Good morning to everybody. We are thankful to Rajkot Orthopedic Association and Gujarat Orthopedic Association for inviting here. The topic given me is the pre-operative assessment and pre-operative planning. It's a little bit difficult topic, but let me make it simple and interactive. This case has generated a good discussion. So let us have a small discussion again on one case. Why we want this pre-operative assessment and why it is required pre-operative assessment for these cases and how to plan it and what are the possible pitfalls and what are the possible problems and what are the possible solutions out of that we will be discussing. So let me start. We'll be learning together. This is the patient, male 52 years, municipal corporator. History of a small injury, abhay. Fall, limb pain, not feeling normal. Strength of the limb, he was not feeling normal. He had a small limb. So he went to orthopedic surgeon. X-ray was taken in the municipal hospital because it was free to him because he was a municipal corporator. And this was the injury, right? Surgeon said that why so much of complaints are there with this? And he thought that treat by ice packs and drugs, nothing else, right? So he treated like that. Still there is a pain and not feeling normal, walking but not feeling normal. Surgeon again took the decision, new X-ray epilateral, right? So he took again in January 2016, this surgeon advised after this much of pain for the TKR. What do you think? Now it is referred to you. MRI was done. There was no instability. Still there is a pain not feeling normal after 9 months. Why? No instability clinically. What will be the right and simple decision? MRI was done, but there was only a knot. MRI films were not there because it was with the municipal hospital. And this is the last X-ray. What will you do, sir? The mic chal raha hai na? Clinical findings, pain only, nothing, sir. No instability, sir.
And the MRI showed.
MRI knots were there. It's insignificant.
Then we would like to take a.
What
full
assessment? CT scan. Okay, good. CT scan was not done. What else than the CT scan, sir? Fantastic. Simple skyline view will be helpful to you. So that was missed by everybody in the assessment. We routinely miss this X-ray. We routinely miss. And surprisingly, what was the source of the pain? I took the simple decision to see the third plane, advise one more view. And it was a non-union patella. It was a vertical fracture of the patella. It was going into non-union, and that was the source of the pain. So many times the assessment is very much important so that you can come to know what is the problem, real problem. So you must do a complete assessment before taking any. And this limb, biomechanics OA is commonest in the knee because largest and most complex joint. 3.4 times the body weight while walking, 4.3 times body weight while climbing the stairs. So it is continuously under stress. And the problem, the main problem is the shift of the weight bearing line from the center. It can be due to primary wear or secondary to varus of the proximal tibia due to osteoporosis in the metaphysis. So common in the medial compartment, why? Osteoporosis in the proximal tibia, microfractures in the proximal tibia, lateral metaphyseal height is maintained by the fibula. So that has a good support. And the collapse on the medial metaphyseal region leads to the varus. OA increases the varus. Varus increases the OA. Both have a very good relationship like politicians and whatnot. So varus malalignment worsens further. These are the papers. In 2001 and 2003, you can see when the varus is that, it worsens the osteoarthritis. But where is the evidence? Why should I choose HTO in my practice? That is a routine question by all orthopedic surgeons. So this is the literature. Varus affects the damaged knee more. KL score, if it is more than 2, the progression is 4-fold. If it is more than 3, progression is 10-fold. That has been established. So again, our focus during all this is alignment, 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 and alignment. And this is the paper. Precise restoration of varus angle is most important, and these are the papers which have shown the life of the HTO. And the most important, the benchmark paper is of Cosino. He has said that he has a survival rate of 93.2% at 15 years. Only thing he has advised is little bit overcorrection. If you do a little bit overcorrection, then and then you get a good survivorship. That was his finding. What is the normal alignment? We are going to have a complete exercise of drawing all these angles. Anatomical axis and joint angles. These are the anatomical axis and joint, anatomical and the mechanical axis. Anatomical lateral distal femoral angle you are going to measure. There will be a complete exercise. There will be some repetitions. Anatomical femoral tibial angle, anatomical medial proximal tibial angle, and the anatomical lateral distal tibial angle. These are the terminologies you must know, and you must know all the values. Mechanical axis and the joint angles, mechanical lateral distal femoral angle, mechanical medial proximal tibial angle, and mechanical lateral distal tibial angle. So anatomical and mechanical femoral angle is also there. That is around 3 degrees. We all know that the mechanical axis of the limb runs slightly oblique from the craniolateral to mediocaudal at the angle of 3 degrees. We must understand this slope also. We have to take care of the slope also, because that has been shown previously, Maru sir, that the slope could not be corrected. And we know this, Jenu Varam, and what are the mechanical axis deviation. We are going to do this MAD test on the workshop. And this is the general line that MAD more than 15 mm medial, it is a varus deformity. But again, the varus deformity, you have to know that varus is a tibia or a femur. That has to be defined. Then and then you can define your treatment, or you can plan your treatment. Same way valgus. So clinical evaluation, patient history of trauma, previous surgery, professional activity, expected patient activity, skin and soft tissue status, vascular, neurological status, range of movement, and most important, knee instability has to be checked. Imaging, X-ray, all X-rays has to be taken. And not in the short film, in the long film, right? To document ligament instability, soft tissue, you have to take the stress views. Then you take the stress view. If you find clinically it is like that. This is very important view to pick up the early osteoarthritis. That is the Rosenberg view. What is that view? That is exactly 45-degree flexion of the knee, and it is taken at this angle. It documents early the medial compartment. In young patients, many times there is a pain, and routine X-rays doesn't show you the compartment, but here you can see that already there is a osteoarthritis changes with the Rosenberg view. So Rosenberg view is a very important view. Full length weight bearing X-ray, entire limb with the patella facing in the front. Why? You can see this is short film, and the calculation done is 85-degree, anatomical lateral distal femoral angle. How much and where is the deformity? You will not come to know whether deformity is in the femur or the tibia in the short film. Now you see, this is the anatomical medial proximal tibial angle, right? And once you take the full film, then the angles are different. So you get cheated if you do not have a full length X-ray. So there is a change of 8-degree difference here with the short film and the long film. So always it is advised to have a long film. Imaging, how to take it. Again, there was a question that how to take the full length X-ray. For a common orthopedic surgeon, all do not have a facility. So there are many views. One is the standing long cassettes are available with the digital X-ray. You can have a long cassette completely. You can fill up 3 cassettes in that. And you can have a single shot stack inside overlapping IP of 14 to 17 cassettes. And then you can have a no grid lines. Adjust the cortical thickness. There is a stitching facility in the software. You can stitch it. No grid line. Adjust the cortical thickness. This is the way you can take in the standing. Auto stitching facility is there in some of the softwares. There is also possibility of stacked cassettes in the stand. In the chest stand, you can make the adjustment and stack it one above one. And then you can take the X-ray and you can have a good X-ray. MRI, yes, as said, meniscal and ligament lesion, degree of changes in the cartilage, status of cartilage in the lateral compartment. But routinely it is not done. But there are studies that how MRI can be helpful to decide. Bone marrow edema is a predictor of progression of degeneration. So you become watchful. You can plan it. You can counsel the patient. There are possibilities. So that you can call them and see that there can be a possibility of degeneration. CT scan is rarely indicated, useful in post-traumatic defects only. Gold standard to evaluate is the torsional malalignment can be done with the CT scan only. Scintigraphy is not required at all. What is the normal alignment? How to do calculate deformity alignment angle practically? That is the next question for the assessment. These are the different things has been described in the literature by different authors. Desired post-op angle, femorotibial, Coventry, Angel. Everybody has described their own findings. These are the another method where how to plan it. So Minasi method says that 60 to 70% of the desired post-op position of weight-bearing line as a percentage of the tibial plate to width. So medial border of knee is defined as 0 and the lateral border is defined as 100. This is one of the method. Another method is the Fujisawa scale where it's a 0 and 100 on the both the sides, lateral and medial side. Center of knee is defined as 0. Medial and lateral border is defined as 100%. And 2/3 of cartilage, 10 to 15%, 1/3 is 20 to 25%, none 30 to 35%. So again, this method we are going to see in the exercise. Draw a mechanical line. Line 1 represents the weight-bearing line of the post-op correction extending from the center of the hip to the coordinate of 67%, 60 to 70% of the tibial plate to width. This is the line you have to draw. Second line you are drawing, the line 2 connects the osteotomy hinge. You must decide the hinge, and that it should be a point with the center of the ankle. And the third line you draw, which connects the osteotomy hinge point with the arc of intersection of the line 1. And that will calculate your angle of correction. There are different methods. This is another method where this can be checked by this, and you can plan your osteotomy, either medial or a lateral osteotomy. This is another method. Line 1 is drawn from the center of the femoral head. Line 2 is drawn from the center of the tibio-talar joint and to the 62.5% coordinate. Angle formed by these two as correction angle. But we'll follow one method only in the exercise. Here is the line is drawn from the center of the hip to the 62% 5 to the coordinate. X-ray is cut in the line. You can plan it. It is better to plan on the paper first and then in the operation theater. The correction angle corresponds to the lateral overlap of the lateral closed wedge or a medial opening of the medial open wedge. Whatever way you want to do. This is the method, and this way you can calculate on the X-ray. The Coventry method is useful if only short AP view is available. Then you can calculate with this formula and you can calculate what is required. Where is the deformity? That you have to find out first. You draw the line. You have a full length, complete X-ray, scanogram, and then you decide here it is 100, femur is MLF DVA, joint line is 4 degree, then tibia you have measured 81 here, you can see here gradually where is the deformity. So you have to measure all these lines, and the pre-operative planning is very, very important. You can see here 10, 2, 6, 18. Right? So anatomical axis, again you can measure femorotibial, 5 to 7% is the valgus. Aim is 3 degree over correction. You always aim for little more correction because you may lose some correction later on. So this is the 7 plus 3 and the 6 degree you require. So you require this much of this. So that has to be, can be calculated. Now softwares are available. Softwares are available with your film. You can plan complete osteotomy on the software where you can put this and you can plan, and there are different tabs where you can plan that, draw a line, measure the angle, put the plate, decide the length of the screws. You can reduce, increase the length of the screws, and you can come pre-op planning with what size of the screw will be required. Here you can see that it shows exactly where will be your base of the cut and where will be you end at the hinge. exactly you can plan it on a software. And you can put a plate in a planning itself, in the planning software. Once you put a plate, exactly after putting a plate, you can open up and you can check that where will be my this screw, where will be my this screw. So you are well prepared on the table. You can even increase, zoom it. You can increase and decrease the size of the screws on the software itself, on that patient's X-ray itself. Once you check this, you can increase. You can see that once you take it, that will measure your screw size also of that patient. So it will be around that. So you are well prepared with everything. So softwares are also available now. So if the mind knows the principle, you can choose your method, whatever way, E equal to MC square. Aim again is to get the normal alignment. So again, emphasis on alignment, alignment, and alignment. But how to calculate the wage? That is another question. The 2D is the planning and execution is the 3D. So many people say 1 degree equal to 1 mm, but that is not correct. It depends on the tibial width of the patient. Every patient has a different tibial width, and this is the ready-made table where it says that what is the tibial, your breadth. So only at the 57 degree mm diameter mediolateral of the tibia, 1 degree equals to 1 mm wedge, that dictum is possible. So always think that what is the size of the tibia, accordingly your wedge will be. That is the one method. Another is the graphical method. You have to make a template and check that template, cut the template and make a template. This method we are going to describe. Here you do not require anything because it's a gradual correction. It's a surgeon-friendly gradual medial open wedge osteotomy. How can you correct the sagittal plane? You have to think of the sagittal plane correction also. Flexion contracture, SCL laxity can be corrected by reducing the tibial slope. And the recovery deformity and PCL laxity can be corrected by increasing the posterior slope. That can you also do. And you can measure that. And there you have to measure in both planes in a complex way. But always, always pen drape both the lower limbs to compare. And always see that you can see completely these rotations also in the C-arm. The hip center, knee center, and the ankle center should be available to you continuously. And you must have a complete lateral view to see this line and the shift of the angle. That is required in the planning. You can see here, plan a template to measure the angle. You can plan exactly how much angle which you had planned and how much you achieved post-op on the X-ray. And so that will give you the exactly. Dinesh bhai has made this template, metal templates ready, plan for template to measure the angle. So detailed steps are very much required, which approach you will take. Method of fixation which you are going to choose. Write down plan completely. Hinge, direction of the osteotomy and where you will end. Which implant you are going to use, whether you use the bone graft or not, and watch for the pitfalls. There are possibility of pitfalls. Osteoporosis, hold of the implant will not be good. Span of the fixation, always think of whether you require additional fixation on the another side, because when there is a not good fixation, it will be a problem. Suppose the lateral cortex breaks. Suppose there is an intra-articular extension while you are doing osteotomy. You must plan and be ready with another fixation method. Plan is a proposed or intended step of the actions in that circumstances, ultimately to get the objective of the goal of the alignment, taking care of the anatomy, biology, stability, and motion all together. That is required. So continuously analyze the situation, continuously think of what the plan is. So there is a 0% failure, 0% consequences if you plan on the paper. But if you plan in the OT itself, it is a day one failure. So prevent day one failure, plan on the paper. So we'll be doing exercise to plan on the paper. So surgeon has to balance between the undercorrection and the too much overcorrection. Overcorrection is also the harmful. So we are back to the basics. Can we improve the outcome by the misalignment or correction? Yes, we can do that because it is in our hand. So planning is in our hand. And plan to counsel the patient. That is also important. How I will counsel the patient. Most important and most difficult part is the counseling to get them by the osteotomy. Ask them to endure the short-term discomfort and enjoy the long-term benefits. So you have to explain that there is a long-term benefits and you are preserving the knee. So we'll be learning together. Thank you very much.
Thank you very much, Dr. Navin Thakkar, sir. Now, I would ask the faculties to get ready for the inauguration and lamp lighting ceremony. I would like to call all the faculties, Dr. Srinivas Rao, sir, Dr. Ketan Thakar, sir, Dr. Avinash Maru, Dr. Navin Thakkar, Dr. Sanjai Rastogi, Dr. Dinesh Thakkar, Dr. Samir Shah, Dr. Nirbhay Shah, to come on the stage for lamp lighting ceremony.
Dinesh, have a seat. Without taking much time, it's a pleasure to declare this conference open. I'd request all the delegates to join me for lighting the lamp and lighting the light of knowledge. Please.
शत्रुबुद्धि
चेयर हटवा दें, चेयर हटवा दें.
चेयर कट है.
यार ये विजन में आ रहा है, इसका क्या चक्कर है?
बोलो.
ये यहाँ होना चाहिए ना. हाँ. हेलो 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 हेलो.
So I would like to call on stage Dr. Sanjai Rastogi for his talk on medial opening wedge high tibial osteotomy with angle stable implants.
Good morning, seniors, friends, and colleagues. At the outset, I'd like to thank especially Dr. Dinesh Thakkar for having invited me, and he has helped me conducting these workshops all over the country. And I still remember the first one when he had come to Kanpur to help me conduct the workshop. Now, osteotomy in the recent times was done by put-do plate, but because of the higher failure rate, because when the gap was more than 10 millimeters, patients were obese and osteoporotic, it led to instability, implant failure, slope increase, and pseudoarthrosis. And the AO group formed and they developed Tomofix to take these problems away from the procedure. We also had hemical in which the distraction was used with fixator, but it has long wearing time. Patients had discomfort. There was pain during distraction, and there's high rate of infection. So in 2012, this system was developed, which has 7 plates. The most commonly used is plate on the medial side of tibia, because tibia vera is the commonest, and 85% of the patient would require this type of fixation, which we are going to see today. And for this reason, this is the first one which should be learned by us. The Tomofix is a biological fixator. That means it conserves soft tissue and bone vitality. It acts on a splinting principle. That means there's some micromotion at the fracture site. It is not a rigid fixation. The alternate weight bearing leads to new bone formation, and it is made of titanium because it is better tolerated and better biomechanical properties. And this is a one-stage special fixator which was introduced in 2000. It had 4 proximal holes for 4 screws in the proximal part, 4 in the distal part. It can have an opening of up to 22 millimeters, and it does not require any bone graft on the medial side, as they have shown in the first 700 patients. Now, when we apply it for the first time, there is a question in the mind whether there's enough space for the implant to be there. And if you see, the distance between the articular surface and the upper end of the plate is 1 centimeter. And the distance between hole A, B, C and D is 3 centimeters. That means if we do a osteotomy 4 centimeters distal to the joint line, there is enough place to put this plate and fix it. The distance between hole D and hole 1 is 26 millimeter. That means for a rigid fixation, we should not have opening more than 22 millimeters. So the osteotomy gap up to 22 millimeters is possible. Then in 2010, a new generation of plate was launched, which was smaller in size, but biomechanically it was identical. And the plate has a thickness of 3 millimeters on the complete length, and there are 4 holes in the proximal part and 4 in the shaft in the distal part. And this allows load distribution over a long distance. The disadvantage was Purdue plate was that is smaller, so there were more pressure in a smaller area. Now it is in a larger area, so it's strong, and there's plastic deformation of the plate takes place because it's only 3 mm, and which allows it to give some micro motion. The hole A, B, C, which are the proximal holes, have an inclination of 10 degrees distally, and 2 spacers are used of 3 mm each in hole D and hole 4. So this keeps the plate away from the bone. The hole A, B, C are long monocortical screws which are directed posterior laterally, and we must have the longest possible screw to have more purchase. The holes in the plate in the distal part are staggered, so this avoids longitudinal diaphyseal fissure fracture. It is a minimally invasive procedure. One must remember it conserves blood supply to the bone and soft tissue. So wide dissection is not needed, and after fixation of the proximal part, a tunnel is made by finger in the distal part where implant is put, and the screws can be locked with a stab incision. So this leads to conservation of the blood supply. The spacers act as pillar of a bridge. The osteotomy gap provides more elasticity, so there's more newborn formation, periosteum, pes and serenus, and MCL is not pressed by the plate. It is away from it. And once we have done the osteotomy, then a cortical screw is applied in hole A, which is distally directed. This compresses the lateral hinge, and it does not require any plate on the lateral side. And as I said earlier, it does not require any bone graft. And there is improved primary stability because of the presence of the plate on the medial side, because these screws in the proximal part are long and spread out. On the lateral side, there is a bone contact because the hinge is there, and on the dorsal side, there is screws are directed posteriorly. So this gives a complete global support into the proximal part. Tomofix has to be understood. It is different than any other implant. It has to be understood well, and it is quite, if you understand it, it is quite easy to handle. It is user-friendly and good reproducibility. So if you have understood why something is there, then you can use it without problem. And as I said, in first 707 cases, the VAS improved from 4 to 0.5 to 1. Patient was able to walk without crutches at 6 weeks on an average. There was no neurological complication, and only 3 patients required trachea in the first 1 year because of increase in deformity. And this is how this helps. The weight is being borne on the medial side, and as we open the wedge, the weight lining is transmitted to the lateral side, which leads to unloading of the medial side, and this heals. So who is an ideal patient for medial open wedge high tibial osteotomy? Active patient, a patient who was an active lifestyle. 70, even 90 is taken as active these days. A patient who has a tibia bone varus angle of 5 degrees, which is unfortunately or fortunately commoner in Asians. So these patients would require and respond better to an open medial high tibial osteotomy rather than a uni joint replacement. The opposite compartment should be intact. That means weight is transmitted onto the lateral side, which is normal. There should be flexion deformity not more than 20 degree. Up to 20 degree, it can be corrected while we are doing this procedure. Patient must understand that he would have certain amount of pain on strenuous activity. If there is a ACL, PCL deficiency, it can be corrected at the time of surgery. Obesity and smoking is not a contraindication because it's an angle stable implant and patient can be made ambulatory. The contraindications are when there is loss of lateral meniscus, there's degeneration of grade 3 or grade 4 cartilage on the lateral side, there's limited range of motion, that means or the deformity is more than 20 degrees, or when there is a poor soft tissue on the medial side and the pain is because of systemic or inflammatory disease. So it is basically when pain is because of tibia vera, then this is indicated. A question is asked about arthroscopy. Arthroscopy per se is not indicated. Arthroscopy is only advisable when patient has a mechanical problem. Osteoarthritis, if you do arthroscopy, it leads to faster degeneration of the joint. So arthroscopy is not the treatment or investigative modality unless there is a mechanical issue. Now, this is to show you what is the biplanar osteotomy. So there is an ascending osteotomy, which is by a smaller blade, which is complete, and there is a transverse osteotomy, which is in the posterior part of the bone. So this is what the biplanar osteotomy is there. Patient is operated supine with lateral support and a foot pad, so the knee joint could be kept in a 90-degree flexion and full extension, and the contralateral legs should be lowered. This allows to take AP and lateral view without moving the extremity. Now, where to do the osteotomy? There is a junction of a convex and concave part on the medial border. So if you feel your knee joint, you will find a clear-cut point which is roughly 4 to 6 centimeters distal from the joint line. And if you do the osteotomy here, then it leads to a isosceles triangle. That means the proximal and the distal cortex align well after surgery. The bony landmarks are in 90-degree flexion. We mark the joint line, cranial border of pes and sinus, medial collateral ligament, and tibial tuberosity. As I told earlier, the pes is at a distance of 4 to 6 centimeters from the joint line. So this is the area which can be felt in practically all patients, and this is where the osteotomy should be done. If we, the skin incision has evolved with passage of time. Previously, oblique incision, longitudinal, and MIPO incision was used. The advantage of MIPO incision is that infrapatellar branch of saphenous nerve is not damaged, and one can preserve this nerve. And so the incision is 5 to 6 centimeters. It's starting from a point anterior to insertion of pes in a posterior cranial direction. After the incision, the pes is identified and the proximal border is retracted distally. And this is a diagram to tell you where the incision should be placed. There is a insertion of the medial collateral ligament, which is 4 to 6 centimeters from the joint line, and it is placed more posteriorly. And so when we retract the pes, we see there's a blue dot which is there. This is the pes and serenus bursa, through which we retract the pes and serenus, and from there we erase the medial superficial ligament to avoid pressure and proper opening of the osteotomy so that the slope is not changed. So this is how the medial collateral ligament is released. Now, another very important thing is that the osteotomy should be atraumatic. This is very important. It requires right equipment, right technique. And what it is, the entire sawing procedure should be done very slowly, with little pressure, with constant cooling, and with specific blades. Normally, people give you blade of joint replacement which are 1.27 millimeter thick, which leads to loss of bone. For this, the blade which has to be used is 0.9 mm, which is 20 mm wide and 90 mm thick. The ascending osteotomy is done by 0.45 mm thick, 20 mm wide, 15 mm wide, and 50 millimeter long. And if you done osteotomy with all these precautions, you can see in a fat suppressed image, there is hematoma is seen with the arrow at the osteotomy side, and there is no bone edema. That means there is no injury to the bone per se. This is soft tissue conserving. With 3 weeks time, there is hyperintense granulation tissue, which is an indicator of a new bone formation. That means the osteotomy starts to become stable in 3 weeks time. So this is what helps us to do a functional rehab. So it does not mean that the patient has to be immobilized for a long period of time, and gradually hematoma reduces. And 6 weeks, there is more new bone formation, and the hematoma is further reduced. So the transverse osteotomy, as I have said, is an isosceles opening. It is junction at the convex and the concave part, and it extends up to a point just proximal to lateral tibiofibular proximal joint. It should not enter into the knee joint. It should not enter in the tibiofibular joint. If the osteotomy is done distal, then correction is less. If it is higher, then it leads to instability. And for internal navigation, we put a wire in the 1 centimeter distal from the joint line, and it has to be in the plane of the lateral tibial slope. This is the red line which is seen on a lateral view, and this is the upper limit from where the plate should go, and this is first passed in an AP plane, then 2 wires are passed just proximal to the osteotomy site, just proximal to the pes insirinus, in a manner that you put a C-arm which is seen as a dot, the AP wire, and these 2 wires overlap as seen in the last, and this forms the slope for the osteotomy. The transverse wire must end exactly up to the lateral cortex, and which is seen in 30-degree internal rotation. So when you put it the limb into 30-degree internal rotation, these wires should not enter the tibiofibular joint. They should not cross the lateral cortex. This is how they are, and it is 1 centimeter away from the lateral cortex. So both wires are parallel to the tibial lateral slope. Then you measure what is the depth, and this is measured by keeping the same length wire onto the part which is outside, and then you measure and you transfer this distance onto the osteotomy blade. So this is the, as I said, transverse osteotomy, which is an incomplete osteotomy. Now when you do a transverse osteotomy, we cut the wires so that it is easy to access the bone, because if the wires are not cut, then you can't go close. And as I said, the cutting depth is marked onto the blade. And one should start cutting the posterior medial cortex first, because it is the hard bone. And once you have cut the posterior medial, then it is done easy. Now there is a fear that the neurovascular structures could be damaged, but this osteotomy is done with knee joint in 90-degree flexion and a Hohmann retractor placed onto the bone and deep to popliteus muscle, so the neurovascular structures are protected. People previously believed that the lateral hinge is stable, but there is no plastic deformation. We have to go as close to the lateral cortex, because this will lead to fissuring of the lateral cortex, and if it goes proximal, it will go to the joint line. If it goes distal, there's instability, and this instability can lead to iatrogenic fractures, decreased stability, and improper bone healing. So this is a big problem. One has to cut the bone right to the end. Insufficient osteotomy of the posterior cortex is there. Then if you open, then you will not open it posteriorly, and there will be change in the slope. So this is part which has not been cut, and this will lead to plateau fracture, unstable lateral hinge, and increase in tibial slope, because posterior cortex is not cut. The ascending osteotomy is parallel to the shin of the tibia, and it should be at least 15 to 20 mm wide, so that there's a thick bone available, and if the correction has to be more, it should be wider. So this is parallel to the shin of the tibia, and this should extend proximal to tuberosity and up to the joint line in between. So it is 1.5 to 2 centimeters thick, and these are the areas where blue lines in which this should fall. So it should not damage the tuberosity, it should not go onto the joint line. And as I said earlier, it is a complete osteotomy. So biplanarity is a wall against dorsal translation. So it does not translate dorsally, or it does not go into internal rotation, and you have to make sure that on table they are in contact and parallel. The ascending osteotomy is done by a thinner blade, which is 0.45 mm thick, 15 mm wide, and 50 millimeter long. After the osteotomy, one should use a ruler to see that the posterior cortex is colored, and then you pass chisels with the depth marked onto the chisels. First is passed distal to the wires, and then between the wire and the first chisel, you put another chisel, which is pushed 1 centimeter less than the previous, and you gradually put 1, 2, 3 chisels. Each chisel, subsequent chisel, is hammered slowly, less than the previous, and this gradually opens. And when we open the osteotomy, the ascending osteotomy should remain parallel. So this must be, the green lines are that it is parallel, because the bone is triangular in shape. That is the reason you see it is opening less anteriorly, more posteriorly. What we have to see, that the ascending osteotomy is parallel. If by chance there is a fracture of the hinge, then before displacing, we must put 2 wires, one in the proximal, the other in the distal part, to see that there is no rotational deformity. And while we open the osteotomy, there is simultaneous lateralization of the tuberosity and the ligament patelli. So for an opening of up to 10 millimeter, there is 3 to 4 mm lateral displacement. Then you check the correction with a caliper, and fine tuning of the osteotomy can be done by keeping a alignment rod passing from the center of the hip to the center of the ankle, and you can see where do you wanted the the weight bearing line to pass. Normally it is at the descent of the tibial slope on the lateral side. Now, what are the pitfalls in slope management? The orientation of the osteotomy has to be parallel to the lateral tibial slope. The release of MCL should be done sufficiently. The spreader should be placed not too anterior, not too posterior, otherwise there will be change in slope. And the final correction is checked with knee in complete extension, and the cautery test is done from hip to the knee to the ankle and in complete extension. Then the guide wires are removed. Then we prepare the osteotomy plate with the help of a guiding block. Remember, the plate is only 3 mm thick. So it is essential to use this guiding block to place the LCP drill guides perfectly. 2 spacers are put which are 3 mm thick in hole D and in hole 4. This is a subcutaneous tunnel made in the distal part to put the plate in the center of the tibia, and then we can palpate the holes. You put an incision, and through a nick, you can lock these holes. And first we fix the locking head screws in hole A, C, and B, and after that a cortical screw is passed in the neutral position in hole 1, which leads to pulling the osteotomy segment close to the plate, forces the plate into suspension. There is a elastic preload, and this also compresses the lateral hinge. This is important. And then we put a screw in the neutral position, and remember, this screw should be discarded because it gets deformed, and it is directed in the direction of 10 degree in the distal part. After that, monocortical locking head screws are put in hole 2, 3, and 4 is replaced by a cortical locking head screw. So this is the final fixation. Hole D is also a long monocortical screw. Hole A is the only hole in which we put a bicortical screw for better purchase. A hematoma is retained by a compression bandage for 8 minutes. An overflow drain is placed exiting the proximal fragment, and this is the final radiological control while we are waiting for the hematoma to stabilize. Post-operative management in the first 24 hours, pain management, cold compression, cryotherapy, and we have to work off full extension to avoid any friction deformity. On day 1, partial weight bearing is allowed. No range of movement is restricted. Arthrosis is optional, and then we take X-ray in 2 planes. Follow-up is done at 6 weeks, 12 weeks, 6 months, and 1 year, and our implant removal is usually done at 1.5 to 2 years time if need be. So the advantage of a biplanar medial open wedge high tibial osteotomy by Tomafix is it preserves the vitality of the soft tissue and bone. It is inherently stable because of the biplanar nature. There is a gradual opening with the adequate release on the medial side. Compression of the lateral hinge is done for the stability, and it's an angular stable plate, and it allows functional rehab. This is a case which was operated 8 years back. The medial proximal tibial angle on the right was 79, on the left 78. This is 13 months post-op when the union is clearly seen. This is of both other side operated. His VAS was maintained at 0.5 and 0 at the end of 8 years. The knee joint range was maintained, and there was a improvement in the knee functional score and knee score. I would like you to concentrate the third sound when this patient is walking. He is able to walk in spite of the age of being 69 with complete third sound. He is not hesitant. So this shows that it has healed quite well. He is able to sit on the um, floor with some raise. So any patient who has a tibia vera, which can be checked by self-examination, and this is what I always propose, that the patient with knee pain should be advised to do a self-examination in front of a mirror, like they advise self-breast examination in female. If a patient has tibia vera, he would definitely develop osteoarthritis knee. So the take-home message is that overlaid medial compartment osteoarthritis knee in an active individual should be treated by medial open wedge high tibial osteotomy. We should not be dhritarashtra. We should not close our eyes to evidence, science, surgical skill, and need of the patient to sit on the floor and squat. This is what was said by many speakers in the morning session, that we have to have a solution which is good for our patients. We must understand the Koshino, who was a batchmate of Dr. Ranawat. After they graduated, Koshino went back to Japan. Ranawat stayed in US, where he worked in joint replacement. Coventry was changed loyalties. He also went to joint replacement, while Koshino worked on knee preservation, and we are having the advantage of his wisdom. And this is a quote which Dr. Stobly said, "A man who works with his hand is a craftsman, one who works with his mind is scientist, and one who works with a heart is an artist, but one who works with mind, heart, and hands is a surgeon." So thank you so very much for your attention.
Thank you very much, Dr. Rastogi, sir. I would like to request Dr. Srinivas Rao to felicitate Dr. Sanjai Rastogi with a token of appreciation.
Or we can do it later.
Kaushal.
Thank you. Thank you so very much. My pleasure. Thank you. I'd like to have a copy, share with a copy of this. Right. इसका पॉइंटर नहीं है यार, पॉइंटर नहीं था इसका.
I would like to request Dr. Navin Thakkar, sir, to give his talk on opening wedge high tibial osteotomy with the help of a fixator.
Dr. Pandit sir is not here, so I am taking that part, responsibility. Source change kare. Gradual medial wedge opening osteotomy by external fixator. You all know this technique. We'll go in a minute details so that we can discuss the reason. Medial opening wedge osteotomy by external fixator, again, aim is to get the right correction. And the Fujisawa point has to be kept in, and it will be a gradual correction. You heard about the medial open wedge and with the plate, but this is a possibility, another alternative for a gradual medial wedge opening. So, how much correction we can do? 2 to 4 degree of overcorrection as a best result, neutral or undercorrection or significant overcorrection has a inferior results. The newly achieved axis should match with pre-op planning. The knee and ankle axis should become barrel. So to get the exact valgus, if you have a control outside with you and you can increase and decrease, then you are at advantage. You will not do overcorrection, you will not do undercorrection, and you can examine it and do exactly what correction you require. That is the principle, that is the advantage why this method is good for those who are starting as a HTO, because on table, you cannot take a complete long film and you can measure exactly what is there. Whenever you're fixing the plate, whatever you're fixing, whatever the angle you have measured or whatever angle you have corrected, that you are accepting on the C-arm or a X-ray film you are taking with a short plate. So these are the advantage. So again we are discussing why this method is important, why we are choosing this method, what are the advantages with this method, how to plan this method. And there are also pitfalls in this method also. Every method has a pitfall, every method has a problem, every method has some solutions. After doing repeatedly that same procedure, you can innovate something. So again, what is essentially it is, lateral wall is not cut in the osteotomy. It acts as a hinge for gradual opening. No translation of the distal fragment. You are not doing translation of the distal fragment, so you are not burning the bridges for the future TKR. Osteotomy fixed with the external fixator. So there are small holes only. They are away from your incision of the TKR. So it is not again burning the bridges. Bone graft is not needed because new bone gets formed gradually as osteotomy opens up. Gradual opening, always under the control of the surgeon. Small incision away from the future TKR that we have said already. Can start mobilization from the second day. Non-weight bearing, that is a disadvantage. Even with the plate, you are keeping non-weight bearing for few weeks. Restriction after 7 to 10 days. Partial weight bearing second month, full weight bearing third month. And it gives consistently good results. And there is no change in the anteroposterior law, if you do rightly. These are the explants. There are no implants. That is the advantage. It is all explants. It is not implant. So no implants are there. This is the position of the patient. Very small video clip. So that you have a space here to manipulate, to keep this pillow. Then first step, most important step is selection of the pin, first pin. And that pin you have to select in a very good bone of the proximal tibia. Otherwise, it will be loosened out. So this is the first precise posteromedial placement, otherwise loosening, that is a pitfall. So this is the first step. You have to be very accurate in this selection and angle. Keep the lateral hinge, otherwise no control. Instability and pitfall. So always keep the lateral hinge, go slowly. And you can put these 2 pins in this direction at the hinge. The tip of that screw is going on the hinge. You can, in the osteoporotic bone, you can use the HA-coated pins to get the fixation. These are the small incisions, 2 pins above in anteroposterior and the 2 pins below. And there is a small incision here where I have put a guide pin to check my direction is ending at the lateral hinge in the tip of fibula or not. You can see here, it is quite below. It is quite below. And take care that keep this at the posterior cortex to prevent the damage to the posterior structure. Always keep your spike here so that you can see that where is the posterior cortex. That is the commonest problem, commonest fear with orthopedic surgeons about the serpentine structures. All serpentine structures is problematic. What I do, I put a guide pin and I make a first drill hole so that my direction is complete. Then on that drill hole, gradually we can put an osteotome and osteotomize further. But when you are putting an osteotome posteriorly, always see once in the C-arm. So your osteotome position should be like this. It should not go out much on the posteriorly, otherwise you can damage the posterior structures. Be gradual. By osteotome only, we are not using so here. In a small, such a small incision, we are not using the so. You gradually complete anterior, medial, and the posterior. Lateral, anterolateral is kept like that. Then you can open up the osteotomy on table completely. First you open up completely on table, you check that it is opening up because you are going to hand over to the patient whether it is opening or not. And check on the C-arm also whether it is opening or not. This is gradual opening. That video of clinical, this is the video of C-arm, where you can see that it is opening up gradually. Precise posteromedial placement and keep the lateral hinge, these are the most important things. And that has to be taken care of. And once you take care of this, your operation is almost over. Go on correcting gradually till you get the right correction as planned preoperatively. You plan preoperatively, but you can change it gradually because the mechanism is outside the body. This is the one of the case where you can see that gradual correction has happened and it is getting filled up by the bone. Gradually, it is opening up. Another case where you can see that gradual opening up and the final healing. So disadvantage is the most important disadvantage is the acceptance by the patient because the pins are there for 3 months. So you have to explain a lot. Posteromedial proximal pin has to be precise placement, has to keep careful not to break the lateral wall. And you need pin track care. You have to explain the patient for pin track care and education. Advantage is patient acceptance is done. If you explain about the metal removal, opening up the surgery, and the re-surgery after correction. When TCR is required, the plate is there, you may require to remove it, or you may not require to, but it's again an incision in that area. And another advantage is control correction as planned, minimally invasive, away from the joint, TKR friendly, even if required by chance later on, not burning the bridges. Message is HTO survivorship is directly related to correction of the angle achieved. And here, you can judge later on. You do not require to judge intraoperatively. Has to be precise. And again, the objective, the aim is 2 to 6% of valgus. Cartilage healing depends on this correction of 4 to 6 degrees more correction. It is proved in the literature. 92.3% survivorship at 15 years is possible as the author has mentioned. External fixator is a precise method to achieve this controlled gradual correction. So again, surgeon has to balance between the undercorrection and overcorrection, and we can go to the basics. Thank you. Thank you very much.
Thank you, Dr. Navin Thakkar, sir. I would like to request Dr. Ketan Thakkar to felicitate Dr. Navin Thakkar. I would like to request Dr. Kaushal Patel to begin his talk on role of arthroscopy in osteoarthritis.
So, good morning to all. So, from after the osteotomy, now there is a time of, is there any role of arthroscopy in the osteoarthritis? So, the role of arthroscopy mainly, I have divided into two. Like, it's a frank osteoarthritis, like grade 3 or 4 KL, and in the joint preservation surgeries, like HTO, proximal fibular osteotomy. So, the role of arthroscopy in the osteoarthritis is always debatable. Those who are dealing with the HTO daily, they will not recommend arthroscopy at all. And those who are dealing with both the arthroscopy, they mostly look for the arthroscopy treatment in all the gray zone patients. So the two principal arthroscopic procedures, like the arthroscopic debridement or synovectomy, and like arthroscopic partial meniscectomy, for the symptomatic meniscus tear, like the bucket handle tear, flap tear. But the role of arthroscopy in joint preservation surgery is a bit different. Because the joint preservation surgery, it mostly depends on some prognostic factors, like the cartilage status of lateral compartment, associated symptomatic meniscus tear, any loose body or osteochondral fragment in the joint, chondromalacia of the patella. So to deal with all the kind of problems, if you do arthroscopy before the HTO, I don't think so there is any harm while dealing with only HTO. So it's better to put a scope first and then go for a HTO. So if there is any kind of these problems in the joint, you can easily treat them at the same time along with the HTO. So there are some literatures like the open wedge high tibial osteotomy along with the combined arthroscopic surgery in the severe medial osteoarthritis give a very good result at the 5-year follow-up. This is another research from the Orthopedics 2011. Do microfractures improve the high tibial osteotomy outcome? Yes, they have higher satisfaction rates compared to the only HTO patients. Now, particularly today we are talking about the role of arthroscopy along with the HTO, not with the frank osteoarthritis patient. So first is a root repair along with the HTO. The Dr. Rahul Patel has already shown this case previously. Another one is a flap tear along with the HTO. Third one is a microfracture. It's very debatable. There is a role of microfracture or not, but yeah, you can go for a microfracture with around 1 or 2 centimeter cartilage defect. Third one is a chondromalacia patella. If the patient has a grade 3 or 4 chondromalacia, you can clearly shave off that under surface of the patella to give a smooth surface. Thank you. So now I would like to invite Dr. Chintan Vadi to throw some light on the role of arthroscopy in the osteoarthritis.
So, is there any role of arthroscopy in early osteoarthritis? I say I don't think it has any meaningful role. Why? Because which kind of patient profile we are talking about? We are talking about age 40 to 65 when the patient is having chronic knee pain and effusion. Usually these patients do not have any instability or mechanical symptoms, right? Like how many patients you have seen with a early or advanced osteoarthritis with a bucket handle tear? Yeah. 1 in 100 maybe. And if the patient is having early OA, then his or her alignment is likely to be neutral or mild varus alignment. So in this patient profile, is there any role of arthroscopy? That is the base on which I will throw some light. So in 2012, many articles came, and these were original articles published in reputed journals where they compared arthroscopic partial meniscectomies versus sham surgery, in which the surgery was done only diagnostic arthroscopy, not a meniscectomy. And the patients was told that you have been operated for meniscectomy. Half of the patients were operated for meniscectomy and half were just scoped and the scope was removed. And these studies were eye-opening. The results of these studies were eye-opening, that the results were same. There was no difference in arthroscopic partial meniscectomy group versus exercise group at 3 months follow-up, 6 months follow-up, up to 5-year follow-up. And these led to debate, like arthroscopists tried to defend their home pitch, that these studies are likely to be biased. The American Arthroscopy, North American Arthroscopy Society even did a editorial against the New England Journal that your journal is biased, because the New England Journal had published 4 original research where all the 4 were showing that arthroscopy was not needed. So there was a debate amongst the community whether the arthroscopy is needed or not. So in 2016, and yes, the Fidelity trial also began, the Finnish degenerative meniscus lesion study. They also did a registry for what is happening to the patients who are being treated with arthroscopic partial meniscectomies. So in 2006, ESCA came with a meniscus consensus. So as a European Society of Arthroscopy and Knee Surgery, they gave guidelines. They defined a degenerative meniscus lesion, which is a meniscus tear in age more than 35 years without any significant history of trauma. And the arthroscopic partial meniscectomy was no longer recommended as a first line of treatment by this body. And it is offered only as a second line of treatment if exercise therapy fails. Now in 2018, another study came that is known as ESCAPE randomized control trial. And what the study was, they studied 321 patients aged 45 to 70. They randomized between arthroscopy group and 16 session exercise group. And at 5-year follow-up, the results were same. Fidelity trial, which was started in 2013, was now publishing the result in 2020. Their study was arthroscopic partial meniscectomy versus placebo surgery, that is diagnostic arthroscopy. Patient did not know whether he was operated for meniscectomy or placebo. MRI and arthroscopically proven tear in 146 patients. At 5-year follow-up, the results were same, but there was slightly greater risk of progression of arthritis in APM group, arthroscopic partial meniscectomy group. Meteor study in 2019, meniscus tear in osteoarthritis research. 5-year outcome, they saw 351 patients, APM versus exercise, 5-year results same. APM had a 7.7 rate of conversion to TKR, while exercise group had 4% conversion to TKR. So this was also eye-opening. Okay? Why 3.7% people are needing more TKR in arthroscopic partial meniscectomy group? prospective randomized controlled studies in 2020 published in OJSM. 150 patients randomized between APM and exercise, no difference found. Surgical outcomes were better in patients without mechanical symptoms. That was also eye-opening. Like we are saying that mechanical symptoms are likely to be treated better with arthroscopy. That was also not the case. Radiographic deterioration occurred in 60% patient in APM versus 35% in exercise group. So also radiographic deterioration was more in arthroscopy group. Review study OAR RSI, that is Osteoarthritis Research International, 2023 study. The study reviewed 13 randomized control trials. And they said arthroscopy results in very small improvement in function over exercise therapy in short term. Long term results are same. And they cannot identify any subgroup which the arthroscopy would give more benefit. So they were not even able to identify subgroups. 2023 CESTA published in May 2023 review study. 7 studies, all level 1 randomized control trials, 2,037 patients. Compared APM versus exercise. No difference in quality of life, pain, range of motion and physical performance. So to conclude, arthroscopy has a very negligible role in degenerative meniscus tear if the only symptom is pain. It should be offered only after exercise and lifestyle modification have failed. And lifestyle modification in India is a very challenging advice to give. Even when it's used in conjunction with HTO, it rarely adds value to the surgery because I have seen 1 or 2 articles where HTO with root repair is giving inferior results to HTO alone. So I don't know why it is like that, but the study shows that it's giving inferior results. And mechanical symptoms, which is in my practice, is the main indication of arthroscopy when the patient is having catching or mechanical locking symptoms. Thank you.
Chintan bhai, I would like to call on Dinesh Chauhan sir to felicitate Dr. Chintan bhai. Dinesh Chauhan sir. Parin Kante sir, yeah. Parin bhai. Shyam sahib. Shyam sahib. Would like Ketan Thakkar sir to felicitate Kaushal Patel.
So the first session of our today's day ends, and now we would like to have some question and answer for all these lectures. Like audience can ask question answers, and at the same time we'll be starting tea. So we are combining 2 sessions. Tea break is, we'll not like to have a formal tea break. The tea break is starting, like whoever wants to have tea can take tea and also at the same time ask questions.
Hello. Sir, you demonstrated a nice case doing fixator, HTO. Hello. But do you release MCL completely or part of it, or you pins or you start an osteotomy distal to the superficial MCL?
Distal, starting from the distal, going proximally. So not touching the medial collateral.
Okay. So in tomofix, we have to release MCL.
Yes.
Leave some of the posterior fiber.
Yes. Okay. Here not touching any ligament, anything.
Don't you find difficulty in opening?
No. It's a gradual. Na? You open up, close it. Open up, close it. Open up, close it.
And since how long you?
Gradual is always accepted in life.
Yeah, dilation, yeah, I understand. But sir, since how long you continue this fixator? Like 3 months post-op?
3 months, 3 months. You have to check on the X-ray.
Serial X-ray.
Then once it unites, you feel, then you can give a breath.
For to prevent pin track.
Routine pin track, you take care of the pin track wherever you take. It's a general principle of axiom fixator.
Add some comment on this.
Yeah, 100%.
Suppose you require 10 millimeter of opening. So you require 16 days to do that. And then you require around 2 months to 2 to 2.5 months. So the fixator stays for 3 months and 10 days approximately. Then you remove it. Because when you want to put in Fujisawa line, 1 or 2 days at the end of the distraction, you may need to do fine tuning. Either you have to compress it or you, as you were saying,
Yes.
gradually.
And indications of femoral osteotomy indications of femoral osteotomy in HTO. Like if a correction is more than 15 mm.
Dinesh bhai, he is asking about femoral osteotomy. His lecture is there. The last lecture is there of the femoral osteotomy. So we'll cover in that.
Sir, what I know is if the correction is more than 15 mm, then you have to think twice before correcting tibia more than 15 mm and go for distal femoral osteotomy.
Whole exercise. Now we will have a whole exercise in pre-operative planning. Where is the deformity? Suppose it is in the both femur and tibia, then we have to correct in both. Whether it is in the only tibia, then we have to correct in tibia. That will be the part of exercise.
Sir, my question, initial practice of external fixation in open wedge osteotomy, the pin placement is nearer to joint. Now you have changed to very distals, and the osteotomy also is a distal. Why there is some changes like that?
You don't have a problem in the fixation. You don't have a problem of Patel alta or other problems. And you are not changing much translation or nothing doing with that. You are just changing the angle, varus.
It is because of the bone quality, because nearer the joint, the bone quality is poor, and
Yes, yes.
from away, there is a pin purchasement is very good.
Very good,
So,
very good.
due to that,
You don't want to disturb the future TGR muscle.
okay.
So it is a unipolar osteotomy.
To joint. Down, okay.
And
15.
it is a unipolar.
There is one more trick I would like to share. Can you hold?
Yes, sir.
Now, when you fix the pin, proximal pin, you want to do fix distal pin. I keep some gap here. Reason is that after completing the osteotomy, I compress it, so that patient works better with the compression of the osteotomy. Keep this much of gap and compress it, and then you open after 10 to 12 days, as per your protocol.
Okay.
So you do the open up completely. You see for the MCL what you say, soft tissue, softening, and then you do that.
Okay, sir.
Any other question?
We are creating a wind sweep deformity.
You are creating, but at the same time, including other
Excuse me. Now we would like to start the session, so please take a seat. You can keep on drinking tea as much as you want. Session.
May I request everyone to please take your seats? Let us assemble once again as quickly as possible so that we don't lose out on time. Request all the delegates to please come on to their seats.
Delegates can have tea on the table as well. Kindly have seat.
Good morning, everybody. And I'm really very thankful to Dr. Ketan Thakkar, Dr. Srinivas Rao, and OSR for this beautiful arrangement and this wonderful arrangement so everybody can enjoy the whole workshop very much. Now everyone must have freshened up with tea break. Now close wedge is not a new thing. We all know close wedge is even older than total knee replacement. Previously, we know that close wedge was being performed, and these are the one long-term follow-up which I am showing. This patient was followed up at the end of 26 years, and he was operated in 1990 by Dr. Prabodh Desai. And here we can see that even at the end of 26 years, he is walking like a normal person. How I could come to this patient? Because his son was searching such a doctor that who can perform surgery like his father has undergone. So these are this was the reason he came to, and his father was there with him. So I took the full length photograph, and if we see the secret of success, then here we can see that even without full length X-ray, without much instrumentation, Dr. Prabodh Bhai has corrected it very nicely, and weight bearing exists post-operatively is passing near the Fujisawa point, even with the staples and plasters. So if some surgeons, some extraordinary excellent results. On the contrary, why Coventry was forgotten or why Coventry was not became popular? Because there were certain failed osteotomies. The reason at that time particularly we don't have a perfect full length digital X-rays. So we could not appreciate that whether we have corrected it properly or not. So at that time, somewhere going into the under correction. Here we can see that arrow is not showing, it's okay. But here we can see that weight bearing force is passing through the medial compartment. So it's failure on day one, or either gradually it collapses later on and it has failure. So if it happens, if we achieve the under correction, we will be out from the mind of the patients. And again, at that time particularly, we had a short AP X-rays. Where the mistakes was, at present we cannot plan anything on the short AP X-rays. Why? Because here we can see that long axis of tibia and long axis of femur. In short AP it shows 7 degree, and if we take full length X-ray and measure the long axis of femur and long axis of tibia, then it comes to the 12 degree, because there is a varus in the proximal femur also. So nowadays every patient wants perfect results, so we cannot plan in the short AP X-rays because digital full length X-ray is easily available. In short, we cannot plan by looking these short AP X-rays. We have to see full length X-ray, then our plan may change. So full length X-ray is a must in a new era. And what Vaizaul says, proper planning prevents poor performance. If you fail to plan, you plan to fail. This is how full length AP X-ray weight bearing we are taking with a single exposure. Now it's again a debatable topic, because now we have a DR system. In DR system, what happens, that there are 3 different exposures, and in that we have to stitch it. We have to check that whether it measures perfectly or not. Now in close wedge, the preoperative planning, already Dr. Navin Thakkar has covered this topic, but still I will like to do some few points, particularly for, I don't know, this is, first what we have to do, we have to draw a mechanical line, then propose post-operative line where the weight bearing force should pass, and then line 1, that is represents the plan weight bearing, line 2, connects the osteotomy hinge point. Here hinge point will come on the medial side. In open wedge, hinge point comes on the lateral side. This is again line 2, line 3, angle between these two is our correction angle. We have to remove the wedge this much angle. Suppose it is a 10 degree or 12 degree, we have to remove the 12 degree wedge like this, and then we can close it like that. So hinge point will come on the opposite side as compared to open wedge. That is the only thing what I have to say. And the site of the osteotomy particularly, which I am going to discuss, an apex in the metaphysis of the medial cortex. So it's an oblique osteotomy, and it's a diaphysial-metaphysial osteotomy. And what care we have to take? We have to take care that that apex should be exactly on the medial border. And the apex should exactly on the medial border if we are doing a closed wedge high tibial osteotomy. And as Navin Bhai also has described, if we want, there is no flexion deformity, then the on lateral side there should be parallel. And if we want to correct the flexion deformity, then we may remove and base anteriorly more and posteriorly less. And if you want to produce procurvatum, suppose there is because of ligament laxity, or if there is a posterior cruciate ligament laxity, then we may have to increase the slope. If you want to increase the slope in the closed wedge is not easy. I think it's very difficult. If we want to increase the slope, then we should choose the open wedge high tibial osteotomy. But we can, theoretically, we can produce procurvatum like this. this is for correction of the, FFD. If we have a few degree of FFD, then we can remove the wedge anteriorly more and posteriorly less. And these are the equipments which will require in doing close wedge. These are the prepared wedges, the tomofix plate, and this pointed clamp. This is very important for the close wedge high tibial osteotomy. And this is how what we are doing. We are not cutting posterior cortex, we are not removing the posterior cortex totally. We are cutting the only distal cortex of the posterior, distal part of the distal limb of the posterior cortex. And then we slide the distal fragment over this. Here in last picture, you can see that it has been slided over the posterior cortex. So strong posterior cortex is intact. This bone model is moving. In that also you can appreciate the posterior cortex is intact. Posterior cortex is preserved, not intact, but it's preserved. This is how in a IITV picture, and here we can see that. And another thing what we can do, we can preserve the lateral cortex along with their soft tissue attachment. We have to cut it, but on lateral side there is so many muscles attached to the lateral cortex, and that we can preserve, and that increases, that work as a vascularized bone graft on the lateral cortex. Posteriorly there is a very strong posterior cortex, and medially there is a tomofix plate. So it is fixed from all around. Here we can, I will show one case that 47-year-old female came with the pain in right knee since 2 years. On examination, there was no fixed flexion deformity with full range of movement, no cruciate ligament laxity. If we take a full length X-ray on the weight bearing, we can degree of varus. Sorry, it is a weight bearing. Here it is written non-weight bearing, but it's not correct. It's a weight bearing X-ray. But if we take a non-weight bearing X-ray, this is also written reverse. I'm sorry for that. But if we take a non-weight bearing X-ray, then it's a 7 degree. Weight bearing X-ray shows 10 degree of valgus. So if we are planning on the weight bearing full length AP X-ray, then we may end up in 3 degree of overcorrection. See, so what we should do, how we should plan. Actually, I am planning my high tibial osteotomy, every high tibial osteotomy, in a lying down full length AP X-ray. So it will, on weight bearing, there is a pseudo increase of the varus because of lateral collateral ligament laxity. And in initial practice, I ended up with so many overcorrections because of this minor mistake. So I could not appreciate initially, and every literature were suggesting it's only 3 degree change. But many patients, I have noticed that it's even 5 degree or more than 5 degree change on weight bearing and non-weight bearing. That case is also I will show you. But the idea is to tell that if we have to plan perfectly, then we should do planning in the non-weight bearing full length AP X-ray. Another, if anybody is going to want to start the practice of high tibial osteotomy, I will suggest that purchase how to take, hold that grid in which we can take full length X-ray at our own clinic. Then and then every minor things we can see even after surgery also what mistakes we are doing. So if you want to start full practice as a knee preserving surgeon, I will strongly recommend that we should have our own full length X-ray taking facility at our clinic. So here, according to Miniaki method, we have planned on the non-weight bearing. According to that, 12 degree of wedge has to be removed. And this is again a planning to take per operative X-ray. How this has been planned. So we have planned in first feature, we can see that we have planned that weight bearing axis should pass through the Fujisawa point. And so our plan is to bring the weight bearing axis like this. Here we can, on the second picture, we have seen that this lower femoral line is used as a reference line, and long axis of tibia, the angle of lower end of femoral line and long axis tibia should be 94. That we can measure on table. We can take short AP X-rays and then we can measure it on table that whether we have achieved 94 or not, we can exact. It can be 93, 94, 95 or 96. But it should be a range of 2 to 3 degree only. We cannot get 94. I don't see it's a perfect method. And this is the most perfect method what we can do, check. We can check our own correction on table. This is, sorry. This is the video. Why this has come? I don't know. આમાં નથી આવતું. It is not coming in this. Full screen अच्छा actually. Okay. Okay, it will do.
Midline incision.
Okay. It will be with the voice. Bear with it. I have recorded.
Is put starting from inferior pole of patella.
It will reduce my speaking.
After cutting skin and subcutaneous tissue, anteromedial surface of proximal tibia is exposed. Periosteum is raised from proximal tibia from where wedge is to be removed. Care is taken to avoid cutting of posterior cortex. So posterior cortex is kept intact at this stage. Multiple holes are made with K-wires to separate lateral cortex of wedge with its soft tissue attachment. Piece of bone is removed. One cortical screw with washer and stainless steel wire is inserted in proximal fragment parallel to proximal cut of osteotomy. Another cortical screw with washer is inserted in distal fragment parallel to distal cut of osteotomy. Middle segment of fibula is exposed by a separate incision over lateral side of midleg. Small segment of fibula is osteotomized. Now posterior cortex is cut only at distal limb of the wedge. Proximally posterior cortex is kept intact. Now osteotomy site is closed in such a way that distal fragment slide over the intact posterior cortex. Reduction is held with pointed clamp. Stainless steel wire is tightened between proximal and distal cortical screws in figure of 8 manner. Now locking plate is fixed on anteromedial surface of tibia. First cortical screw is inserted in distal fragment of tibia through combi hole of locking plate. Then one cortical screw is inserted in proximal fragment through combi hole of locking plate. Now remaining locking bolts is inserted in proximal and distal fragments. Now extra remaining stainless steel wire is cut with a cutter. Wound is closed by taking sutures in subcutaneous tissue after.
So this is how the high tibial osteotomy is performed, but in between we take per-operative X-ray because we have planned where the long axis of tibia we have to bring. So we can make it, we can prepare a template here like this with the normal angles, MPTA 87 degree and LDFA is 81 degree. So we can put this per-operative X-ray during surgery with temporary fixation. We can take per-operative X-ray and we can put on this X-ray. So this template. And here we match the lower femoral line. And the long axis of tibia, we can see, the blue line we can see, we have achieved little overcorrection. If we bring tibia on the same blue line, then it's a normal of the tibia. So we have to do little overcorrection. We can draw one more line, measuring 94 exactly also. But here I have not drawn this moving around. And here this represents the lateral, this
this is with soft tissue attachment. Here only, on the posterior side, only distal limb has been cut, and this proximal, it's kept intact. And if we slide over it, then it will look like this. On the lateral side, there is this is with soft tissue attachment. It is closed like this, and this side there is a strong tomofix plate. And this is how it looks. This blue tab, pink tab represents the soft tissue attachment of that fragment. So this fragment is a vascular piece, and another, on this side there is a strong tomofix plate, and on posterior side we can see that this is a strong posterior beak of posterior cortex. So this, it becomes stable from all around. If we have achieved this, then we can plan from posterior side it looks like this, and this is the post-operative X-ray. Here we can see that weight-bearing axis exactly passing from the Fujisawa point. There are 3 different criteria to measure whether we have achieved desired correction or not. One is that weight-bearing axis should pass from the near the Fujisawa point. Second is that there should be mechanical valgus of 3 to 6 degree, means mechanical axis of femur and mechanical axis of tibia. Angle between these two should be 3 to 6 degree. Lower limit is 3 degree, higher limit is 6 degree. And if we go through another method, that is the long axis of femur and long axis of tibia, then it should be around 10 degree post-operatively. So this, by all 3 methods, it's the desired correction what we have achieved, and so that we have crossed the mechanical axis, so we are safe, we are not out of from the mind of our patients. And this is the, if we have achieved perfect, then we can allow her to walk on the second post-operative day with a partial weight bearing after high tibial osteotomy. There is no need to keep, if we have other, if patient is younger, we are not encouraging bilateral high tibial osteotomy on the same sitting in a elderly patients. But if patient is young, here is a 49-year-old female, has pain in both knee, and then she was operated in a single sitting on both sides. And here we can see that after bilateral high tibial osteotomy, the correction is near ideal correction in both the plane. And if we see, we can allow her on the 4th post-operative day to walk. Sorry. She can walk on the, with walker. She is encouraged to go for the toilet even after bilateral high tibial osteotomy. So closed wedge has advantage that we can take some liberty of weight bearing earlier than the open wedge. And if we have achieved the achieved here, 48-year-old patient came in year 2006 with knee pain over right knee since long, and there was no smartphones at that time. This snap was taken with newly purchased digital camera in 2006, and at that time digital X-rays were also not freely easily available. So we have planned it on the simple AP X-ray that we are developing in our dark room, and then we did, even at the end of who was operated in 2006, in year 2023, we can see that he has a full function, he is completely pain-free even after 17 years. And in here we can see the secret of success that weight-bearing exists. At that time, there was no tomofix available in India, so it was fixed with the lateral hockey plate, what we were using in the trauma. And then weight-bearing exists, little overcorrection. I can say that it's little overcorrection, but still, patient is completely pain-free, and in between he has enjoyed the full function. He can even run, he can sit cross-legged. And even after 17 years, he is walking like a normal person. So these are the results even after 17 years. So we can expect more than 15 years pain-free after high tibial osteotomy. High tibial osteotomy is not the short-term solution. And so I request, and this seminar is only just not kill the knee joint. Please save it. And thanks for your kind attention. Thank you.
Thank you, Dr. Dinesh Thakkar, sir, for wonderful talk. Now I would like to request Dr. Avinash Maru, sir, to felicitate Dr. Dinesh Thakkar, sir. Please, sir. Thank you, sir. Now I would like to request Dr. Samir Shah, sir, to deliver his talk on the transcondylar valgus osteotomy.
I will be shifting was devised by initially by Professor Chiba. It is also known as Chiba's osteotomy. He was from Nagasaki. And his student, Professor Teramoto, further progressed, made modifications, and termed it as tibial condylar valgus osteotomy. And I had been to Japan in 2016, worked with him for 2 weeks, me and my colleague, Dr. Ajit Patel, and then we started doing this, and I will be focusing why we should also stress on stability and congruity of the joint. As a previous speaker, I think Maru sir said that HTO should not be done when patient has a waddling gait, when there is instability of the knee. The HTO doesn't give good result. I think you made that statement, sir. Fatty. So why HTO fails in certain patients, I will be highlighting that. Why it fails. And Ketan told that why we are saving forest, we are saving trees, we are saving electricity, we are saving the girl child, we are saving tigers. Why not to save the knee? So our focus for this CME is how to save the natural knee. Few facts. 1 out of 4 human beings have already or will develop osteoarthritis of the knee. About 1/3 of the patients scheduled for total knee replacement are potential candidates for an osteotomy. I am conservative, but 20% of the patients of all who are undergoing knee replacement are not satisfied with the result, mainly because of residual pain and stiffness. The fourth fact, which I have not written, I should not write, is because of this Ayushman card business, the rate of TKR, unindicated TKR, has increased to a tremendous extent. And probably we will be facing in next 10 years all the complications of TKR, because TKR are being done in a very young patients. So we should not behave like a gynecologist. We are orthopedic surgeons. Whoever has uterus should not have hysterectomy. So next to Ajit, and he is Professor Takanake. And they are going to come on 2nd and 3rd of December to Akola for the 360-degree HTO. So if you go into the pathophysiology of cartilage degeneration, why the cartilage degenerates? Yes, alignment. Second thing is instability. And third thing is incongruity. So these are the 3 important points why the cartilage degenerates. We are stressing on alignment, alignment and alignment. But only alignment doesn't give good result. You have to make the joint congruent, and you have to give stability to the joint post osteotomy. Then and then only the cartilage can regenerate. When we were in Japan, when we were interacting with Professor Teramoto, I gave them that you stress on alignment, incongruity and instability. Can you tell us what is number 1, what is number 2 and what is number 3? So he said, stability number 1, congruity number 2 and alignment number 3. Already alignment has been talked by the previous speaker, so I will not go into the details. What is joint stability? It is the state of a joint remaining or promptly returning to proper alignment through an equalization of forces, and this requires a very good synergy, coordination between bones, joint capsule return to proper alignment. This is joint stability. What is joint congruity? When a joint is congruent, the joint surfaces have maximum contact. Congruence and stability go hand in hand. This is how the joint is, Wedling gait. This is intra-op. That is why the patients have Wedling gait whenever they walk. This is ligamentous instability during weight bearing, during walking. This is how the patient walks. Many patients we see in our outpatient department walking with a lateral thrust. This is because of the laxity of the ligaments and incongruity of the ligaments, joint. Lateral thrust. Instability clinically. In mild osteoarthritis, the problem is of only malalignment. The medial and the lateral joint surfaces are in good contact simultaneously during weight bearing. However, whenever the osteoarthritis progresses, the medial meniscus subluxates medially, which we see in many MRI reports, the medial subluxation of the medial meniscus. The cartilage is degenerated. The medial femoral condyle subluxates medially. And there is, because of medial subluxation of the medial femoral condyle, there is detachment of the lateral femoral condyle from the lateral tibial condyle. So there is loss of congruity of the knee joint. This is the teeter effect, which is very well depicted by Ketan. The inner and the outer joint surfaces are not in contact simultaneously during weight bearing, and that is why the inner joint space, the inner cartilage, the medial cartilage wears off. This is what is happening whenever we walk. So always constantly there is a instability of the joint. In mild osteoarthritis, the joint surfaces are in good contact during weight bearing, and shifting of the load from medial to Fujisawa point or to the intercondylar eminence redistributes the load. But however, whenever there is instability of the joint, if you see, no, not working. Just I will. નથી કરતો છે મારી પાસે
આમાં ફેરત આવશે
નહીં તો છે મારી પાસે
એ નહીં ચાલે એ બધું એક જ સરખું જ
નથી ચાલતું
ના ચાલે કરશે
સારું થેન્ક યુ
આ બતાવો સી this arrow is
okay. So what happens is, if you see here, the mechanical axis is corrected, but still there is detachment of the lateral femoral condyle with the lateral tibial condyle. That is why there is loss of contact, stability to the joint. And that is why in such patients, the patients are not happy, even after doing an HTO. So what happens is there is persistent instability because of detachment. And that is why they have, even if you have corrected mechanically malalignment, they have some waddling gait. And because of that instability and incongruity, there is, because of this detachment, there is persistent instability and incongruity, and that is why they have pain, and they will curse our surgery. Medial tibial condyle and medial femoral condyle articulation contact also increases. So the shapes, both the opposite femur, the patient's natural femur will act as a template for the tibia, proximal tibia. So the correction, once you open up the wedge and check the stability, the opposite femur will act as a template, and the correction is automatic, is natural. You cannot control that. It is natural correction because of the opposite. So it is basically tailor-made, and it is not custom-made osteotomy. See, if you see, the osteotomy is opened keeping the medial joint contact till the lateral tibial condyle comes in contact with the femoral condyle. So you open up from the medial aspect. So there is shifting of the load line with simultaneous contact of both the joint surfaces during weight bearing. That is instability and congruity. And the load distribution is much, much better with stability. What happens in TCVO? What are the bony changes take place whenever we open up the osteotomy? The tibial condyles become, from the pagoda type deformity, they become concave at the intercondylar eminence. The medial femoral subluxation, which we have seen in intra-articular deformity, is reduced. And some external rotation, there is some external rotation of the tibia over the femur. So the medial femoral torsion is also reduced. And what are the ligamentous changes occur which give stability to the joint? The distance between the two condylar eminence, fibular head rotates little posterior, which makes the lateral collateral ligament tight. The tibial tuberosity is externally rotated and anteriorly translated, which decreases the patellofemoral pressure and improves the patellar tracking. It is an L-shaped osteotomy, and it is on the medial side of the patellar tendon. The patellar tendon is splitted into 1/4 and 1/3 and 2/3. And distal to 5 to 7 centimeters distal to the joint line. And the osteotomy is opened up with this. I will show you the steps in the subsequent slides. Once you are doing the osteotomy is opened up with a spreader till the lateral femoral condyle and the medial femoral condyle contacts the opposite femur, patient friendly. That is the main motto. This female, 60 years old, had medial compartment osteoarthritis with instability clinically. This is how the things are done. After the medial incision, a guide wire is passed from inferior border of the tibial tuberosity right up to the intercondylar eminence. It should be in the center of the intercondylar eminence as clearly seen. Once that is done, and first the vertical limb of the osteotomy is done, not osteotomizing the posterior cortex, vertical limb, and then the transverse limb, the horizontal limb. So it becomes an L-shaped osteotomy like this, and posterior cortex is first drilled by multiple drill holes posteriorly under C-arm control so that you don't damage and put You should keep the knee little flexed so you don't damage the neurovascular posteriorly. And you have to do this multiple drill holing of the posterior cortex under C-arm in various directions, like this direction, this direction, this direction, like this, so that you don't have to hammer much. You have to just connect those drilling holes posterior cortex so that damage to the neurovascular structure is prevented. So once the osteotomy is done, this was before opening the osteotomy. If you see, it is passing on the medial aspect. Once the osteotomy is opened up with a spreader, if you see, it is passing. I don't go too lateral. I just aim at the center, intercondylar eminence, center of the intercondylar eminence, or the lateral tibial spine maximum, but no overcorrection in majority cases. And if you see, it is aligned. This spreader position is also very important. This spreader should not be too anterior in lateral plane. It has to be parallel near to the posterior cortex so that you don't increase the slope. The slope has to be maintained to 0 to 2 degree in the lateral view. If you see this video, this was the instability, and after opening, the osteotomy has, after opening, it has stabilized. The joint has been stabilized. And then this plate designed by me is fixed. It's not available commercially. This was her post-op X-ray. This was his functional outcome at 6 months. This was after 1 year. I removed the plate, and this is her gait. No lateral thrust. This was again a 70-year-old female, just done in 2017. Once I came from Japan, she had, if you see, osteochondritis dissecans of the medial femoral condyle. They ended up with trouble, infection. So she was scared of total knee replacement. She told me that, do anything other than knee replacement. I don't want knee replacement. So I explained her that we can do this surgery. This was her scanogram. This was her post-op X-ray. And this is her functional outcome at the end of 6 months. This patient is the father of a doctor. He is 58, 59 years old, and no lateral thrust, no pain of the analgesics. This is his gait after 1 year. This female, 48 years old, had a persistent knee pain with medial instability. And this was her scanogram. This was her post-op X-ray. And at 6 months follow-up, she did Garba this year at the end of 6 months because of the Navratri festival recently. And she's happy. This female, 72 years old, had a medial compartment osteoarthritis varus with medial instability. This was, she's 72 years old. This is her post-op X-ray, and at 3 months follow-up, she's happy, off the analgesics, walking, and still undergoing physiotherapy because it is 3 months follow-up. So the highest stage operated by me is 79, my mother, who has undergone TCVO. On one side, it's a controlled side in her case. One side is TCVO, one side is total knee. This slide is presented to me by Professor Koshino, late Professor Koshino, because he expired, I think, in 2020. He was doing a lateral close wedge osteotomy, extensive soft tissue release. And he used to put plate on both the sides, medial and lateral aspect. and he used to insert once the fracture or osteotomy is united. It is a fashion and dictum. Again, he used to open up the joint, release, again a soft tissue release. And at that time, he documented that the cartilage regenerates. Though the cartilage, which originally is hyaline cartilage, this is a fibrocartilage, still the quality of the cartilage is good and the patient remains pain-free for a long time. This is one of my patients, 72 years old, done in 2019, and this is his testimonial. Voice.
હું રાજેન્દ્ર મહેતા વડોદરા કોટામાં રહું છું. મેં 2019માં ડિસેમ્બરમાં સમીરભાઈને ત્યાં ડૉક્ટર સમીર શાહને ત્યાં વિનાયક હોસ્પિટલમાં ડાબા પગનું ની સર્જરી કરાવી હતી. જાપાનીઝ ટેકનોલોજી રેક્ટિફિકેશન ઓફ ની. તો મને અત્યારે 2019થી લઈને આજે 2023 4 વર્ષે કોઈ તકલીફ છે નહીં ને મને સંપૂર્ણ હું ફિટ છું. પહેલાં 2019 પહેલાં હું અડધો કિલોમીટર બી ચાલી શકતો નથી. અડધો કિલોમીટર ચાલતા પહેલાં મારે 2 વાર બેસીને ચાલવું પડે. અત્યારે હું 3-4 કિલોમીટર ચાલી શકું છું અને મને કોઈ સાંધામાં દુખાવો થતો નથી. આ મારી એ છે. હું એક્સરસાઇઝ બી પૂરી કરી શકું છું તથા પન્નઠી વાળીને પણ હું બેસી શકું છું. આરામથી હું યોગાસનને બધું કરી શકું પન્નઠી વાળીને અને મને ઘણી જ રાહત છે.
Thank you very much.
Thank you, Dr. Samir Shah, sir, for wonderful lecture. Now I would like to request Dr. Ketan Thakar, sir, to felicitate Dr. Samir Shah, sir. Now I would like to request Dr. D.P. Thodakia, sir, to felicitate Dr. Avinash Maru, sir. So here we are taking 5 to 10 minutes of discussion. So if you have any questions, then you can ask Dr. Dinesh Thakkar, sir, Dr. Samir Shah, sir, regarding these osteotomies. After that, we'll start with the Dr. Sanjai Rastogi, sir's lecture.
Thakkar sahib. Dinesh sir, I have a question. We say weight bearing axis should pass through Fujisawa point. Then why not the planning in standing? Why not?
If we do in a standing, there is always laxity of few millimeters. So if we take X-ray, both weight bearing and non-weight bearing, there is a difference of, here I have shown that 3 degree. If I plan on the weight bearing, and then after the weight bearing force will be on the lateral compartment. So it will not get compressed. Medial compartment, after HTO, if we have done perfect job and the weight bearing line has been shifted, then if we put a weight on limb, the force will be on the lateral side. So it will not reduce the medial joint space. It will be overcorrection. I have faced in so many patients. That is always end up with the overcorrection. That's why I started to take in the one X-ray I will show in the later lecture, afternoon lecture, that there is a difference of weight bearing and non-weight bearing more than 10 degree.
So that is where the JLCA comes in the action, joint line conversion axis, if I am not wrong, that medial are contracted, most of the cases MCOA, and lateral are lax. And that is what we have to subtract. I am planning, I and I probably sir is planning, and Chintan bhai and Kaushal are planning. We plan through a standing X-ray, and we subtract the soft tissue varus. Varus is due to either the femur or the tissue or tibia. And we are doing osteotomy tibia. We are not touching the soft tissue. So we will subtract the soft tissue varus.
No, but in that case, see, Anand Joshi had his own osteotomy done by Dr. Pele. He had a frame, and then he tightened the lateral ligament by putting a compression device in the frame. It was way back, before 20 years, if I'm not mistaken. So he tightened the lateral ligament, and then this is what I say, by frame and everything, and then do an osteotomy.
Soft tissue, I would, if we are doing HTO, sir, the axis we are thinking. So what sir is saying is 2 degree to 6 degree. That is 180 is a straight limb, and we are aiming 182 to 186 degree valgus. So when ultimately while walking, the axis is going through the lateral compartment, and the soft tissue, that is LCL, we say lateral ligament complex, that is going to get over a period new alignment, because they have got a new tibia and new fibula at place, so they will get contracted.
So what I would request you is that you take your X-rays, varus, all X-rays, and let us see what the results are. Because when you...
It will not get contracted. See what Kaushal said, I think Kaushal, no? Kuldeep said, it will not contract the lateral collateral ligament, but it will compensate the laxity of lateral collateral ligament. As such, ACL laxity, we decrease the posterior tibial slope. That is also, we are not tightening the ACL. We are compensating anti-accruciate ligament. It doesn't happen anything to the lateral collateral ligament. But there is no varus force on weight bearing. After see how, unless with that Alizaro frame, even Dr. Milin has stated that it doesn't work, whether we cut the fibula and then bring the fibula downwards. It's not working properly. Huh? It's not working. That is accepted by Milind Chaudhary. That was accepted by Milind Chaudhary.
Sir, the problem, I don't know, how are you planning your mechanical alignment, but are you considering joint line convergence angle when you are planning for your osteotomy? Because if we are considering joint line convergence angle, then whatever mechanical alignment, like if there is a 12 degree of varus and the joint line convergence angle is 2 degree. So the 10 degree is the bony varus and 2 degree is the joint incongruity. So if we then the problem that you faced in your initial years, that you were overcorrecting, that was maybe because the joint was flexible. So it was patient is tending the medial, because the axis is medially, so compressing medial and the lateral tissue is getting distracted. So there is a method in which like 0 to 2 degree is the normal joint line 0 to 2 or 1. So first, after we collect the full correction, like that is 15 degree. After that, we have to deduct the normal, that is 1 or 2. So 15 minus 2. And then there are studies that after HTO, if the joint line convergence angle is 6 degree, then after HTO, there is a tightening of the medial structure. So in those cases, even in supine position also, your correction would be higher. Because the MCL is
contracted, so on weight bearing, there will be no opening of medial joint space. See, MCL is already contracted. You are correcting soft tissue with the bone. No, soft tissue I don't touch. But if MCL is contracted, even in the post-operative full-length weight-bearing X-ray, joint space will be reduced only. Even in the post-operative, that is contracted. But we have shifted the weight-bearing force on the lateral compartment, so patients are happy, even though joint space has been reduced. You understand?
Yeah, I am understanding, but right, my question is how will the patient's scanogram would be different if the MCL is contracted in standing and supine? Because the MCL will not let the tibia move in the neutral alignment, even if the patient is sleeping, because MCL is holding it in that position.
See, there is a reduction of medial joint space by 2 reasons. One is because of both cartilage loss and MCL contractions, right? Another patients in which the MCL is not contracted, but the cartilage has been lost. So in that particular, where MCL is not contracted and cartilage has been lost, there will be a dynamic varus. So on weight bearing, there is a more varus, and in non-weight bearing, there is a less varus. But if MCL is contracted and cartilage has also been lost, then there will be no change JLCA, right? That is the solution. That is why I take lying down. If it is contracted, it will not open. And if it is not contracted, it will open. So after surgery, if MCL is not contracted, it will open. So I have to do perfect on lying down. And on table, I take a reference line, not proximal tibial line, understand? I take reference of lower femoral lines. That will take care of JLCA also, right? Another, please. Yes.
Sir, I want opinion of the senior people sitting here that HTO who come after 7 to 10 years afterward, I find that they come with varus. The varus appears again. So I don't know what to do at that time. And so it's, can someone throw more light on this?
In which particular, when we were doing close wedge osteotomy, in open wedge with medial fixation, we have to confirm after surgery with full weight bearing, either at the end of 6 months or either at the end of 6 weeks, whatever the convenient time. Post-operative full length X-ray is most important. And in which most of the, I have come across many high tibial osteotomy open wedge and patients are not happy. They come to me and I take full length X-ray and there is under correction. See, I don't explain to the patient that why you have failed, because it doesn't create good impression. But that is the first thing what we have to confirm, whether we have achieved proper correction or not. And once we have achieved proper correction with a medial fixation, suppose it is in the center or it is in the, at the Fujisawa point, then there are very few chances of in progressing varus, because there is a unless you remove the implant. If you have removed the implant, and there is possibility that it will be go again in the varus. Because medial side, I have seen that. So if we keep the implant inside, it does not allow the collapse, because osteoporosis is an ongoing process for all when age increases. So there will be some microfractures in the proximal tibia later on when our age increases. So if we remove the implant, there are chances that it will collapse gradually on the medial side. Particularly, it happens more with the external fixator. It happens more with the external fixator. Even Mangal Pariyar had admitted that he has faced this, that there is again varus. And there must be collapse on the medial side also, medial tibial condyle also, and medial femoral condyle also. So gradually it goes into the varus, because main reason is osteoporosis.
Recently, I had one patient, TKR on one side and this HTO. She was very happy with the HTO side. She could do everything what she wanted to. And now when she came to me after almost 10 years, so she was unhappy with the HTO. TKR was still working fine. So that set me thinking that where am I going wrong? So if that's why I wanted the opinion of the house.
I give the introduction of this Dr. Manoj Kumar, who is from Delhi, and he traveled here for knee preservation. Yeah. Please give your introduction.
Yeah. Okay. I am Dr. Manoj Kumar. I was professor of orthopedics at Maulana Azad Medical College. I retired 2 years ago, and the Ministry of Ayush has a new initiative of starting integrative orthopedics and sports injury at their new center at All India Institute of Ayurveda in Delhi. So I am working on that project, primarily on joint preservation, and that's what it brings me here, that I am here. HTO, I have long interest in joint preservation. Thank you.
I have started HTO since 5 years, and now I'm planning on weight-bearing X-rays. Then recently we came across that single stance X-ray should be done, full-length X-ray. Now you are telling that non-weight-bearing X-ray. So it's still confusing for me. And particularly I think all of us must be confused. So you can just clarify.
See, single length stance X-ray is okay. What I have that Chintan and Avri has said that on weight bearing and non-weight bearing, if it is contracted medial collateral ligament. So if we are planning for the open wedge, and I have done around 40-50 open wedge also, but for that, if we are opening, because MCL is intact, the superficial part of MCL is still, it is attached much lower on the posterior side of the proximal tibia. So if we open, then I have observed that joint space, medial joint space reduces in open wedge. When we open, MCL will, and it is attached at the lower end of femur. So if we open, the medial condyle goes near the femur. So that what happens, for this, I suggest you, not written in the book, but I suggest you to make a template which I have shown you. On that template, check on the table. Plan your long axis of tibia, where you want to bring the long axis of tibia. Check on the table, matching with the lower femoral line, because in open wedge it reduces, in closed wedge it does not reduces medial joint space, because there is no tightening of medial collateral ligament. So this issue comes when you are doing open wedge. And in open wedge, for every, except external fixator, for every HTO surgeons, I recommend that per operative perfect with patella in the center, take per operative X-ray, make a template, put on the view box, we all have a view box in our OT, and then measure where you want to bring the long axis of tibia. Bring near to that, and then you fix finally. After temporary fixation, you can take X-ray per operative, measure the angle perfectly, and then if you are satisfied, then fix it with the other screws. That is the only solution of your query.
We are running bit of late, so rest of the discussion we'll do at the...
Just quick explaining.
Oh.
Just a quick explanation to your query. See, basically, osteoarthritis, when the patient is having mild osteoarthritis, they're never ready for surgery. By and large, they remain conservative. They manage by conservative line of management. But when osteoarthritis progresses to moderate to severe in few patients, because you are correcting only the alignment, but you are not giving stability and congruity to the joint. So for an intra-articular deformities, you require an intra-articular surgery for correcting the intra-articular deformities. Then and then only the patients will have a stable, congruent joint. If you observe your post-op X-rays of bicondylar tibia with a stable fixation, but with a step, they are happy. But if they have laxity in the joint post-fixation, even if your joint, if you manage the congruent of the step, they are unhappy. That is why stability of the joint is one of the most important aspects to give good result to an arthritic knee.
Now, very interesting part, very interesting and very informative part is pre-operative planning exercises, and that will be conducted by Dr. Sanjai Rastogi. And I will thank you in front of you all that even Sanjai Rastogi, doctor, has recovered from a very bad chikungunya just before 2 days. He was on the tablet and still he arrived. Thank you for that, that he has taken a lot of, very informative. I was impressed first time when I visited Kanpur and he called me by pre-operative planning exercise that clears all the concepts about high tibial osteotomy. It will be very interesting. Please participate in this exercise. Thank you. Do it yourself, yes.
Good afternoon. I would once again thank Dr. Dinesh Bhai for giving me this opportunity once again. He is one who is so much interested in propagating knee preservation, and that it is always a pleasure to come and be with him. All of you have 3 sheets and few pens and few scales and a goniometer. Remember, there are 3 exercises. We will start with the first, and please write your name. At the end of it, once we finish the last lecture, there is a feedback form. I'd appreciate if you fill this and send it to us again. वहाँ से मंगवा दीजिए. हाँ, सब लोग जाएंगे तो. And before everybody is getting his sheets, I must tell you, the credit of this exercise goes to Dr. Stobley. He encouraged me to work on it. And the other person is Sabaguchi, who modified and helped me develop this. Unfortunately, AO does not have a osteotomy course as per the evidence. So we have to work around by your own methods. So we are working on exercise 1, and you have written your name. So there are 3 domains of learning, and they are knowledge, attitude, and skills. So till now we have learned the corrected knowledge on HTO, which will help us change our attitude. And now we are into the 3rd domain of learning. We will learn these skills by doing this exercise, and then there is a sawbone demonstration which will help you. So we all know that this is the Fujisawa point on the lateral side at the descent of the lateral tibial slope where it comes. This is the Fujisawa point. And if the total cartilage is lost, the weight bearing line should pass from here. The hinge point is just proximal to the proximal tibiofibular joint, right up to the lateral column. Now starting with the exercise, first exercise, sheet number 1, mechanical axis deviation. And for this, there is a plastic sheet. Yes. With the help of this sheet, please mark the center of the hip joint. Unfortunately, I don't have table instructors, so yes. But once you have done this, just raise your hands, just say, we proceed, so that, and try to take everybody along with you. Then you mark 2 most convex points on the femoral condyle, and these are the points. And now we draw a connecting line with these 2 points. This is the distal femoral joint line. Then we draw two dotted perpendicular line flushing the lower end of the femur, medial and lateral, onto the knee joint, femoral condyle line. These are the dotted lines. And then we mark the center of this. This is the center of the femoral condyle. Then we mark 2 points on the concave aspect of the tibial plateau, subchondral line. It is not the joint line, it is the subchondral line. Then we draw a connecting line. This is the upper tibial joint line. Like we did in femur, we draw two dotted perpendicular lines on the upper tibial joint line, flushing the tibial condyle. And this will give the width of the tibial condyle, and we mark the center of the tibial condyle in between the dotted lines at the upper end of the tibia. Then we mark 2 points at the either end of the ankle plafond, which is lower down here. Then we draw a connecting line, which is the distal joint line. Then we draw two dotted perpendicular line on the distal tibial joint line, flushing the talus. So that will give us the center of the plafond or the talus. Now we connect center of the hip to the center of the ankle joint. Now this red line, which you will be marking with the red pen, will tell us whether there is any deviation of the mechanical axis or not. If we are on the right page, exercise 1, it is passing just medial to the joint line. That means it is normal. So, if there are any clarifications at this point of time, then we can take it now. Because if this has been done correctly, we have decided that there is no deformity in this diagram, and Dr. Navin Bhai says, you are right, there is no deformity. Then we go to the exercise 2. This is mechanical axis deviation plus malalignment test. That means what is the change in the alignment. And this is, we mark the center of the hip. I'll go a little fast because you have already done it. We mark two most convex points on the femoral condyle. We draw a connecting line at the distal femoral joint line. We draw two dotted perpendicular lines on the femoral joint line, flushing the femoral condyle. And then we mark the center of the femoral condyle. Then we mark 2 points on the concave aspect of the tibial plateau, subchondral line. Draw a connecting line. This is the upper tibial joint line. We draw two dotted perpendicular line on the upper tibial joint line flushing the tibial condyle. Right. Everybody has marked 2 points on the concave aspect of the tibial plateau subchondral line. And this is the upper tibial joint line. And then we draw two dotted perpendicular line at the upper end of the tibia, flushing the tibial condyle. These are the lines. And then we mark the center of the tibial condyle. Then ankle profound line. Then we draw a connecting line, which is the distal tibial joint line. These are the lines. And then we draw two dotted perpendicular line on the distal tibial joint line, flushing the talus. So the width of the talus is taken as the representation of a plafond, and we mark the center of this tibial plafond. Navin bhai is working at the ram speed. Connect center of the hip to the center of the ankle. Now once you draw this with the red pen, you will see that this is going more than 15 centimeters from the joint line. That means this patient has a varus deformity. And Dr. Dror Pele and others have taught us that we have to correct the deformity where it exists. So till now we only come to know that there is a varus deformity. Where it is, tibia or femur, this we don't know. Now we connect the center of the hip to the center of the femoral condyle. Black line. Center of the tibial condyle and the ankle joint. Lower down in the leg. And then we measure the mechanical lateral distal femoral angle, medial proximal tibial angle, and lateral distal tibial angle. Now all of you will tell me what is the angle. You have drawn it, you have a protractor to measure it, and please tell me what are your findings are. So what are the findings? What is the medial proximal tibial angle, and what is the mechanical lateral distal femoral angle? This is the femoral line. This is the joint line. This is the lateral side. This is the distal end of the. Everybody is with me? Yeah. This is the femoral joint line. Yes? This is the mechanical axis of the femur. So small m for mechanical, capital L is for lateral. आप मुझे दीजिए. Capital L is for lateral, D is for distal, F for femur, and A is for angle. That means this is the angle. This is the angle. And as Dr. So the center of the femoral condyle, joint line of the distal femur. So this is the lateral angle, right? Is it clear? Now what is the angle? 95. What should be the normal? Between 85 to 90. 94, 95 is the same. Right? So that means there is varus deformity because of the increase in the mechanical lateral distal femoral angle, which is more than 90, which is 94 or 95. Is it clear? Now when we go further, the mechanical axis and the anatomical axis of tibia is the same. So medial proximal tibial angle is the same. So this is the line. This is the tibial joint line. And this is the medial proximal tibial angle, which is how much? Anybody else? Anybody else? 85 I have heard. The way I calculated was it was 84, but if you accept that it is 84, just for the proceeding further, this varus deformity is because of deformity at the upper end of the tibia and lower end of the femur both. Right? Having understood this, if you want to correct this varus deformity, what will you have to do? Correction at both. The practical solution could be, I'm not suggesting, but could be correcting the lower end of the femur, and because there's only 1 degree on the tibia, by doing one surgery, you will give a reasonable alignment. Now, that means the first exercise was normal knee. This second exercise is for varus deformity because of femur and tibia. And now we proceed further. And this is exercise 3. Please write your names. Now we mark the center of the hip joint, again with the plastic sheet. We mark 2 most convex points on the femoral condyle. You have done it before. If you say yes, I proceed. Then we draw a connecting line. This is the distal femoral joint line. Then we draw 2 dotted perpendicular lines on the femoral joint line, brushing the femoral condyle. Then we mark the center of the femoral condyle. Everybody is at the right speed, right page. Then we mark 2 points on the concave aspect of the tibial plateau subchondral line. I'll repeat, this is not the joint line, this is the subchondral line. These are the points. Then we draw a connected line. This is the upper tibial joint line. Then we draw two dotted perpendicular lines on the upper tibial joint line, finishing the tibial condyle. Then we mark the center of the tibial condyle. Then we mark 2 points at the either end of the ankle plafond, lower down here. Then we draw a connecting line. This is the distal tibial joint line. Then we draw two dotted perpendicular line on the distal tibial joint line, finishing the talus. This is the talus, and we have drawn these dotted lines onto the ankle joint, and then we mark the center of the plafond. Now with the red pen, you will mark center of the hip to the center of the ankle, and for a second you can go to the exercise 2 and compare the two lines which were drawn in red in exercise 2 and exercise 3. Now both these lines indicate that there is a varus deformity. Am I right? But what is the difference? To know that we connect the center of the hip to the center of the femoral condyle. And then we connect the center of the tibial condyle to the center of the ankle joint. And then we measure number 1, mechanical lateral distal femoral angle, which is 85, and we know 85 to 90 is normal. So this patient has a varus deformity, but this varus deformity is originating at the lower end of the femur. Why not? Because it is 85. So it is normal. All of you are alert. Then we measure the medial proximal tibial angle, which is how much in exercise 3? Right? Now, how would you correct this? Exercise 2 had deformity both at femur and tibia. This has deformity only at tibia. So how would you correct? Doing only single osteotomy. And as in my lecture I said, 85% of the time, especially in Asians, the deformity is at the upper end of the tibia on the medial side. That is because of the tibia varus bone angle. It is congenitally into varus. So instead of, it is good to know all techniques, but it is also good to know the right technique for the right patient and try to do first one which is more common. So if you have 100 cases, 85 patients will require open wedge osteotomy, upper end of the tibia. It's a just guesswork. Now, how to correct this? You have a green pen. With that, the red was deformed. The green is what you wanted to be happening. So you draw the desired weight-bearing line after open wedge high tibial osteotomy, which is number 1, from the hip joint center to the Fujisawa point, and you extend it distally. Green line. Right? So you have changed the pen. You have drawn the futuristic joint line, weight-bearing line. Now, where is the hinge point? We have just learned the hinge point is just this is the lateral side. This is the medial side. Everybody is with me. This is the tibial spine. This is the lateral slope. And where this lateral slope meets the joint line, this is the Fujisawa point. Everybody clear? This is the proximal tibiofibular joint, upper end of the tibia. So the hinge point or the cora is quite close to the joint. And so this is the lateral hinge, and this is the piece of bone from where your osteotomy should exit. It should not enter the joint, tibiofibular joint, because it will give pain. It should not extend to the knee joint because it will lead to instability and pain. It should not fall too short, otherwise there will be a fracture into the joint or lower down. So it has to be close to the lateral cortex. And how do you do it? When you pass this wire, see this under C-arm in 30-degree internal rotation, and your wire should be right up to the lateral cortex. I'm sure you will recall seeing this picture in the first lecture. I can show you this little later again. If you are comfortable, then it's fine. So this is the lateral tibial spine, and where it ends, it is the Fujisawa point. This is the tibiofibular joint, and point just proximal to it is the lateral hinge joint. And this is A. Now draw a connecting line between the hinge and the ankle joint. Because once you do the osteotomy here and correct the deformity, how much correction it will require to come to the futuristic joint line till this point touches the line 1, right? So you rotate the line 2 onto the line 1, and then you draw a line from hinge point to the lower point, and this is the angle which is alpha, and this is the amount of correction which you will need to do by opening the osteotomy this much. Now, you have measured the alpha angle, right? But once I showed the technique, I said the osteotomy should start at a point where the convex or the concave point meets here, so that when you open the osteotomy, this line and this line will be same, right? So there is no mismatch in the width of the upper end of the tibia at the osteotomy site. Is it clear? Pardon me? We are not in, we just measure this and we transfer this here. And we measure this height from B to C. So this is the base, this is the amount of wedge which will require to be opened. So this height is H. To see it clearly, this is the hinge. This was somewhere the osteotomy line. When you open it, opens equally. This point and this point will come here. And this is the B and C. B and C is the height of the wedge, right? The last one. So, if there are any questions, वापस कर दीजिए, जोड़ दीजिए. If there are any questions, clarifications, I'll be too happy to answer that. Say that. हाँ, आप क्या this is the angle alpha, center of the ankle. This is the futuristic joint line, this is the hinge point. So from here, center of the ankle, futuristic joint line, and alpha. This is the angle. Now you measure this angle and just remember that angle. How much to open, where to open? The osteotomy will be at the junction of the convex on the concave part. For a second, all of you can touch your medial end of the knee joint and try to palpate a depression between the convex and the concave. This is here. It is so simple. And this gives 4 centimeters, 4 to 6 centimeters of bone proximal to it. And this is the difference between the screw holes A, B, C, and D. So that means when it is 4 centimeters or more, all the 4 locking head screws will have purchase in the bone. Right? And then you measure the height B and C, which is H. B and C, H. This is the amount of correction which you can measure with a caliper. इनसे कहिए सब लोग काम कर रहे हैं, फोटो खींचते हैं सबकी. So if there is any clarification, लोग इतनी मेहनत से पढ़ रहे हैं, फोटो तो 2-4 खींच दो यार इनकी. I find this picture which the photographer is taking now as the most important testimony of my taking this exercise.
Many people have 12, many people have 15, some has 20, some has 18.
That is
Important is how to do
because, and I am so very grateful to all of you who have applied themselves so diligently at the end of the day, and this is my reward. Believe me, this is my reward. I take it as a passion to conserve knee joint, where Dr. Samir will teach me TCVO at Akola. Of course, so that his boss and Dr. Milind, Dr. Ajit will teach us. Because unless we know these tools, we cannot tell our colleagues that they should not be doing joint replacement. And one thing which I take this time because Dr. Dinesh told me there is some time. If we give right advice at the right time, and all of us do that, there is no reason why patients should not follow the advice. Somebody told me in Ayush, you can't do more than 3 joints in one center or something. In Korea, there is a board who certifies that knee replacement is the only option for this knee joint. Only then a knee replacement could be done. What I believe is we must practice and preach this. And this is my passion which brings me to Rajkot, and your working so hard is my reward. So, Dr. Dinesh Bhai, and see the dedication of Dr. Dinesh Thakkar turn around. He wants everybody to learn the right way. If you fill up the feedback form, and there is a survey on SurveyMonkey which I have sent the link to you, I request you to complete this survey, fill this form and submit to me. The purpose is that whenever I do exercise somewhere else, I coming there on 13th, you can come and be table instructor. Because you have learned this art, so this will help my task easy to explain to your colleagues. And teaching is the best method of learning. So if you teach, you learn. Dr. Dinesh Bhai, any questions? Any questions?
If it's okay with you, can I make a small announcement?
You are the boss.
It's a pleasure for me to invite all of you to this IOACon 2023 at Lucknow, and we have been privileged to host the Dolakia CME. Gujarat Orthopedic Association is conducting the CME, and Navin Bhai is the convener, and he's come up with a brilliant idea, and it's a very different Atke CME, where we have 60 plus 5-minute lectures on an idea that has changed my practice, an idea or technique which has changed my practice. There are 60 people contributing. They are all Durandars of Rajkot orthopedic practice, and it will be a pleasure to hear it. We won't know where the time will go, and all singularly because of.
What is the date?
The theme, the date is 14th December,
So
14th
it serves
December.
my purpose. You come on 13th.
13th for workshop.
For the workshop. And if you really want to be a table instructor, on 12th evening, I would conduct a interaction for table instructor to learn. So you will know it better. And then help me this. Of course, I can only thank you. I have nothing else to offer.
That is the best offering.
Yes. Because,
so
but
the theme,
you will be as happy as I am.
yeah. So theme is innovation, technique, idea, or a case, or a paper, which has changed my practice, may change your practice. So there are 50 presentations from all over India, where the new techniques, they have done something new, or they have adopted the technique and they found it and modified it. So these are all unique presentations. So those who are coming, already registered, please remain present 9 to 5. It will be privilege for Gujarat Orthopedic Association for your presence. Thank you.
And you can write to me for being table instructors. I don't know, is there a group running?
We'll get it. We'll circulate it. We'll circulate.
So, no, for this, there's a group. If I am there, my number is there. You can write to me that you are coming on 13th and you are happy to be. Right. Thank you so very much.
I think if I'm not mistaken, there are a couple of things which, with the permission of Dr. Navin Bhai, I would like to inform that this CME je chhe, ema samanya rite, if I'm not mistaken, you are supposed to register for the conference as well as for the CME. Jare ama kai kevu che ke you can do only the CME evu kai che sahib? We have to do CME and the conference, but the CME is 1 day prior, and if I'm not mistaken, once again, there are about already 900 participants. More than 900 participants. So it will be a great privilege. And as Dr. Rao sir was telling, there are genuinely big names coming up. I mean, Dr. Navin Bhai and Dr. Dinesh Bhai are there. But at the same time, Dr. S.M. Tuli sahib, Dr. Rajsekharan sahib, all these are participants in this event. So I am genuinely wishing and requesting all of you, jetla loko avi shako etlo saru, because you are in luck now. You really have to take this chance, because non-veg vada ne chicken પણ મળશે અને જે તમારા wife છે એમને પણ પેલું chicken curry પણ મળશે. So I am very sure it's going to be helpful in every which way. You will be happy, your wife will be happy. Chicken is everywhere. So take that chance. And Lucknow is like a great visiting place as a tourist place. એટલે હું જાણું જ છું કે મોટા ભાગના કોન્ફરન્સમાં આટા જ મારતા હોય છે. So that also will be, that wish will be fulfilled. Thank you so much.
Last year,
You have to register separately?
You have to register for CME, yeah.
Separately?
Separately. And last year, it was around 2,000 present continuously from 9 to 5. And the CME, where there is no parallel hall, only single hall. So you can attend fully. You do not have to run any other halls. Only single hall, CME 9 to 5.
Thank you, Dr. Rastogi sir, for wonderful talk. Now I would like to request Dr. Nirbhay Shah sir for his talk on the uni-condylar knee arthroplasty. This pointer and this for slide change.
Slide change શું છે? Forward.
આ રીતે સર. Forward. હા, yes.
Forward, backward.
Right. Pointer છે.
Perfect. Now, where are you? આગળ રાખી દે ને ભાઈ. What difference does it? Thank you.
The industry, without our being conscious of the fact, pushes us in a different direction. And this is what is happening. That means uni-condylar is taking as a joint.
It is.
With folding hands.
No, I do everything, sir. That's what I'm trying to tell.
passion.
I am the villain today.
No.
Every movie needs everyone, no? Gabbar Singh bhi chahiye na, sir.
But I very strongly believe it can't be knee preservation.
भारी सबका है, sir.
So if we
कोई ना पग भारे से जोई लेजो.
understand this, I'm not saying do, don't do, when to do, when not to do. Don't put it in.
अगर तो कब का मर गया बेचारा.
And there's one more thing. Things which are complementary can take you for a ride. Don't think something is complementary.
Nothing is complimentary. There is no free lunch. They are not.
You are being taken for a ride.
You are addressing different issues here.
Right.
Sir, can I start?
Please.
Thank you, sir. Thank you. मेरे पास है. Thank you. I have everything. You see, that's what I want to tell you. See, this is what I am. I am not an arthroplasty surgeon. I am not an arthroscopic surgeon. I am not a trauma surgeon. I am a joint surgeon. I am ready to do anything which is good for my patient and what is indicated. And that's what I am going to talk in my debate. This is not my issue here. This is that I am going to introduce partial knee replacement to you. This surgery has been in market since 45 years. So it doesn't need any introduction. Many of us are doing it since many years. I just want for the youngsters to have something in their mind as an alternative when it is indicated. And when you feel that you need to do a uni-compartment knee replacement, what are the things that you should take care of? આ ચાલતું નથી. આ સ્લાઇડ જ નથી ચાલતી. સ્લાઇડ જ નથી ચાલતી. જે ચલાવવું છે નથી ચાલતું. That's good. Someone can stay. Keep in mind, patient, this is how you do it, how you select the patient. It's okay. How you select the patient, how you do it, just a basic introduction. You have got internet, you have got companies which are going to tell you, will give you literature to read, steps to do. That is not my aim today. But if you are doing it and what I am doing it, what you need to do when you are doing that surgery, what are the important relevant points that you should take care while doing a partial knee replacement. That is my aim today. So, thank you. So it's a selective replacement, either the medial or the lateral compartment. But lateral compartment has not been very successful, so 99% times you are doing a medial compartment replacement. Same thing has happened to HTO. It's very rare that you do something not for the medial compartment, fine? Everything is focused to that. And most commonly medial, and I have done only medial, fine? The company does say that they have a lateral compartment replacement, there are minor changes, but we have never done it. So it is not new, as I said again. It was in 1974 that, maybe in 69, St. George and Marmor started in US in 72. But they were just very initial beginning, role into this. The idea was there. But a very professional, John Goodfellow, the orthopedic surgeon, and John O'Connor, the engineer, they designed this mobile bearing with a completely spherical femoral implant. They took a metal sphere, cut out that implant from that sphere so that it had a 10 to 20 degrees of play. Even a minor mistake they could cover because they didn't have many other technical advance of the mild varus deformity or mild varus position of the tibia and the knee anatomically and physiologically. But commonly it was seen that in about 95% of the cases, it was the anteromedial part of the joint which started getting eroded. Over a period of time, the ACL got lax because of that collapse of the medial compartment. Once the ACL got lax physiologically, or even it got degenerated and torn, it started migrating to the patellofemoral and the lateral compartment. So you had around 5 to 10 years of time in between where if you could catch the patient, if it comes to you, you can do either an HTO. It was till now suggested that high tibial osteotomies are good in mild to moderate, and from moderate to severe medial compartment osteoarthritis, uni-compartment knee replacement gives a good result. The difference between HTO and uni is that on treating the anatomical problem, or you anatomically correct the problem where it is located, you are not bypassing the problem as you do in a high tibial osteotomy. That is what is said in favor of a uni. Now it's controversial. Everyone says, okay, this is better, that is better. That is not my aim today. And this understanding of the natural history of the osteoarthritic knee that initiated the thought about a replacement or a partial knee replacement in the knee. Selection criteria, as I said again, the indications are very important, selection of the patient is very important, and only if you do this will your partial knee be successful. Otherwise, you're going to land into trouble. So, it has to be a selective medial compartment involvement. Now you have a lot of MRI and other things which can help you. Please don't be afraid of taking an MRI. If you are in doubt whether you should do a partial knee or a total knee, please take an MRI and confirm. Okay, it doesn't make any difference to the patient. Fine. And the patellofemoral and lateral compartment should be relatively free of osteoarthritic changes. Clinically, there should be a varus deformity, only medial joint line tenderness, and no patellofemoral or lateral joint line pain. Then over a period of time, you start stretching indications as you go senior, as you get more experienced. And if you are not doing anything else, if you are an arthroplasty surgeon then, and the joint has to be lax. There has to be an increased play in the valgus stress, but it has to be correctable up to neutral and not beyond. Please understand, you come back to neutral. It has to be correctable to neutral and not beyond. That will help you to understand that there is no subluxation, the ACL is okay, and there is no increased pressure on the lateral compartment. You can take a valgus stress knee on an X-ray on that. And when in doubt, go for an MRI. Don't take a risk in today's practice scenario. And the lateral X-ray should show that it has a good patellofemoral joint. Mild medial patellofemoral arthritis is not a contraindication for a uni-compartment knee replacement. When not to do a UK, patient has a varus deformity, is not getting corrected up to neutral. If it is tight medial compartment, not getting corrected up to neutral, don't do a uni. If it is going beyond neutral, don't do a uni. Fine. Obesity is a partial contraindication, but we have done up to 115 kgs of weight, and in 10 years that this patient is normal, no problems. So that they say that, but if ACL is gone, particularly in mobile bearing uni replacements, torn ACL is a strong contraindication of doing a uni. Medial subluxation of the femur on the tibia is a strong contraindication of doing a uni. But age is no bar, weight is no bar. Patellofemoral joint, as I said, mild to moderate medial patellofemoral disturbances, and quality of bone is no bar. Osteoporosis, I will not do this, that I think that is not a question in this. So oldest in our list is 78 bearing tibia with a metal back or an all poly. And I personally prefer, I have all my unis I have done is mobile bearing. I was trained on that, and I started doing on that, and I never found a reason to change my routine, and I do only this. But there are lot designs and available, all poly or metal back, which also give very good results. It's up to you to decide what you want to do, how you are trained, and what you are happy with. So what we preferred mobile bearing. The advantages which I found that time, and also now I feel that I have a greater advantage, is the less wear rate. Mobile bearing has the biggest problem with unis till date was the increased wear. And they found lot of wear, and there were a lot of failures early in the uni compartment, and it gave it a very bad name. But mobile bearing has changed the scenario. The wear of body is less than 0.003 mm per year. So it gives a very good result. The highest, particularly in Oxford, that we are doing this 32 years of survival. The patient died after that. They did it at 60 years, patient died at 92, and she was still comfortable. Okay, so they have a survival of 32 years. They don't have anything beyond that. I have around 17 years of my follow-ups, and we have very good results. Now, this is for the basic beginners, not for seniors who are doing it, but this is for you to do. Particularly in mobile bearing, there is a great difference in the position of the knee. It is not like as if you are doing a TKR. This is a free hanging knee when you do this procedure on the table. So it's a free hanging knee. The flexion you should be able to get 120 degrees of flexion and complete extension on the table, because during the procedure you have to do both, and it should be easy without any force. The incision is starting from almost the upper part of the patellar surface, right up to the medial part of the tibial tuberosity. That is usually an incision. You may take a larger incision. No patient is going to say anything in the initial part of your practice. But then as you do more, your incisions do start getting smaller. But still, you should be able to see everything very clearly. You can create a mobile window because extension and flexion give you view on the different parts of the femur. Then, this is the view you usually get. You have to have a very good view of the ACL. My experience has been that because of that collapse, the ACL, I do a lot of arthroscopies. I have an ACL or the arthroscopy hook ready. And I always feel the ACL. You can use it with an artery or with a ACL legs when you see this. Once you do your trials, you'll find that the ACL has gone very taut. It's very tight and strong and straight, and that indicates that you have covered that collapse of the lack of cartilage, and the laxity of the MCL is covered, and that will prevent further damage to the lateral condyle. The patients are, sir, andar no sandho ghasai gyo, to pachi bar no sandho velo ghasai jai. No, if you correct that inner deformity, both intra-articular and the loss of cartilage, and the ligament laxity, the transfer from the medial to the lateral side of the osteoarthritis usually does not happen for many, many years. It may last maybe a lifetime for the patient. So that is what has to be understood. The pathology of the osteoarthritis has to be understood. Opening the joint, and if you are doing arthroscopy, I tell my fellows, khol ke rakha hai samne, why don't you see the anatomy of the ACL which is right there in front of you? Look at the ACL, look at the tibial attachment, because afternoon I am doing ACL reconstructions. If I don't, why not you see when you are opening the joint, when you are seeing the anatomy in front of you? I do repairs of ACLs, I do repairs of PCLs also, we do reconstructions also, and we do this also. So when you are doing a replacement, everything is in front of you. See the anatomy of the proximal part of ACL, distal part of ACL, proximal PCL. When you are doing removing the ACL, tame jare PCL kapo yani pehla PCL kya jai che tibia ma, just have a look at what it is going. And then once that is clear, we are not doing cadaveric after we do our PG, but this is what we are getting, live anatomy, understanding of anatomy of the knee joint. When you are opening, your medial epicondyle is right there in front of you. Why can't we see that MCL ke kya jai che, kya che? You are seeing the lateral part. Why can't you see the anatomy of the LCL and this? It's right there in front of you. We don't waste 5 minutes. We want to finish the surgery so fast. We don't give 5 minutes to understand what is there in front of us. So this is there in front of us. See, every patient that will do you learn. The patellofemoral joint is good, the lateral joint is good. There are osteophytes here. Don't miss those osteophytes here. ACL is sometimes pressed by those osteophytes, and because of those osteophytes, ACL goes away. See that groove here? That helps in a lot of other decisions that you are making. Your idea, the lateral condyle, how good it is. Do you expect anything to go wrong in the future? Make a note in your operative note that this is what I saw. Follow up, maybe that will help you to learn what you are doing, whether it was good or not, whether you have to learn something and do something else when you want to do this surgery. Then again, remove the osteophytes properly. But before, and take the size of the femur after you have removed the osteophytes. There are two benefits of removing the osteophytes. One, you are removing that tenting of the MCL. You'll get the proper joint space, osteophytes right up to the, and feel, put your finger in, tame patella, you can see that border of patella, remove the osteophytes from lower pole of patella if there is there. Feel whether you can feel the osteophytes, you can put your finger in. See the osteophytes on the superior edge, the PF joint, whether the lateral side has an osteophyte or not, medial osteophytes right from the top till the bottom. Remove them properly and then size your femur. Don't size before that. You'll get a wrong size. You'll put a larger femur instead of that. So take your femur, remove, and take this curved osteotome. Because of arthroscopy, I have this small osteotomes with me, which was benefit for me. But this is not costly. Please, you should have small osteotomes which are straight, curved. Keep them with you on the table. Tell your dealer to get them with them if you don't want to spend. I want this on your trolley when I do this. And they are very ready to help. So remove the osteophytes right from behind the MCL and right up to the top, and then size your femur. Number 2, then you decide, see this. This is very important. It's my habit to mark everything before I cut. Now, once you have done this, your vertical cut on the tibia, the tibial cut is the most important part in your mobile bearing this, because you are building up your entire process on your tibial plateau. Tibial plateau, once you cut, and the alignment of the tibial plateau, your basic alignment of all your future cuts is based on that tibial cut. So if that is wrong, everything will go wrong. Fine? This is tibia first surgery. This is flexion first surgery. You measure the flexion gap first, and then you do your extension gap based on that flexion gap. This is a mobile bearing. All mobile bearing, whether you do a TKR mobile bearing, you'll do the flexion gap first, and then only you do the extension gap, because your flexion gap has to be tight, otherwise your bearing will come out. So please understand, this is not like a routine arthroplasty surgery. You are doing a vertical cut. So your tibial biscuit, we call that a biscuit. The tibial biscuit has to have a vertical cut. It should be perfectly aligned. The basic idea is that the tibial line, you put your assistant, tell your assistant to put a finger on the ASIS. Then you see the tibial absolutely in the center of the tibia. Just have a vague idea of where it is going, and then take a cautery and mark your on the lateral edge of the medial femoral condyle. It has to be beyond that. And then take your cautery and just make a mark so that your vertical cut doesn't go. It has to be in the axis of the joint movement. It doesn't go medial or lateral. And that will make a difference in the result of your surgery. So this cautery line is very important. Then you put your tibial cutting guide. They have this clamp or the spacer, and then this is the cutting guide, and there is a C-clamp, but I'm not very happy with this. You still have to do a lot of eyeballing. I think this needs to be corrected in particularly this type of implant. Still you have to do a lot of eyeballing. You have to do plus minus 1 or 2 mm. And there are ways and means to do it. Only experience will teach you that. Don't depend on this. Abo khatarnak vastu che. You may cut a big, huge chunk of tibia and you are in big trouble. Cut less. Ochu kapaye to you can always cut more. If you cut more, you cannot come back. So you make a mistake on the tibia on cutting on the lesser thickness of the tibia. Make a mistake, make an error on the safer side. Cut less, you can always increase your cut. Don't cut more by mistake, you'll be in big, big trouble. So once this is done, see where it is. You think this is too big? Okay, there is a plus 2 mm available. There is a, instead of plus 2, you want to do plus 1. So you have the slot or the thicker plate is available to put on the cutting guide, where there is a cut. Want to do this or not. Please be very, naito you take a foot rule and see how much you are cutting. It should not be more than 3 mm. The tibial plateau on the medial edge, don't do it on the inner side. On the outer edge, it should not be more than 3 mm. Whatever happens, please do eyeballing. I don't mind that. But don't make the mistake of depending on this. It causes a lot of mistakes. That is my very big. Then you can do your perpendicular vertical cut. You can do your horizontal cut. Be very, very careful about the MCL in the horizontal cut. Put a spike or that. They have that jiggly wiggly saw, or jiggly wiggly retractor. You can use a simple spike also, but it should be between the tibial condyle and the MCL. Throughout, don't do without that. And be very careful of the MCL when you do this. Once this is out, you can see this. Now, this is the area. This is posterior, this is anterior. You see this? This is the eroded area. So this indicates, the anteromedial arthritis indicates that in this patient, the ACL was intact. Again, on an X-ray, on the lateral view, in a weight-bearing X-ray, the femur should be in touch with the tibia on the trial. Take the opposite side of the tibial triad, put it on the reverse, the under surface of the tibial biscuit, and measure what size of the tibial opposite side nu rakhvanu. But the tibial plate has to be of the opposite side so that you can measure the tibial biscuit. The upper surface is curved, you can't measure it. The lower surface is flat. You can measure your side easily by putting this on the, but because it is the reverse, you have to put the opposite side trial to see the size of your tibial biscuit. So please be very careful of that. Again, now you mark your intramedullary rod, you'll put the intramedullary rod. Now it has to be exact center of this and around 1 to 1.5 centimeters above that, depending on the size of the patient. Jo medial, the femoral condyle size is medium and above, go 1.5 centimeters. If it is extra small, small, go 1 centimeter. That means the patient is small. Keep that, a basic concept arakhan, wo vichar nahi karwano, you should have a clear idea of what I am doing. Then, put in the intermedullary rod. There are two sizes of rods available, small and large. Medium and above, put the long rod. Extra small, small, put the small rod. Then this is that spacer to decide your holes for the posterior cut. So this is your posterior cutting jig, which has to be pushed into that space, and this has to be connected with the intramedullary rod. Again, very confusing. Don't use your brain much. It's very important that this part has to be parallel to this. You can see from above, once it is parallel and equal, automatically there is a small flexible Y-shaped jig available which goes into both the holes. Once you are in exact alignment, don't hammer that jig, it has to go with your hand. Easily it should go in, that means you are in perfect alignment. Then don't force, let that jig take its own position. You will feel this is a very wrong position. This doesn't seem to be good. This is going in the wrong place, this is going outside. Don't use your brain there, please. Let the instrument do the talking. You will never make a mistake. If you use your brain, try to correct it and put into this, you are going to. Okay? Be very clear about this. So, this is it. Now, this is that, flexible jig. So, once this becomes parallel to each other, only then will this slide very easily. See now this. Because they are parallel to each other, this jig is inside, and you have to push it with the hand. Don't use a hammer. That means, now this is, you have got two holes. Now, you see this. It is almost in the center of the medial femoral condyle, and it is not beyond, it is not in the patellofemoral joint. That patellofemoral joint area, this is not going there. Now there are two holes, 4.5 and 6. So first you put that 4.5 drill, leave it inside, that gives stability, and then only drill your 6.5 hole. Once that is done, remove everything. And this is, you have two holes. Put in your posterior cutting jig here, and then put your spikes again, because this also can cut your MCL. And when you go with the saw has a tendency to skive. So you put in the saw, put your hand down, so it goes curved like this, and then it will not skive. Please be very important, that blade is very thin, very flexible. Put it down, curve the blade downwards, and then cut, you will not skive off. Fine? So that's again important. Now, once this is done, your posterior space is decided. Fine? Your posterior space, the flexion space is decided. Now you want to decide the extension space. So what you do is, this is a spherical implant. They have removed that they have cut that piece from the sphere. So they have a reamer, a round reamer, which is going to create a sphere where their implant can fit. So what you do is, put a 0. This is 0 mm cut. This is a 0 spigot. That means you are going to just cut the edges of the femoral condyle. You are not reaming anything on the distal surface of the femur. So that is 0. Once that 0 is done, you have that edges here, and in this is a very different surgery. Now put in this is 3 mm spacer. I have put in very comfortably. This is 4 mm. It is not going in. Don't push. You should be able to put, you hold your spacer with the finger. See how I'm holding it here? Just this, and it should go in. It should not go like this. It should be like this. And it should go comfortably. It should take some effort to pull it out, and there should be no rocking. Two things are important. Difficult to pull it out and no rocking. Otherwise, very difficult to push or very easy to kick out and rocking. You need to increase. Otherwise, you are okay. So that is okay. Here I have got the flexion space is 3 mm. 4 mm is not going. Now, extend your knee not fully, only up to 20 degrees of flexion, because the right point with proper without extra tightening of the ligaments, it's 20 degrees of flexion, which gives you a proper ligament tightness and unnecessary no strain on the MCL. At 20 degrees of flexion, try to put in this metal spacer, which is 1 mm, 2 mm, 3 mm. Now your flexure space is 3 mm, fine. Now this is 1 mm. I'm trying to put it in 20 degrees of flexion, it is not going. That means there is not even 1 mm of space in the 20 degrees of extension. So the extension gap is less than 1, that is 0. So my flexion space is 3, my extension space is 0. So how much more do I have to ream to get my extension space to flexion space? So I have to ream 3 mm more to get extension and flexion space. So that is very simple. 3 mm more is 3 number spigot. So I put a 3 number spigot, see it's 3 here, into this, ream more, so I am reaming 3 mm more. Once I have done that, I have put my space, I put my trials again, put the spacer in flexion very gently. You may be wrong. Still very gently come to full extension. If very good, even in extension, I'm getting a semi-tight feel in my spacer. Go flexion again, extension again. During extension, if that spacer pops out, you may not touch it, just do it like this. See, I'm not touching, I'm not doing anything here. It has to be free. When I do extension, if it pops out, that means the extension space is tight. Let me do it again. Let me see if my spigot has come out or my reaming was not proper. Do it again. Do it with 3 mm only. But see, sometimes the spigot comes out, it's not gone in properly, and you may have reamed less. Do it again. Don't be afraid of going again. Spend 5 minutes more. Otherwise, you'll end up with FFD post-op. Once this is done, I'm doing my tibial preparation, putting a tibial trial, putting trials again. Then that spacer was different. It was a flat spacer. This is a curved spacer, which is very similar to the bearing, the final poly bearing that is, because this has a raised edge here and a raised edge here. This is not that flat thing. So you put this in, and once everything is okay, you're fine, then you put in your implants, cement them, again put in this spacer. But ideally, what is one more important thing is, if you feel your space is 3 mm, when you are waiting for the cement to set, put in a 4 mm spacer inside before you put it in 45 degrees of extension and wait for the cement to set. Why? The thinnest spacer available is 3 mm. You don't have a 2 mm spacer. Let's imagine you put in a 3 mm spacer and you are trying to fix it. The cement is around point something mm. That cement causes a rising of the implants, and that 3 mm spacer becomes too tight and you can't put in your 3 mm spacer, you are into big trouble. So when you are trying to set the cement, put a 4 mm spacer, you may have to press it in, hold it up to 45 degrees, don't extend it because the MC will stretch otherwise, and go down, put a higher spacer so that you are safe, you can put in your minimum 3 mm spacer. Once that is done, you can put in your, this is again stop, okay. So this is your poly, this is on the lateral side, push it in, it should snap in, angutha dukhe pachi. This should pain you when you put it in. This should take an effort. There may be some slight stretch in valgus, sometimes it is very tight. That can help you with flexion, slight valgus you can put it in. Once it is in, do flexion extension, you can close. So this is basic, that's the practical. Our results, we have done more than 1100 in the last 17 years. We started in 2006 when there was no company available. We used to get the implants from Bombay. C&F agent ato, and Prabhu Desai Saib first karu to Gujarat no. One of the first in the country. And I had to ring him up, Sahib, training lane, so I don't know where to get. He helped me to get it from that agent, and we started doing in 2006. We have 5 failures till date. And 5 failures, one was a medial fracture, tibial plateau, because cycle mathi bhai padi gaya and he had a fracture. We had to convert it. One patient had pain in the knee. 15 days pachi, someone advised me, oh no, this is a failure, and he got it. 2 patients had loosening of the femoral implant. And we had to, do a total knee. 3 patients had a bearing dislocation. I consider it as a complication of the mobile bearing, not a failure, because we just reinserted a thicker poly and they are happy 4 years, 5 years down the line. This is but it is and there has been no recurrence after we have corrected or we have reinserted the poly. There are many studies, good survival rate. Our rate, 5 failures in 17 years in this, it is more than 98% now. And we are equivalent to all others. They have said 9% of the joint, you're not touching the ligaments, you are just replacing that 30% of the joint. And conversion to TKR is very easy. We never used a rod, we have used a primary TKR without a wedge or a rod. So, and you are, how much TBR removing is 3 mm. 3 to 4 mm of TBR, not much, because the remaining part is covered by the MCL laxity. So the amount of TBR removed is not more than 3 to 4 mm. Anyway, in a TKR, you're removing 5 to 6 mm. In medial 3 mm, lateral maybe 6 to 7 mm. So you will be able to do a primary TKR. Maximum fine, maybe you may use a rod, which you are anyway sometimes doing in a complex primary knee. So don't be afraid of this being a replacement surgery. I'm going to talk about this in the debate also. Please understand what your patient needs and do it. Thank you. These are results. Again, this is only for this. I have been telling him no, he is not agreeing to it, he is doing it. But I would really advise this not to be done in routine life. If they are somewhere in the trouble, they have to do this, they can do this. There is not much of a problem in this, but not routine. And But otherwise, you can sit, you have good results, don't worry. Complications, as I said, bearing dislocation, see this. It is anteriorly, sometimes it is posteriorly. One bearing dislocation, I did not remove that posterior poly, just put in extra poly and patient is fine. I couldn't go behind to remove that poly, it was posterior. Fine, thank you. And we'll do this later on in the debate, the comparison to HTO. Thank you.
Thank you, Dr. Nirbhay Shah, sir, for wonderful lecture. Now I would like to request Dr. S.R. Rao, sir, to felicitate Dr. Nirbhay Shah, sir. I would like to request Dr. Paresh Nanda, sir, to felicitate Dr. Kuldeep Parmar, sir.
Just a 1 minute before we break for lunch, I stand before you today to release the special Diwali edition of our e-bulletin. As we celebrate the Festival of Lights, we also illuminate the 4th edition of the informative publication. I extend my heartfelt thanks to our guest editor, Dr. Dhiren Ganjwala, whose expertise has ended. Special appreciation also goes to the anchors, Dr. Ketan Shah and Parin Kantesaria, for their dedicated efforts. May this Diwali edition bring light not only to our screens, but also to the wealth of knowledge it holds. We will share the link of the bulletin to all of you and in all the fora. Your suggestions and comments are immensely solicited. Please go through it and give us a feedback. Thank you. Do we break for lunch?
So now we are proceed for the lunch, and after, so we'll take around 30 minutes of lunch break, then we'll start with the workshop. Thank you.
Hello.
सर जी आप ले लीजिए देख लीजिए हाँ सर सर सब आ जाएगा अरे भाई चालू करो ना આજે કરે ને એ લાગે बंदा पूरा एक बंदा एक पूरा रखा है सर नहीं यार वो बंदा आप रहेंगे वो बंदा आप फालतू नहीं यार चालू करो नहीं यार all the delegates if they have taken their lunch kindly have your seats સાહેબ આવે છે માઈક ભાઈ
Everybody, please. We will proceed with the medial open wedge high tibial osteotomy workshop by respected Dr. Sanjai Rastogi sir. Sir will be carrying out on the front table and that will be live telecasted on the screen.
So we are all ready to go. Dr. Rastogi sir is ready with the demo instruments and the equipment. So let us start.
Good afternoon. The best is when you operate with your own hands. The second best is when you do a sawbone exercise with your own hands supervised. And the third is when you see somebody demonstrating. And the fourth is when you see a video. I had sent a link to the video. I'm not sure whether it reached you or not, but one can always go to the Synthesis site, and if not done already, see the video. So that will help you revise this procedure.
टेबल पे ही है रिमोट
The upper
नहीं
the upper edge of the pes and
ये क्या हुआ जहाँ मैं था वहीं चलाना था So I will try to demonstrate as best as possible how to do a open wedge high tibial osteotomy, a sawbone exercise. If you have any problem, don't hesitate in stopping me. I'll try to clarify as best as possible. So before we proceed, we have to understand that this Tomofix is an angle stable implant. It has 4 locking head screws in hole A, B, C, and D. And all these 3 are longest possible monocortical locking head screws. And as I said earlier, this distance is up to 30 millimeter, and this should be 1 centimeter from the joint line, so that makes it 44 centimeters. The distance between this hole D and hole 1 is 30 millimeter, so this allows a comfortable opening up to 22 millimeter, which can be with care go up to 26. The locking head screws holes 1, 2, 3, 4 are in a staggered manner. A, B, C, 3, 4 are round hole, and D, 1 and 2 are combi holes. They are for specific reasons. Holes in the shaft are not in one line. They are staggered to avoid a fissure fracture into the shaft. This is all clear? Now, what are the learning points to perform a osteotomy? So what are the landmarks for osteotomy site? Then we have to place 2.5 mm threaded wires for transverse osteotomy. Then we have assessment of depth of osteotomy, which we transfer onto the blade. How we do it, I'll tell you. Then we do ascending osteotomy, a transverse osteotomy, and then we do gradual opening of the osteotomy. Height and alignment of osteotomy is checked on table. So I'll run this.
The upper edge of the pes anserinus and the medial collateral ligament are the main anatomical landmarks. The lines of the biplanar osteotomy are marked on the bone. The first osteotomy plane is now marked with two parallel 2.5 millimeter K wires with
So a lateral support and a support under the ankle joint, and we mark the osteotomy site. You can see this line. This is at the level of the pes, and as I told earlier, it is at the junction of the convex and a concave medial border, and this allows 4 to 6 millimeters difference from the joint line. This is the tibial spine, this is the joint line, and when we do a ascending osteotomy, it should exit between the tuberosity and the joint line. So this dotted line, it could be here, here. It has to be parallel to the shin of the tibia. And while we were doing the drawing exercise, we had marked the hinge point. It was just proximal to the tibiofibular joint onto the lateral cortex. These points are clear?
The upper edge of the pes anserinus and the medial collateral ligament are the main anatomical landmarks. The lines of the biplanar osteotomy are marked on the bone. The first osteotomy plane is now marked with two parallel 2.5 millimeter K wires with threaded tip. The plane goes from the upper edge of the pes anserinus in the direction of the tip of the palpable head of the fibula. The depth of the first The upper edge of the pes anserinus and the medial collateral ligament are the main anatomical landmarks. The lines of the biplanar osteotomy are marked on the bone. The first osteotomy plane is now marked with two parallel 2.5 millimeter K wires with threaded tip. The plane goes from the upper edge of the pes anserinus in the direction of the tip of the palpable head of the fibula.
Stop. Now, this bone is marked 1. I will send this bone to all of you gradually, so that you can see the bony landmarks which are marked here. Right? To my mind, you don't remember that well. If I go stepwise, then I show you then and there.
If you continue the video, we will have some impression in our mind, and then you can go step by step. So first if it is possible, then you go for a video.
Everybody agrees? Perfect.
Preparation and insertion of the
बस दो ही है ये
the upper edge of the pes anserinus and the medial column anatomical landmarks. The lines of the biplanar osteotomy are marked on the bone. The first The upper edge of the pes anserinus and the medial collateral ligament are the main anatomical landmarks. The lines of the biplanar osteotomy are marked on the bone. The first osteotomy plane is now marked with two parallel 2.5 millimeter K wires with threaded tip. The plane goes from the upper edge of the pes anserinus in the direction of the tip of the palpable head of the fibula. The depth of the first osteotomy can be found.
पीछे नहीं होगा उसमें पीछे नहीं होगा
Now, how to decide the plane of the osteotomy? I'm talking of transverse osteotomy. So it has to be parallel to the lateral tibial slope. And this is the wire is when you see it from the side on a C-arm, this will tell you the upper limit of the plate. Plate. एक और होगी एक और होगी एक और होगी अरे है यार लेके आओ है हाँ so the upper border of the plate has to be 1 centimeter from the joint line and parallel to it. And how to do it? We put a anterior posterior K wire and then put the C-arm into AP view so that this wire is seen as a dot. And then from the upper border of the pes, we pass a K wire just proximal to the pes up to the palpable head of the fibula in a manner that you have passed two wires but you are only seeing one. That means they are in the same plane and the plane was seen by this AP wire in the lateral projection. So, is it clear? इसको थोड़ा सा पीछे रन कर दो यार पीछे रन करके दिखा दो Thank you. So this is the AP wire in the plane of the lateral tibial medial side and you bring the C-arm into the lateral.
The upper edge of the pes anserinus and the medial fixation. To insert 5 mm self-tapping locking head screws in the T-arm of the plate, a 4.3 mm drill bit is used.
मैं कर लूँगा।
પહેલાથી રન કર દો બસ એ જ ને ફૂલ સ્ક્રીન અહીંથી થશે પણ ક્યાં અહીં સુધી બતાવું છું કે આગળ લઈ જવો છે
नहीं आया नहीं ना
नहीं આવશે આવશે वो आएगा
हाँ भेज
आपको
दिए
कहाँ से स्टार्ट
यहीं से करना है
कर दो
हाँ
और कंटिन्यूस रन कर दो ऐसा सबका डिमांड है
ठीक है
The upper edge of the pes anserinus and the medial collateral ligament are the main anatomical landmarks. The lines of the biplanar osteotomy are marked on the bone. The first osteotomy plane is now marked with two parallel 2.5 mm K wires with threaded tip. The plane goes from the upper edge of the pes anserinus in the direction of the tip of the palpable head of the fibula. The depth of the first osteotomy can be found using a third K-wire. The osteotomy is performed just caudal and parallel to the K-wires with an oscillating saw. Both wires help to guide the saw blade in the correct direction. Sawing must be done carefully and slowly with little pressure. Loss of resistance is felt when the posterior cortex has been traversed. After reaching the planned cutting depth, the anteriorly ascending cut is made with the narrower blade. This osteotomy, lying in the frontal plane, must also cross the cortex at the lateral side. Once the cortex has been cut, the blade is directed to the frontal plane. The osteotomy is now completed with chiseling, the lateral cortex remaining untouched. To make it easier to insert the flat chisels, the narrow saw blade is positioned in the osteotomy. The scale on the chisel indicates precisely how deep the chisel must go in the osteotomy gap. A second chisel is driven carefully into the gap. By slowly driving a third chisel in between the first two, the osteotomy can be spread open gradually. Before this step, care must be taken to ensure complete separation of the dorsal cortex to prevent an ascending fracture. The chisels and the K-wires are removed. The flat chisels are replaced by a spreading chisel. Its arms are slowly opened with a screwdriver until the right degree of correction has been reached. The gap must be opened slowly, taking several minutes to help plastic deformation of the lateral bony bridge so that the bridge does not break. The osteotomy gap is checked with the calipers. A bone spreader is inserted into the postero-medial corner of the osteotomy so that it comes into contact with the hard posterior cortex.
This completes the first half of performing the osteotomy. Do you want me to proceed with the second half, or there are some questions to be asked on this?
Any questions from audience? Sir, continue.
The upper edge of the pes anserinus and the medial collateral ligament are the main anatomic.
Next. ये देखो ये वाला ये वीडियो आधे से ये बनेगा. So that after having done the osteotomy, we prepare and insert the implant, and the learning points are: placement of threaded LCP drill guide with the help of a guiding block in A, B, C holes. This is extremely important because the plate has only a thickness of 3 millimeters, and there are only 3 rounds of hole to engage the screw into the plate. So until as the sleeve is placed perfectly, there will be mismatch and loss of strength at that area. A spacer is placed in hole D and 4. This keeps the plate off the bone to conserve the soft tissue, give it a springing action, helps tension the lateral hinge. Then the plate is placed on the medial side and temporarily fixed with K-wire in hole B, which is the middle hole in the proximal part, with the help of a K-wire sleeve through LCP.
Preparation and insertion of the implant. The implant is now prepared. The guiding block is placed on the shaft of the plate and pushed forward up to the proximal end of the plate. The threaded LCP drill guides can be placed in their correct positions in the guiding block and screwed into the plate holes. In addition, spacers are placed in hole D and hole 4. The screws to be placed 1 centimeter below the joint line. The plate is temporarily fixed with a K-wire placed through the middle drill guide. Therefore, a guide sleeve.
So this is how we prepare the plate and keep in a manner so that it is right onto the bone. It should not. This is the third part and the last part. 5 mm self-tapping locking head screws, monocortical, are put in hole A, C, and B. You remember B, we had put a 2 mm K wire to hold the plate onto the bone. So first we put a locking head screw in hole A, followed by in hole C and then B. After that, a bicortical screw is put on hole 1 in neutral position so that the gap which has been opened does not change. The angle fixation of the shaft is done by monocortical screws from hole 2 and 3. The spacer in hole 4 is replaced by a monocortical locking head screw. Removal of the cortical screw and insertion of a bicortical locking head screw in hole 1 is done. This is the only screw which is bicortical, and the cortical screw which has helped to compress the hinge is discarded because it gets deformed. And final fixation by replacement of a spacer D in hole D is done by a, again, long monocortical screw.
Fixation. To insert 5 mm self-tapping locking head screws in the T-arm of the plate, a 4.3 mm drill bit is used. The plate is pressed firmly onto the tibia to avoid the plate spinning, as bicortical anchorage is not absolutely necessary, and to avoid soft tissue irritation. The screw tips should not protrude from the lateral cortex. The required screw length can be read from the scale on the drill bit. For optimal buttressing of the tibial plateau, the longest possible screws should be inserted. These locking head screws are partially inserted with the power drive and the screwdriver shaft. The last turns have to be done by hand to prevent the threads from jamming, so the torque-limiting screwdriver is used. The same procedure is used to insert the screws into hole C and hole B. Now the angular stable fixation of the plate shaft can begin. After locking head screws have been inserted into holes 2 and 3, the spacer and the lag screw are replaced by locking head screws, with all the plate holes in the shaft filled with locking head screws. Maximum stability is achieved and the correction maintained. Since monocortical self-drilling and self-tapping screws are used here, only a shallow hole is drilled in the cortex with the 4.3 mm drill bit of the LCP universal drill sleeve. In holes 2, 3, and 4 of the plate, a monocortical screw fixation with self-drilling and self-tapping locking head screws is sufficient. However, a bicortical self-tapping locking head screw is recommended for hole 1, distal to the correction gap. As an alternative to self-drilling and self-tapping locking head screws in holes 2, 3, and 4 of the plate, self-tapping locking head screws can be used in a monocortical fashion. This option requires pre-drilling and the use of drill guides. The proximal spacer is replaced with a long self-tapping locking head screw. Monocortical screw fixation requires 18 to 26 mm locking head screws. The internal fixation is now complete and is stable enough for partial load bearing.
So, if there are any questions,
if there is more deformity, can it be corrected?
Pardon me?
If there is more deformity, more than 18 degree or so, can it be corrected by tomofix?
No, I said the distance between the hole D and hole 1 is 26 millimeters. So you can go up to 22 because it's an angular stable implant. It does not require any bone graft. They are asking, it is only in the tibia. Any other question? You have seen the model 1. This is 2, in which this is the plane of the lateral tibial plateau. This helps us to decide the, in a lateral view, that the upper end of the plate is parallel to this wire. This plate should be such, parallel to this wire. This plate should be such that it should not overhang anteriorly or overhang posteriorly. It should be in the center here. वो कहाँ गए? नंबर 2 और 3 नहीं, यहाँ नहीं है. 2 कहाँ? Now I'll demonstrate the number 3. The point to be noted are that this line is the upper border of the pes anserinus, right. The osteotomy, the ascending osteotomy and the transverse osteotomy should be 1:3. When the deformity is more, then it should be 1:3. When the deformity is less, it could be 1/4 and 3/4. And this ascending osteotomy should be parallel to the shin of the tibia, and it should be proximal to the tibial spine and the joint line. So this will reach you, so you can see from the close quarter. Now there are few models of this model 2 was when I said it has to be AP wire into the lateral condyle 1 centimeter distal. So this distance is 1 centimeter, and this will allow us to put the proximal part of the plate in a manner that it is parallel to the K wire, right? And when we put the C-arm in AP view, this AP wire is seen as a dot, and once it is seen as a dot, these two wires should be seen as one. So that means this wire, which is in the plane of the lateral tibial plateau, has these two wires also in the same plane, and they act as a rail onto to do the osteotomy. It should be done slowly, and the posterior medial cortex has to be cut first. And after having marked this, you should shorten these wires, because once these wires are short, then you can do the osteotomy with ease. If these wires are there and then you do the osteotomy, it will push in the other direction. Now these are the few models in which the osteotomy has been done. So it has one ascending osteotomy, which is parallel to the shin of the tibia, which is a complete osteotomy. The other is the transverse osteotomy, which is in the posterior 2/3, and it is an incomplete. The anterior portion is not cut. These wires are only held to keep the osteotomy stable for demonstration, because when I demonstrate, people try to move it. So this is not part of the operative exercise. It is just to keep it positioned so that you can imagine. So the सब एक से हैं. All these bones are same, so this will give you a concept of what a biplanar osteotomy is, because this is difficult to imagine. Having seen this, it will be easier to understand this. So वो एक ही हैं, आप पीछे तक कर दीजिए. Now this is the alignment rod. This is at the ankle joint, and this is at the knee joint. And this wire helps you to decide the joint line orientation of knee and ankle. So once it is kept on the extremity, this will go onto the hip. This will be at the knee. So this will be at the ankle. And this wire will match with the axis of the tibia lower end. This will match with the femur, and this will be at the center of the hip. This will be at the knee joint level, and this is at the center of the ankle. So this will give an idea of any other question or clarification? No, KYs should be cut short. They should be used as a rail on which the blade runs, and after completing the osteotomy, they should be retained till you have opened the osteotomy, because those K-wires provide certain amount of stiffness to the proximal fragment. And then you pass a saw blade below it, then you pass the...
Do you use any protective, hello? Do you use any protective sleeve or retractor to cut the posterior cortex?
For cutting the posterior cortex should be done in 90-degree knee flexion.
Achha.
And Hohmann retractor should be passed posterior to the bone, anterior to the popliteus muscle.
Sir's K-wire will prevent the saw being moved in the upper tibia. So below the K-wire, so keeping the K-wire is that is also helpful. No, our blade will not shift above and prevent the plateau
fracture.
fracture.
Rail on which the wire runs,
to prevent the
saw blade runs. एक बोन ले आइएगा, एक ले आइए, एक ले आइए, एक ले आइए, नहीं कटा हुआ चाहिए, एक ले आओ यार, दो तीन घूम रहे हैं, नहीं इसका वो कहाँ गया, नहीं इसका की, हाँ इसमें होगा, हाँ नहीं कुछ नहीं करना है. नहीं ब्लेड चाहिए नहीं. Now when we have passed two K wires which are in the proximal fragment, we put the saw blade into the osteotomy. So on one side, the wires provide the stiffness, the other side, the blade provides the strength. And then we pass chisels between the two. And they are slowly hammered and then when we put the second, and we have marked what is the depth of the osteotomy on this. So say it was 50. So it should be marked on the chisel so that you don't overshoot this. And the third chisel would be inserted between the two, and it will be 1 centimeter less than the previous. So gradually they will open up. So this is the idea, that they should not go to the same depth. Sequentially, they should be less. Now, having done this, spreader. Then we apply the spreader. So the posterior medial portion. So it should be applied into the posterior medial corner of the tibia, which is the hard bone. If you apply somewhere else, it crumples and the correction is lost. And this is how we spread, right? So this is how, so this will hold the correction, right? And then one will apply the plate anterior to it. So the spreader is in the posterior medial side. The plate is applied into the middle of the tibial shaft, 1 centimeter from the joint line. One can also measure the H. You had remembered the height H. So you put this and you measure this. It says 9 millimeter. So this is what you had decided, how much you want to open it. This will be, instead of using the नहीं, वो अभी था ना, मैडम दिए हुए थे. We can also use this spreader to increase the gradual opening of the osteotomy. So this can be done with multiple chisels or this device, right? On the handle, it says 10 at this stage. So we have opened H as 10 millimeter. Anything else which needs clarification? Dr. Samir bhai, any point you want to add, want me to explain? जी.
Initially, everybody had a fear of breaking the lateral cortex, right? So hinge protection K-wire, we can find out. We can use hinge protection K-wire while opening. So it will prevent that we can add once we are doing, once we have good practice of doing multiple osteotomies, then we may not require it. But initially, if we are feared of that, we can pass a hinge protected K-wire.
Lateral cortex, preventing the lateral cortex.
We pass it from here to here, or naito from here to here.
The line is the same. I'm telling you, at that point of time, that means your lateral hinge is unstable. So put 2 K wires, one in the proximal, the other in the distal. This will tell you what is the rotation before you start moving them. So this will take care of the rotation. Now how to compress. You have a cortical screw in hole 1, which is in neutral position. You tighten this, and this will bring the bone to the plate, and this will compress the lateral hinge.
But at that time we should remove that washer, that spacer, when we want to bring the lateral cortex.
No. Spacer, the purpose of the spacer is to have a preload in the plate. The purpose of the spacer is it should not compress the periosteum. It should not compress the pes insulinus. So to maintain the vitality of these structures, spacer should be removed in the end. Say that again.
When you are putting the cortical screw with the 2 spacers in place, and you're expecting that the bone is going to be pulled towards the medial cortex.
Up to 3 millimeter.
So when that happens, would that not cause a kind of stress on the other screws?
You have not
because
applied.
You're going to change this screw again and put the cortical.
You have not applied the screws.
No, sir, but at the end, this cortical screw remains still. You put all the screws, and then you remove this cortical screw, and then put a locking screw.
First, you put
The
monocortical
4 top screws.
A, B, C. Then you
put the cortical screw.
Then you put the cortical screw with the spacers on.
in place.
Then you put monocortical locking head
The
screw.
last 2 screws.
Second, third, and fourth.
Yeah.
Then you remove and discard the cortical screw. So by this 3 screws, because it can't compress, because there was a spacer. So that space is already there. Then you put a bicortical locking head screw in hole 1. And last, hole D, you remove the spacer and put one long locking head screw. If you have understood the reasoning for this implant, then it is quite simple and mathematical.
When to remove the spreader? After fixation?
After you have fixed the plate by 2 or 3 screws. Usually 2 locking head screws are enough. But if it is not interfering, which it does not, you can keep it as late as possible.
Any questions? So we will have a few minutes of debate between open and closed wedge osteotomy, and Rastogi sir will speak for open wedge and Thakkar sahib will speak on closed wedge osteotomy.
Fixation. To insert 5 millimeters self-tapping
Presentation 4. If I have to sum it, I would say do what you do best. It is futile for me to try doing closed wedge, and similarly, I'm sure Dr. Dinesh will not like to do a open wedge because he's so good at closed wedge. Having said that, what are the indications for a open wedge high tibial osteotomy? When there is patella alta or there is insufficient medial collateral ligament. Open technique allows to tension the medial collateral ligament. If there is associated ACL injury, then this can be reconstructed at the same sitting. The only difference is that you should not put this locking head screw in hole B, because that's where the tunnel for the your graft will go. And it allows you to do a medial arthrotomy, while if there is a patella baha or there is a intact medial collateral ligament, the ACL is intact, or you don't have to repair it, and you want to inspect for whatever reason the lateral joint, then closed wedge is the right choice. Open wedge is a more soft tissue conserving surgery, and it is faster and safer. The tibial slope correction is possible when you do the open wedge. It has a high precision. There is minimal risk of saphenous nerve lesion, especially with the MOWHTO incision. Extensors are not erased, so it is more soft tissue conserving. Remember, open wedge high tibial osteotomy allows a functional rehabilitation. That means from day 2, patient can be made mobile. And there is some amount of limb lengthening, which in a bilateral lesion, once you do the other side, is compensated. Otherwise, some patient would like to use a shoe raise. Now, closed wedge osteotomy is a long surgery. Large soft tissue dissection is required. One has to cut the fibula. Tibial slope correction not possible. And since it's a closed wedge, it has a low precision. There is high risk of peroneus nerve lesion. Extensors are erased, and there is a shortening of the limb. As the extensors on the lateral side are erased, there are chances of peroneal nerve injury in 3 to 16% cases. However, on electromyography, lesion up to 27% has been reported. since compression of the osteotomy site in closed wedge is required, it requires a much larger incision to apply a compression device in the lower part. For closed wedge, there is lateral translation of the shaft. There is impaction of the medial hinge which leads to loss of correction, and it interferes with the knee replacement later on because the peg goes into the lateral cortex. There are various studies which tell us about the possibility of a peroneus nerve lesion in various studies. So for this reason, open wedge osteotomy is what should be preferred. Because this is the last presentation I am making. So now you are entitled for being a table instructor from 13 December in Lucknow. And we have one HTO 360 from 1st to 3rd December at Akola. And then 13th we have a pre-conference workshop. And remember, I am always available for any lectures, hands-on workshop, sawbone demonstration, video presentation, till my term as chairman, knee preservation subcommittee. Otherwise, it's my personal commitment to myself that I'll continue to propagate because I so strongly feel about it and it works. Thank you for your time.
From Kanpur to Rajkot via Ahmedabad. Thank you so much, sir. We appreciate all your work. Now I call Dinesh Thakkar, sir, to talk on closed wedge osteotomy. અમને તો એટલું ખબર પડે સાહેબ થોડી ક્લોઝ વેજ અઘરી છે મીડિયલ ઓપન ઇઝી છે એટલે અમે મીડિયલ ઓપન વેજ કરીએ
નહીં I will if we get a chance I will demonstrate how to simplify it because what I have demonstrated in the video is the after doing more than 500 high tibial osteotomies, but when I did the first time it was a different issue. This is closed wedge. Once we have measured by Miniaki method how much wedge is to be removed. Only simple thing, put a wedge on the scene of tibia that I already have, I will show you, and cut both the cortex. Don't preserve lateral cortex, don't preserve posterior cortex, that I have adapted later on. So remove the wedge triangular piece, close it and close like a fracture, fix it like a fracture. It's a very simple thing, but as our experience increases, then we may try to achieve earliest union. And all other two, that I preserve the posterior cortex and I preserve the vascular bone graft as a lateral cortex, is all to have an early union. But as a beginner, remove whole thing, whole triangular piece, close it and fix it. That's very simple. I think I will demonstrate. I will not demonstrate what I do, but simple remove and close, fix. It's as simple as that. So I think it should not be a problem.
Mid-shaft fibula fracture, right? Mid-shaft fibula osteotomy.
Mid-shaft fibula osteotomy. First osteotomy when I did closed wedge, first I did fibular osteotomy. Just before beginning anything, cut fibula first, either segment of fibula or just transverse cut. And that is why I am cutting it at the mid-shaft level. That prevents the. That prevents. No, there is no. lateral popliteal nerve palsy I have faced in 3 patients, and that reason I find out very late. Even today, Dr. Maru Sahib has also said that we have fixed medially, we have done open wedge, and still he had a lateral popliteal nerve palsy, and that was recovered in 9 months, what he said in his lecture. That was the what was the reason? In that particular case and in my case, that is the drilling over on the lateral aspect, while we are passing a screw. And in one patient, when last time I faced this peroneal nerve palsy, and then I suddenly realized at that time, immediately on the next day I noticed that it is in the lateral popliteal nerve palsy. Then I remembered myself, then I have over drill and my drill was passed too far laterally. That was the reason. After that I take very much. Now why I prefer the closed wedge. First thing, real fact, we cannot have a good slip with open door. We will always have a threat to something will be stolen from our house. So we cannot slip. And same way, union is delayed in open wedge as compared to closed wedge. So orthopedic surgeon cannot slip till our osteotomy site unites. That is the one thing. So if we want a good slip, then we should have a closed door. That is the reason, and in union is almost assured in the closed wedge, right? Another thing, as I said, orthosurgeon cannot sleep well when union is not assured. Open there, that young girl and boy sitting in a room and with a door open, they have many limitations. So open wedge has also many limitations. They can't do whatever they want to do. Which are the limitations? Which are these limitations? First, varus more than 12 degree or 15 degree, whatever you say. Rastogi sir is saying that we can open up to the 22 degree, but as we open more, there are more chances of delayed union. So ideally, routinely, more than 15 degree is not recommended for open wedge at present, unless it is done by gradual medial open wedge. Another, flexion deformity more than 10 degree cannot be corrected by open wedge. Some amount of flexion deformity can be corrected, but more than 10 degree cannot be corrected. Valgus knee with lateral compartment arthritis in that particular lateral open wedge has not been described till. And another thing, internal tibial torsion is difficult to correct with intact lateral hinge. If we are doing with internal tibial torsion and we do an open wedge, we cannot rotate the distal part of tibia. So that are the limitations of open wedge. Many liberties with closed door. Same way, many liberties with modern closed wedge, particularly. I am not talking about the Coventry. Varus more than 12 degree. Here we can see that here on one side it is 25 degree and on one side it is 18 degree varus. And this has been corrected very well by closed wedge on both sides. And here we can see that weight bearing axis is passing from near the Fujisawa point. And we can say that how she was walking before surgery, and after surgery also she walks nicely. This is my phone, please close it. This is how she is walking after. Another thing, flexion deformity more than 10 degree. Here we can see that there are so much of flexion deformity on lateral view, and that can be corrected by closed wedge by removing the anterior base more and posterior base less. So this can be corrected by closed wedge, may not be possible by the open wedge. These are the post-operative X-rays. We can see that the flexion deformity was corrected by altering or reversing the posterior tibial slope. So it's again a debate that whether we should reverse it or not. But by reversing the posterior tibial slope, the flexion deformity was corrected. But how she was walking before surgery and after surgery she becomes comfortable, and we can see that after correction of flexion deformity and varus, she is very comfortable. This is lateral compartment arthritis, can be corrected by medial closed wedge. After that, he can enjoy full function, Padmasana, Vajrasana, squatting, everything. If we see the x-rays, these are the pre-operative and post-operative x-rays. So this is possible with the closed wedge. And another thing, internal tibial torsion. Here we can see patient have an internal tibial torsion post-operatively, because here we are cutting both the cortex. So we can rotate the distal fragment after cutting both the cortex, and we can fix in whatever rotation after correcting the rotation. This one another additional advantage. And one another, the large deformity with a ligament laxity, too much ligament laxity. Here we can see that there is a opening of the lateral side. See, while she is putting weight, there is a dynamic varus. We can appreciate that dynamic varus when she is putting weight on the floor. And these are the weight-bearing x-rays. Someone is asking why weight-bearing x-ray measurement. If we do in this measurement, how much correction will you achieve?
So that is what the JLCA is too much. I will subtract.
Yeah,
I will subtract.
Yeah.
I
But that
need
is
to
why I
remember that I am not going to add on that JLCA into my correction because I am doing bony work.
Yeah. That is what, another thing is that non-weight bearing shows normal x-ray. See, this is on other side, it's a non-weight bearing x-ray. So we have to calculate on the non-weight bearing. And this is, the weight bearing line is passing from medial to the medial joint space, right? So if we put a weight, if patient puts a weight on this limb, obviously there will be opening of the lateral joint space. But once we correct it, see, once the weight-bearing axis has been shifted near the Fujisawa point, and after that standing X-ray, standing X-ray, there is no any opening of the lateral joint space. So if we correct it perfectly, then what Dr. Maru was discussing with me, but he is not present here. So he was telling that lateral collateral ligament
may not need because now the soft tissue are shifted to a new bone alignment.
That is
when
what
they will get some correction.
It doesn't require any reconstruction or repair of lateral collateral ligament once we correct the axis. See, this is after surgery, we can appreciate. This is post-op on one side, and one side it is pre-op. So after on weight bearing, we can see there is no opening of joint space now. There is no opening, it's become stable after surgery. So all this luxury can have with a closed wedge, probably open wedge may not solve this problem. Another, there is a lateral, typical lateral thrust. This is the lateral thrust we can see here. On one side, there is left side. If you observe left side very carefully, there is a lateral thrust. Proximal tibia shifts laterally while she is bearing weight. This is typical lateral thrust, what we can see in many patients. So what are the reasons for lateral thrust? Only one collateral, can you add
It can be, sir, supervarus. Maybe the LDFA is more than 90 degree. The LCL is lax as well as the proximal tibia vara. Or it can be a long tibia vara. Distally also there is a varus.
Too much laxity, not only that.
Soft tissue caution, sir. That is supervarus. When soft tissue are also involved.
Only there is not much of varus, not a LDFA is not much of. But there are, if there is a varus with two ligament laxity, one is LCL already, lateral collateral ligament. Second is either of the cruciate, either PCL or ACL. If two ligaments out of 4 ligaments are lax, then lateral thrust occurs. Only one ligament, suppose in previous case it was only LCL lax. So there was no lateral thrust. There was just opening of the lateral joint space while she was bearing weight. But when there is a ligament laxity, both, in particular this patient, I have seen a patient with a lateral collateral ligament laxity and PCL laxity also. They have also thrust. And with ACL and LCL, then also there will be a lateral thrust. Here we can see on examination. These are the, we can appreciate, this is the lateral collateral lax on examination. We can easily appreciate in video also. Medial is good, see, medial is not that lax. Right? This is the lateral collateral ligament laxity. And there was an anterior cruciate, see, this is anterior cruciate is also lax. Anterior drawer test is also positive. So there are two ligament laxity with varus, then there will be a lateral thrust. And if we do a perfect job and realignment and bring our weight bearing axis in the just Fujisawa point, then we can see after surgery there is no lateral thrust. Lateral thrust has gone and knee has become stable. Two things we have made, we have done. One thing, correction of the varus, and second thing, reversal of, decrease the posterior tibial slope. That I will show in X-ray. both the things done together. One thing is correction of axis that will take care of the lateral collateral ligament laxity, and reduction of the posterior tibial slope that will take care of anterior cruciate ligament. None of the ligament were reconstructed. So she was operated on the opposite side also after 2-3 years, and these are the post-operative X-rays. We can see that weight-bearing axis is very well passed from the near the Fujisawa point, and these are the correction for the lateral collateral ligament laxity, and she was able to sit cross-leg. And here we can see there was too much. It's not a good X-ray, but here is too much posterior tibial slope. We can observe here, and after surgery, the posterior tibial slope was reduced. So these take care of laxity of anterior cruciate ligament. So these are the things is possible with the closed wedge. All these things probably may not be possible with the open wedge. But still we should remember it's not 100% safe. As we have a closed door, then somebody can come from the window and can steal also. So closed wedge is not out of complication. I have also faced many complications after doing so. More you operate, more you face the complications. That is the dictum. And I have also faced overcorrection, non-union, lateral popliteal nerve palsy, everything, whatever they described in the book. Almost all kind of, actually I don't have any vascular injury. All complications I have faced, and some of the solutions. But one thing is very important with these osteotomies, that there is a option remains open. Joint is with us. At least patient can pardon us with our complications. See, this is not a dead-end surgery, so we can have always some solution for that. So why I prefer closed wedge? Because it can replace the knee replacement in many cases. That is the thing. Otherwise, if we don't do osteotomy, then they might have undergone total knee replacement. So again, I will repeat, save, don't kill, save the natural knee. Thank you for your kind attention. Thank you. I think if anybody have a question for Dr. Rastogi, because he has to leave, they have to, Dr. Navin sir and Dr. Rastogi sir has to attend the function at the function of Ahmedabad Orthopedic Society. So if anybody have a question for Dr. Rastogi, then this is the last chance to have.
Rotational instability. So before you distract, put one K-wire in the proximal, other in the distal, to know what is the primary rotational alignment, and keep them parallel at the end of your surgery. One. Second, the screw from the hole 1 would help to compress the hinge and make it stable.
You have to be ready with the lateral fixation also. You have to be ready with the lateral fixation.
Actually, this has all been said, with due apologies to Dr. Navin, but there have been series of more than 700, the initial ones, but it has not been shown. We are hesitant.
Sir, you can put in a hinge, as sir is making the two hinge and medial plate. You can make a hinge on the lateral side. Screws in the proximal tibia, distal tibia, and make a figure of 8. Yes. And they say if the osteotomy is above the fibula head, the slope is above the head, then it should not be a worry. If you have been below the fibular head on the osteotomy, then there is an issue. If you are above the fibula head, the fibula is going to give the support to the tibia. So that is the crux. Go above the fibula head and never below the fibula head in tibia. That the osteotomy. Now I would like to call on Dr. Nirbhay Shah Sahib for Uni versus HTO.
બસ પછી બતાવી દઉં. ના ના વાંધો નહીં મળવાનું આપી દઉં. So, review of literature is a double-edged sword. We all know that in a controversial, any controversial topic, whatever the review we want to find, if we want to find a literature in favor of uni, then plenty of literature is available that favors the uni. And if I want to find the literature favoring the high tibial osteotomy, so there are a lot of articles that favors high tibial osteotomy is better than unicondylar knee replacement. But HTO, in favor of HTO, what is there? That is some simple logic. Anyone who is going to purchase anything, whether you choose a duplicate or original, obviously original, right? So this is the one argument. HTO is we are preserving the original knee joint, right? HTO preserves God-given original knee joint with full function. While in uni, we loses our half of the knee joint. Sir said 30% of the knee joint, but okay, chalo, 30% of knee joint we are losing. While in high tibial osteotomy, we gain the lost cartilage. We are not losing anything in high tibial osteotomy. Instead of losing, we are gaining what we have lost. What we have lost? We have lost our hyaline cartilage. And we are getting it back. Obviously, it's fibrocartilage, but we are getting it back. We are not losing anything. So we all know that it's very well documented that cartilage does regenerate in most of the cases after high tibial osteotomy. Another thing, if we have achieved a good skill to achieve the perfect alignment and weight-bearing axis passes near the Fujisawa point, so patient can enjoy full function including Padmasana and Vajrasana. I think even in his lecture he said that even he has shown some slide in which one patient was sitting in the squat and sitting on the floor with, then also he has to clarify that ideally I don't allow, but patients are doing, and that's why I have taken. So he accepted that full function after high tibial, unicondylar knee replacement is not possible. And here we proudly allow them to have a Padmasana, Vajrasana, or whatever they want to do. This case, we can see that the correction is good. Most of the time, medial joint space open. If it is medial collateral ligament is not tightened. And if we have achieved perfect correction, patient can squat also. And we can allow proudly them to, okay, you can squat, we don't mind. So that fearless allowing of squatting probably may not be possible with unicondylar knee replacement. Most of the Muslim patients, as we discussed, wants to pray namaz. So here, after correction of varus on both sides, patient can pray namaz easily. If they have a full range of movement before surgery, we can give them back the same range of movement after high tibial osteotomy. If we look towards the x-rays, so the foremost criteria is good alignment, and good alignment, right? We have to achieve the perfect alignment. Overcorrection is, little overcorrection is partly accepted, but too much overcorrection is not accepted, undercorrection is not accepted. We can accept up to the midline. If we have shifted the weight-bearing axis up to the midline, we can accept that. But beyond midline, medial to the midline, we cannot accept. So this is how, after surgery, we can appreciate that he can easily pray the namaz after HTO on both sides. this is, I have shown this patient, I will not discuss this. Patient have a full function even after 17 years. So these are the securities again. But in between, I have shown this, I am going forward. So in between, this patient has enjoyed full function. Running, jogging, probably impact, what creates impact on our knee joint is not allowed probably after unicondylar knee replacement. Many of the patients have a fond of playing badminton, many of the patients want to play table tennis and everything. Then many of patients are fond of doing trekking. So this is not possible after unicondylar knee replacement. Here is the patient who had a fond of playing badminton daily and doing trekking. So this virus has been corrected, well-aligned knee, and after that we can see that patient is back to the playing, back to play badminton daily. He is playing daily badminton for few hours. And he himself sent the videos to me. No, I am very happy and I can play badminton. So all these benefits, and this literature also supports this, that impacts opening wedge high tibial osteotomy allows better outcome. That is for open wedge and uni. Opening wedge high tibial osteotomy allows better outcome than unicompartmental knee arthroplasties in patients expecting to return to impact spots. So these are the reviews. Long-term follow-up is also, I should say that long-term follow-up probably may be comparable to unicondylar, because unicondylar also he has told in his lecture that unicondylar knee also works for very long time. It may be parallel to this, or even osteo after high tibial osteotomy is also long. But one again, when a younger patient consulting to the knee replacement surgeon, मेरे घुटनों में तो बहुत दर्द है. Now the people are searching in the Google. They know everything about that. So फिर after examining this relatively around 40s to 50s young female, he advised आपको घुटनों के दर्द के लिए half knee replacement करवाना पड़ेगा. What she answered? Knee replacement से डर नहीं लगता साहब, arthrodesis और amputation से लगता है. So it is never arthrodesis or amputation in case of high tibial osteotomy. Probably it is more common with the total knee replacement. Very rare, I know. Very rare arthrodesis and amputation. But it is never with high tibial osteotomy. And another thing, we are not using any cement here. Very few cases out of 1 lakh, probably one patient have a cement reaction. And we may have seen that because of embolism and due to cement, the patient goes into the ICU and some of them are dying also. So that is also not with the high tibial osteotomy. To conclude, even we compare the best results of the HTO is also much better than the unicondylar knee replacement. And even we compare the worst result of HTO, then also it is better than unicondylar. Even we are thinking of worst, then also it is better. Even we are thinking for the best, then also HTO is better. And another thing I want to say that HTO is knee replacement is an adapted knee, like an adapted child. That adapted child we have seen in the society that દત્તક લીધેલું બાળક તો ક્યારેક ને ક્યારેક તો યાદ તો અપાવે જ કે I am adapted, I am not your own child. So these are the, while in high tibial osteotomy we have our, just like our own child. So so much marketing, in spite of so much marketing, we all know that coconut water is always better than Coca-Cola. So there are so many marketing of unicondylar and total knee replacement, but we know by heart that high tibial osteotomy is much better than either uni or total knee replacement. In legal if I talk on the legal language, there is a one word, Greek word in the legal language, res ipsa liquitor, means the thing speaks itself. HTO speaks for itself. I have not to argue much about that. So HTO is much better than unicondylar. Thanks for your kind attention. Thank you.
Nirbhay Shah Sahib for Uni.
Uni 20230. Emma. Yeah. Thank God there are few people here. Anyway, so my work is, as I said before, I am the villain here today. So it's my very strong belief that all debates are matter of ego and nothing else. And surgeons have a very big ego. Everyone knows it. We are surgeons, we know what ego we have. So it's just a matter of ego. And another thing is a matter of what we don't do. See, if I am a joint preserving surgeon, I will not do uni, whatever be the indication or not. I'll try to do HTO whenever possible. If I'm an arthroplasty surgeon, I'll try to put uni in everything rather than doing an HTO when it's indicated. So my advice to all is, I'll talk many things, but simple one sentence advice is, learn both, do both, understand both, and decide when to do what. I think you'll be very honest with your patients, you'll be justified in what you are doing, and your patients, all your patients will be happy. Please do both and learn both. Ek ne ek, hua karun, hua nat kartan, hua am karun. Come on, why? Nothing is so difficult to do. It's very easy to learn both HTO and uni. It's very easy to do both. Bada પાસે IIT બી હોય જ છે. બधा પાસે જો ડીલર જે બહાર છે ડીલર આપણા એ ઇમ્પ્લાન્ટ યુનિના પણ આપે ને HTO ના આપે તો આપણે બે ન કરી શકીએ. એક ડીલર બે વસ્તુ કરી શકે તો એઝ અ સર્જન we can't do two things. Now, that's the biggest tragedy of us. We are trying to, segregate and do whatever is indicated. HTO is a very good surgery if you know when to do, how to do, and when not to do it. जैसे राणावत साहब कहता कि क्या न करूँ नहीं सीखो यार, तुमको कब नहीं करना वो नहीं आता. That's the biggest tragedy of surgery. And learn when to do uni and when not to do a uni. So let's start. She came to me a few years ago. She was operated 4 years before that for an ACL reconstruction by a traveling surgeon. The traveling surgeon must have come, I don't know, but must have come to the OT. Patient must be ready and ACL નાખીને જતા રહ્યા. જેમ થાય છે, બરાબર? He never saw the lateral compartment, never saw whether lateral opening હતું કે નહીં, કશું જોયું નહોતું. 4 વર્ષમાં patient was with this. This is her normal routine bipedal weight-bearing X-ray. She was walking with a lateral thrust, 28 years of age, female. આપણે uni તો નથી જ કરવાના. I'm sure anyone would do uni in this or totally in this? No. So there is something which we have to do to save the joint. And whatever we do, the basic thing to do in this કે HTO કર્યા પછી આસપાસ બધું કરો ને તો જ ટકશે, નહીં તો નહીં ટકે. Whatever ligaments you do. So it's very clear in this patient, if it is indicated, you are going to do an HTO with other things, you are not going to do anything else. So you should know what to do and what not to do. આમાં uni નથી કરવાનું. You don't do uni in this. But if an arthroplasty surgeon does a uni in this, you get a bad name. Uni is bad. The surgery is never bad. It is the surgeon who is deciding what to do and what not to do. That is the biggest curse of all surgeons. હું આ કરું છું, હું આ નથી કરતો. હું નથી કરતો, બાપા refer કર દો ને. Refer it to someone who is doing it. But you should know when to refer. And if you are doing it, do it properly. The patient will be happy. See, this is 4 years after her surgery. 4 years after we did what? We did an ACL, but we just made the holes, did an HTO with a posterior opening so that we have a forward slope, fine. And we did a PLC reconstruction because the lateral was absolutely gone. The surgeon had missed the PLC. And we did a PLC, then we fixed the ACL. ACL graft nakhi didu. We did a holes of the ACL, did an HTO, fixed the HTO, passed the ACL graft, didn't touch the ACL graft on the tibia, did a PLC reconstruction and then tightened the ACL. So you have everything. It was 2 hours of the surgery, sorry. You have everything here. We have done the PLC here, we have an ACL done here, we have an HTO with a posterior space more than the anterior, so we have the increased posterior slope downwards for anteriorly, and see she is weight bearing, and see it's very normal good knee. You are not going to do a uni in this. In such cases, you don't do it. Why blame the surgery? Why are we fighting in this? I really don't know. There is no debate. Pehla 90s માં છે ને uni હતું જ નહીં. I am working since 91. I am doing joints since 91. હું HTO જ કરતો કા uni હતું જ નહીં ભાઈ. મેં મારા મધરમાં HTO કરેલા છે ક્લોઝડ વેજ 8 વર્ષ 10 વર્ષ ચાલ્યા પછી I had to do a TKR fine so what but uni આવ્યા પછી પહેલા શું the debate was between HTO and TKR હતા ને debates ત્યારે હવે debates are between HTO and uni TKR બાજુમાં રહી ગયો કારણ ખબર જ છે કે TKR is there is no match between HTO and TKR so now because there are two closely done surgeries two surgeries maybe કંઈ ગ્રે ઝોન છે વચ્ચે કે જ્યાં પેશન્ટ્સ ક્રોસ થાય છે એટલે ઝઘડા ચાલુ થઈ ગયા કે હું કરું મારો પેશન્ટ હું આઈ ડુ ધીસ આઈ નોટ ડુ ધીસ દેટ્સ હાઉ ઇટ સ્ટાર્ટ્સ ઇટ્સ યોર નોલેજ એન્ડ ઇટ્સ યોર ઈગો વિચ ઇઝ વર્કિંગ ઇટ ઇઝ નોટ ધ સર્જરી સો ધીસ પેશન્ટ આમાં MRI ખબર નહોતી પડતી હી હેડ કમ વિથ 2 MRIs a scanogram will not show you this his problem was whenever he was walking it was going into hyperextension કે સાહેબ મારો પગ પાછળ જતો રહે છે I don't know what's going on simple sadhu there was when he fell down he had a history of injury he went into hyperextension his bone was soft anterior slope medial side માં વધારે દબાઈ ગયું the tibia got pressed anteriorly which no one detected maybe 8-10 orthopedic surgeons joint surgeons replacement surgeons MRIs scanograms it was very simple we corrected it we didn't do much what we did was an anterior open wedge osteotomy simple anterior open wedge we corrected it on table we just slope we corrected the slope to the opposite side and what we did was IITV may show anything clinically as he said we keep the opposite limb scrubbed so we were very sure how much normal hyperextension it had and we matched this to that and it was fine and he's superbly fine now 4-5 years post-op he is very happy as you can see here and see bilateral same hyperextension he still has the same he is very happy with what we have done for him ama uni thai થઈ શકે maybe you can correct the slope thai but hyperextension ma then you have to match and he is very young active hard working so it was the anterior rim injury yes but who diagnoses as I said I want all of you to understand be a complete joint surgeon, understand both the things, understand what the patient has, examine the patient, please understand what the problem is and treat it. We'll come one more. Now, she's only 37 years of age. This is the gray zone. The joint is not 37. It is not even bone to bone, it is more than bone to bone. It is not bone to bone, it is more than bone to bone. There is erosion on both sides. As you can see, it's very, and lateral, it's classic anteromedial osteoarthritis. See the femur touching the tibia, where it is? Even on the lateral side. Even on the lateral side. Yeah. But at 37, HTO, you're sure is not, maybe yes, sahib kari diye, saru jiye. I feel, as my experience is, I would do a uni in her. I am treating the anatomy exactly where it is in problem. I don't want to take a chance. She may be 37, but as I'm going to talk again, see the age of the joint. Don't see the age of the patient. But this is gray zone. He may be right if he says, I'll do an HTO, I'll do close wedge. If he says, I'll do open wedge, he may be right. He'll get a good result. Absolutely, no problem. But this is the gray zone. I would prefer a uni. I want my patient to walk early. I want him her to be good for 15, 20 years. We'll see later on. No, there was, it was opening right. I got an MRI done. Everything was fine. It was opening up to neutral, not beyond that. And classic lateral, you see, it's an anteromedial osteoarthritis. See, the ACL is intact. There is a patellofemoral also. Mild, yes. But again, as I said, as I said, PF joint, no bar. I had written there. Medial side, grade 2, grade 3, OA, medial, no problem with that. You can do a uni, there is no problem with that. This comes in the gray zone between the uni and... Yes. So, gray zone ma jhagda chalu thai jai. હું આ કરીશ અને હું આ કરીશ so gray zone ma use your experience please that's why I tell you those patients will not bother you I have to do HTO okay I'll do uni fine these patients will screw you and you should know what you want to do you can do a correction I don't say no this is gray zone આમાં તમારું ઈગો શું કહે છે તમારી આવડત શું કહે છે ને એના પર આખો આધાર છે I understand. But with the bad lateral, comparatively bad, you see the osteophytes, uni will still work better if the ACL is intact because you are not overloading the lateral compartment. Yeah, but intra-articular barabar, tami ECO ni baat karo cha, understood. But ama ACL becomes okay, becomes tight, the lateral, the stability congruity, કારણ કે આવી જાય ને તમે open, because you do a uni, your weight bearing on this becomes normal. You don't extra load. See, the understanding of uni is very bad. You are going to give that congruity to the lateral compartment where you are correcting the ligament problem. તમે space મૂકી દો છો. Your lateral becomes absolutely congruous to the opposite side. Understood? એટલે જ uni, I would prefer uni in this only because of that. Understood? TCO પણ કામ કરશે. As I said, it's a grey zone. I don't do EVCO, તો હું કરીશ નહીં uni. Because congruity. It is not alignment in this. The bone is gone. There is lot of erosion of the medial side bone also. How are you going to compensate for that? આ તો કરશું તને રિફર. અમે આજે સાંભળ્યું. I learned today. I am going to think. અને રિફર કરતા હું શીખીને કરું નહીં પોતે. Why not? So learn that. શીખો અને કરો. રિફર કરો ન આવડે તો. પણ મેં તો આજે જોયું. I learned that today. હું રિફર કરીશ અને કાં શીખીને હું કરીશ. કેમ ચિંતન બરાબર ને? શીખીને કરવાનું. હું ફોન કરીશ. બાપુ આ નથી આવડતું. Teach me and I'll do it. Why not? If I do everything in joints, EVCO is fine. Maybe 10-15 minutes of focus in what I am doing. And we still learn. અમે ચિંતનને ફોન કરીને શીખીએ. બાપુ આવડતું નથી અમને કયો ને અમે શીખીને કરશું. Why not? So either you learn or you refer or you do what you do your best, but only if it is indicated for the patient. Debate ત્યાં છે. તમારો ઈગો કેટલો નડે છે, તમારી આવડત કેટલી નડે છે, ડિબેટ ત્યાં આવે છે. No surgery is bad if it is done properly by a proper person who knows what he is doing and knows when he is not supposed to do it. Please, please. In anyone's hands, no problem. Sure. Uni will work for her because at least you coach to learn the procedure well or refer to a person who is doing it well. Fine. અમે તમને રિફર કરીએ સાહેબ. અમને લાગે છે અમે HTO કરવો છે, હું કરતો નથી સાહેબ, તમે કરી દો. I understand that, sir. પણ પેશન્ટ તો અનાપી જ રહેવાનો છે સાહેબ. નામ સર્જનનો નથી બગડતો, નામ સર્જરીનો બગડે છે. એંગલ બદલવાનું ઓપરેશન કર્યું ને કાંઈ ફેર ન પડ્યો. એ નથી કહેતા કે કોણે કર્યું, કેવી રીતે કર્યું, how it is being done. I totally understand. This, as I said, this is grey zone. I am coming from HTO to uni. I am trying to say that there are grey zones where something else works rather than what surgery is being done. That is what we all have to realize. Ego ને બાજુમાં મૂકવાનું થોડુંક, આવડત કેટલી છે જોઈ લેવાનું, આપણે કરી શકીએ એમ છે કે નહીં, મારે આમાં શું કરવું છે, what I want to do in this. Simple. Once you do that, there is no debate, please. There is no fight. 50 years female, same. Classic medial side pain, no other morbidities, 3 years, 2 to 3 years, all conservative treatment has failed. Same, grey zone. I will do HTO, I will do uni, I will do this, I will do that. See? And see the condition of the cartilage. Raw bone, bare bone, there is erosion on the tibia, there are a lot of osteophytes here. The ACL was intact. Once you do this, the ACL becomes tight, strong, tight ACL. Only when you feel it, you realize what the patient is getting back. All other osteophytes have been removed. The joint becomes very comfortable for many years. And 50 years is still a good zone to think of uni as compared to HTO. Because you have a good amount, the patient can reach 70 and you can do a TKR later on and they'll have a good life post that. 37 was very much of a grey zone. 72 years male, classic anteromedial osteoarthritis. Again, purely someone says 72, I'll do a uni. You say, what 72? I'm doing 75, 76, I can do a HTO. Both are right, both will give good results, and both surgeries are proper in this. Again, a grey zone. Fine કે નહીં સાહેબ, તમે HTO કરો તો ચાલે ને આમાં? કે ન ચાલે? TKR શું કામ? Lateral joint is superb, સાહેબ. Lateral joint is fantastic. અમે તો clinically, again, as I said, sir, yes, the lateral joint is superb. Why do you touch it?
સાહેબ તમે MRI કરાવો છો આમાં 72 માં?
હા, MRI કરાવ્યું, absolute. Again, મોટું હોય ડાઉટ અમે તમને પહેલાં કીધું, MRI કરાવવાનું, ACL જોવાનું, if he is more older કારણ કે degenerate હોય, અથવા lateral cartilage જોવાની, એના વગર નહીં કરવાનું. Plus, it was classic anteromedial. એટલે મેં આગળ વધ્યો, નહીં તો I would not have thought of it. My highest is 78 years. Again, MRI, હું તો બહુ કહું છું, MRI કરાવો બાપા, એ તો 4,000 ખર્ચાય, ભલે ખર્ચતા. Let them spend that 4,000, doesn't worry. 1.5 lakh આમાં ખર્ચે છે, they can spend 4,000 more. Get an MRI done. Get very sure what you are doing. Even in HTO, suppose there is a doubt, Carillion bhai, what is the problem? What's anything wrong in that? They are fighting. This is absolute like the Israel-Hamas war.
Lateral cartilage.
There is not going to be any solution to this. I am better, I am better, I am going to win the war, I am going to win the war. Russia, Ukraine, બધું આ જ છે. Decide what you want to do, learn everything that you can do in whatever you want to do. Again, 68, ANI, failed conservative, HTO or Uni. There are so many things. Again, this patient came to me with a severe varus knee, severe osteoarthritis, tri-compartment. She was done a lateral wedge, closing wedge, high tibial osteotomy. For 1 year, she came 1 year after the operated knee. And it was, you can see the condition of the joint before, after. Now this is how you are extending the indication. This is my clear indication. કે આમાં maybe TKR જ હતું પહેલાથી. HTO હતું જ નહીં. છતાંય આપણે HTO કરીએ તો પછી it's not the fault of the surgery. It is either our ego or our lack of knowledge of doing a TKR, or maybe no, I am happy with TKR, I'm getting very good, I'll do it fine. But then if you land up in failure, it is the failure of the decision, not the surgery, the decision of the surgeon. So the debate doesn't, it's always a fight. Jeetwanu, harvanu, it is nonsense. See where your ego is, see what you are doing there. Is it going to help the patient? Are you going to find a way for the patient? And I think everything works well. This is the circle of life. This is the gray zone. Where your ego and knowledge each काम करे छे. Nothing else works. Both surgeries are good. Both have stood the test of time. 50 વર્ષ થી તો Uni available છે. It is not in market only because of companies push. Surgeon ne result મળ્યો, patient ne result મળ્યો તો જ ટઈકો એ market માં. So many things came into the market and disappeared. મને કયો કેટલા નથી disappear થયા? All કેટલા surgeries, implants disappear નથી થયા? Fine, that is his way of looking at things. After 17 years, I understand. After 17 years, મારા પેશન્ટ ચોટીલા ચડીને પ્રસાદ લઈને આવે છે મારી પાસે. એવું નથી કે નથી કરતા, ટ્રેકિંગ કરે છે. પ્રસાદ લઈને મને આપી સાહેબ ચોટીલા જઈ આવ્યા, ઓલો ખોડિયાર માતાનું મંદિર પહાડ પર ચડી આવ્યા. They are doing good life, happy life. More are females, let me tell you that, yes. But they do live a very active life. Forget in India, you don't say sports, but પગથિયા ચડવાના, ખાડા ખબડામાં ચાલવાનું, ઉપર નીચે ચડવાનું, you're working normal walk in the house, going out, you are going for buying vegetables and groceries. You keep on walking, moving around, living life, impact. Sportsmen, I understand young sports people, yes, you don't do a uni. I never say that you do a uni in such a case. As I said, indicated. What is indicated, do that. What is necessary for the patient, do that. Let's not fight with it. Let's not use our ego to decide what is necessary. So, both HTO and Uni-knees are specific procedures which were meant for specific indications, and both have stood the test of time. Please understand that. 17 years is not less, 50 years, 32 years na follow-up. Or Dr. Swart from Sweden, 20 years na follow-up cheni paase. Tyare, I'm talking of 10 years ago. Now, 30 વર્ષ na follow-up cheni paase. It is not that it's just like that. So there has to be something which is being done right. So both sides, HTO has stood the test of time. It has to be a good surgery. A surgeon has to be well versed in understanding and performing both procedures so as to rightly choose one.
Hello, ha. So the gray zone patients are the one where it is not the merit of the procedure, but the experience of the surgeon along with his ego work more than his desire and the demands of the patient. And so learn both the procedures thoroughly. તમે કરો એ જરૂરી નથી, but you should know about both the procedures properly, what I need to advise and whether I need to refer or not. And know when to do which and advise accordingly. Problems occur when you stretch the indications either due to inability to understand which procedure or the lack of the skill to do it. Understand the age of the joint rather than the age of the patient. This is when your ego works and not your experience.
Nirvay,
yes, please.
Supposing a patient comes in a gray zone.
Yeah.
To you.
Yeah.
And you are adept at both HTO and
Fine.
the Uni.
Fine.
So when will you do which?
Patient is young, hardworking, farmer, or wants to do sports, I will go for a HTO. Female, थोड़ा sedentary lifestyle, I know she's never going to play sports, 40, 45, and I see it's bone to bone. I'm sure that the cartilage is not there, it's bare bone. I would go for a uni. I'm very clear about that, and I'm happy with it all these years. I do both, so I'm sure this is happy, and my patients are happy. I may be wrong sometimes, maybe 10 Matthew Bema Mari Bhule Thai hoy. I should have done that or this, but fine. 5 થયા છે અત્યાર સુધી એમાં 2 TKR માં કન્વર્ટ થયા છે. 2 they have gone somewhere else. So 5 failures in out of almost 1100 in 17 years. So I think અને બીજે બધાના આ જ રિઝલ્ટ છે. That Dr. Swad from Sweden, he had that, એ કેવા ડોક્ટર હતા, એનો આખો હેન્ડ રિટન ચોપડો હતો. He used to write everything by hand. So he had that big huge chopra.
And most of his patients outlived his knee.
Most of the patients outlived knee. And Sweden में એવું છે કે કોઈ બહુ migrate નથી કરતા, they don't leave the country, they are there in the same address. So he had followed up all 100% follow-up rate. He followed 1,000 patients for 20 years. And his success rate was more than 92%. And on his own, one surgeon, single surgeon. See, I think that is better. Multiple surgeon karo, surgeon ma bhool, surgeon na hath ma skill ma, there is a difference. So multi-center studies, I am not very happy with that. Single surgeon studies, because one person has done it, all his mistakes are his own. All his errors are his own. So let's focus on that. I think that works. And overall, yes, failures are there in everything. HTO માં શું failure નથી ભાઈ, ભૂલ થાય છે, બધાથી થઈ હોય, કેમ ન થાય? સાહેબે કેટલું frankly કીધું કે મારાથી આટલું જો આટલું થયું છે. It is there. પછી TKR માં પ્રોબ્લેમ થાય, બહુ વાલ્ગસ થઈ જાય તો TKR ના પ્રોબ્લેમ્સ છે. There are problems. એવું નથી કે પ્રોબ્લેમ્સ નથી. એને તમે છે ને when you dislocate the patella, we are afraid કે અમારો patella tendon નીકળી જાય ઘણીવાર when it's a valgus knee. It is a problem, sir. એટલું easy નથી. It takes problem. અને અમુકમાં તો we have had to do a osteotomy, remove the patella, tibial tuberosity beforehand, do and refix it once we have done the TKR. એટલે knee flexion 70-80 degree આવે, વધારે ના આવે. There are problems. એવું નથી કે HTO પછી TKR માં અને uni પછી પણ છે. If you are not careful, they are there. Fine.
એ કે ભાઈ તમે જે કરવું એ કરો, પણ મારે રિપ્લેસમેન્ટ નથી કરવું. Then you will do HTO or not. That's because this kind of patient usually I get, patient finds me only reason that I am not doing total knee replacement. And there is some of the group of the patients in the society, particularly after Ayushman card.
They have seen failure in their family.
They will die. They will die, but they will not undergo total knee replacement because some of the their near and dear ones face a complication.
That is where my point comes, that uni is not TKR. Don't mix.
No, uni is a half replacement. In market, that is why. No, that is, uni is half replacement. Uni is half replacement. See, Gadi, you are not removing bone? Do you not remove? Market is, that is why I am telling that they are saying that it's a knee preservation. So how can we say knee preservation? It's not a knee preservation. Obviously, it's not a knee.
See the
knee preservation.
TKR marketing, how it is done? TKR marketing. કે તમને બીજે દિવસથી દોડતા કરી દઈશું. બરાબર છે? તમને દુખાવો નહીં થાય. બરાબર છે? હે? કસરત તો અમારે અમે શીખવાડી દઈશું બધું. બરાબર છે? This is what the psychology is. How the patients are being they are trapped for TKR. બરાબર છે? So my question to them, I face such questions by my patients. When I say them that we can preserve your knee. પણ કે એમાં તો દુખાવો બહુ થાય.
I understand.
The straight answer which I am giving to them is કે બે સ્ટીલની તપેલીઓ અથડાય તો દુખાવો કેવી રીતે થાય? અવાજ થાય ખાલી, દુખાવો ના થાય. Because we are preserving your knee, pain will be there, but you will be able to preserve. દાંતનો દુખાવો થાય તો ચોકઠું કરાવી લો. knee replacement એ ઘૂંટણનું ચોકઠું છે. એ મગજમાં ઠોકી દેવાનું.
See, that is okay. And another thing, what I want to conclude, કે after uni or knee after HTO the complication happens that I have already accepted, but આમાંય થાય છે, પણ આમાં જે થાય છે ને HTO પછી એ પેશન્ટ માફ કરી દેવા થાય છે. That is the only statement.
ક્વેશ્ચનનો એક જ જવાબ છે કે આ પેશન્ટ મારું ફેમિલી મેમ્બર છે તો વોટ આઈ વિલ ડુ. That is the only answer.
Sir.
No, then your intentions are clear.
Sir.
Then you may make mistakes. That is not.
Nirbhay sir, one. Nah, sir. Sir.
That is the only filter possible.
Sir, do you feel that when the uni started, there were written contraindications, that age more than 100, weight more than 100? No, when it started.
I am telling you, અમે જ્યારે મેં વાંચ્યું ને ત્યારે જો 2006માં કોઈ એવું ઇન્ટરનેટ કે ગૂગલ કાંઈ નહોતું. મારી પાસે લિટરેચર હતું. હું ઓસ્ટ્રેલિયા ડૉક્ટર મર્સર છે જે અમે એડલેડમાં કરતા હતા. હી વોઝ ડુઈંગ ધીસ. ડૉક્ટર જેગાન કૃષ્ણન વોઝ ડુઈંગ યુની, પણ એ સ્મિથ નેફ્યુનું કરતા હતા. ઓલું ઓક્ઝિનિયમ એ વખતે આપણે તો જોઈને ગાંડા થઈ ગયા આવું આવે. એ સ્મિથ નેફ્યુનું કરતા હતા, પણ આઈ વોઝ નોટ વેરી હેપી. મર્સરે જ્યારે સિવિલ ગવર્મેન્ટ સેટઅપમાં કરતા ને ત્યારે આઈ સો હિમ ડુરિંગ ધ ઓક્સફર્ડ, અને આઈ ફાઉન્ડ ઇટ વેરી કન્વિન્સિંગ. એને મને એનું પ્રિન્ટેડ લિટરેચર ને બધું આપણે વાંચ્યું ત્યારે એમાં બહુ ક્લિયર લખેલું છે. પછી પહેલી વાર જ્યારે અમે અટેન્ડ કર્યું ત્યારે પણ બહુ જ્યારે કીધું હતું. Sorry, yeah. So there was no internet, no Google, nothing. We were given written all Xerox copies. वो जर्नल में से कॉपी करके Xerox copies देते थे. याद है ना, कोई गया होगा फॉरेन तो भाई निर्भय तेरे लिए मैं Xerox करके आ गया, you know, like that. So he gave me all those Xerox copies, all those literature, this, that. I read, and then I asked him questions. He was doing since years. Slowly and steadily I realized, and then when we came to the first that I attended, when Biomet came to India in 2010-11, and we did the course, the first thing they said was, age no bar, weight no bar. મારે 115 કિલો છે.
That is what I am telling.
This is I have done 8-10 years ago, not now. This was old.
This is what is happening. The initial contraindications to a procedure get diluted gradually to
even initially these contraindications.
Patellofemoral joint, if there is involvement, you should not do it. That was initial doctrine. That was initial doctrine. That was initial doctrine.
Attended also. I know he has attended Oxford. Jo, સાંભળો, yeah, he has attended. I know it. Yeah. Started, I'm telling you, yeah. Yes. MRIs nata ne bhai. There was no MRI available who could show you the cartilage. Now we have MRI. There is no need of arthroscopy. When in doubt, take an MRI. Tell the radio, my cartilage barabar jo che, do that. Show me the cartilage properly. Yeah. So even HTO. But sir, even HTO, the indications are expanding.
Sahib, young લોકોનો issue.
Even HTO, the indications are expanding, sir. Yeah. Sahib, मैं मारी जिंदगी में नत कही रूप. I've never touched the clavicle fracture. कोई मारे patient तो मैंने not come and hit me. And they are doing plating. My son says you have to fix the clavicle. I look at him and say, okay, fine, that's what you do. I will not do it.
ના સાહેબ, young લોકોમાં તો
કોણે ફિક્સ કર્યું clavicle આમ જો તો.
ના young લોકોનો તો પ્રશ્ન એ છે કે HTO સમજતા જ નથી.
But that is the biggest.
Why it is so, sir? I have passed my MS in 2015 and I had not seen a single case. I had seen many replacement. If I have not seen my studies, how can I convince to my patient?
But I had seen
and that is why we are over here, we are learning.
Yes. No, but Kuldeep, no, let me see. In my training in 91, who Sancheti Mato, I saw so many HTOs because Sancheti Sahib was master in closed wedge. And he base screw nakhi ne tension band mein bow કર્યું છે. મારા mother માં જ કર્યું base screw ne tension band. એ Sancheti Sahib ઈ જ કરતા. And I never saw a replacement.
એટલે અહીંયા the people here would understand to sell at least. Like the selling the tibia, nail, DHS, PFN, uni, total or whatever. How to sell, why to sell, when to sell.
Yeah, please, have to. अब बदन घरे जावा दियो હવે. હવે one thing, અમે રેઝિડેન્સીમાં તમે નહીં, અમે આર્થ્રોસ્કોપી કે રિપ્લેસમેન્ટ વિશે સાંભળ્યું પણ નહોતું. અમે કીધું કેટી ધોળકિયા સાહેબ કરે. હવે એવું તો આપણે સાંભળ્યું હતું. અમારા સાહેબ તો ઓલું જેનેલ નાખતા અને એવું બધું કરતા, કાંઈ જોયું જ નહોતું કાંઈક. અને એમ પ્રોસ્થેસિસ ઠોકતા દે ધનાધન, કાંઈ આવડતું નહોતું. વોટ વી હેવ લર્ન્ડ ઇઝ ઓલ આફ્ટર MS. જોઈને જઈને શીખીને પ્રાઇવેટ પ્રેક્ટિસ બંધ કરીને 6 મહિના. તો પ્લીઝ સ્ટાર્ટ.
ના લેક્ચર તો ઠીક છે હવે, પણ સો બોન ખાલી જસ્ટ ઇન શો
વિડીયો હોય તો સાહેબ એમ કરે. વિડીયો અંડરસ્ટુડ નોટ ધ વે હી ડુ. બધું ઇંચ બચાવવાનું, લેટરલ ને પોસ્ટિરિયર.
હલો બસ હલો. At present, for the young orthopedic surgeon, it is a good opportunity to learn close wedge or open wedge. Why? Because if you want to learn, અત્યારે આયુષ્માન કાર્ડમાં 55 નીચે ની રિપ્લેસમેન્ટ કે યુની કશું આપતા નથી. You try in few of your patient who has Ayushman card, because here we can fix it with a simple plate also. It doesn't require tomo fix. We have to remove the wedge and we have to close the wedge and then fix it with this. Like ચાલુ છે આ દેખાય. This is how medial, it should be exactly at the medial border. We have to check it with the center, patella exactly in the center, and we have to fix this like this. Bijjo object here. It's very simple. Initially you cannot have a intact lateral cortex or posterior cortex. Remove the triangular piece and close it when you are doing first time. So this is how we have an option of 4 K wires. Here we are fixing 2. We have to remove 12-degree wedge. We'll copy them. Show. So what? બે છેડા કાપી કાઢવાના, કશું. There is nothing more we have to do. This is how. નહીં આ કાપી કાઢવાનું, કેવાર કાઢવાનું. See, this is how. It is fixed with the K wire, but here, so at least don't cut with the show. પકડી રાખ. Now we can remove this. Now this wedge is ready. Now અહીંથી થશે. હવે અહીંથી જોવું પડે, આ બાજુ બતાવવું પડશે. ઇટ્સ ઓકે, બટ ધીસ ઓકે હા, these two limbs should be parallel.
These two. Right. હવે posterior cortex initially drill અથવા blunt બહુ sharp osteotomy ના હોય ને very sharp એનાથી કટ કરી નાખવાનું બસ sharp એટલે it's નહીં cortex નહીં we have to break the cortex at present I am હા ના combination is okay નહીં sharp હોય તો combination ના થાય પણ I made a groove with a show that I can feel it. See, I made a groove on the posterior cortex. It's just last one. It's 1 millimeter only, and then we have to with sharp. So there is a popliteus muscle, so it will prevent osteotomy. Nothing corticotomy. So here there is no fear of cutting the posterior tibial vessel, so I am cutting with this. Bas this is wedge is removed. We can have a good bone graft. So we have to close like this, right? And then we have to fix it with a plate, any plate, simple buttress plate, T buttress plate, that we are using in our residency. No, that is at present I am doing. I am just, anybody is doing first time, then don't go in much detail, lateral tension band and medial locking plate. You remove the wedge, fix it whatever the method you want. You can adapt gradually here, and I will suggest don't put only medial plate, because I have faced the complication of collapse on the medial side later on, says Dr. Manoj Kumar. I think he has left, but he has faced. So what happens if we fix only lateral side, then it collapses on the medial side and loss of correction. So that is happens with a locking plate, it happens less, but if with locking lateral plate also I have faced loss of correction gradually. So I fix it on the medial side, and then it will not give any loss. So this is how we do, and then fix it with like this. Right? See, that is again apex is at the as Sir said, concavo-convex surface. This is here, this is the apex, where convex surface finishes and concave surface starts. That is the apex, that is in the metaphysis. And base just below the attachment of patellar tendon. Just below the attachment of patellar tendon is complete. Then and then we can rotate somewhere. Yeah. So this is the apex. This is the apex. Here VH can give below. This is here the patellar attachment of patellar tendon ends. So this is how the apex is kept, like exactly at the medial border with a patella in center. With a patella in center, this should be exactly, it should not be like this, it should not be this. And then this is how we do. This is the way we see. Here is a sloping surface. Here is a parallel vertical. So this has a soft tissue attachment. Later on, after doing few osteotomies, you can preserve lateral cortex. Initially, you may not complicate the surgery. And another, later on, you can preserve the posterior cortex also. That is gradual, but initially remove, close, fix. That is the only thing. Laterally, exactly if you want to do lateral tension bend, initially I was passing 2 parallel screws, but at present I have, this model is there here. So, then initially, but at present I put a just below, parallel to the articular surface and subchondral. And distal is little away from the osteotomy side, and then I do tension band wiring on this. So this tap is, pink tap is representing the soft tissue attachment of this piece. And here also this gap we can see, but this gap is not, so it will not be a gap even after closed wedge. So little gap also. And in many times in X-ray you will not able to appreciate that it is osteotomized. It looks like a normal fixation of plating. And here is the posterior cortex which I kept intact, but that is after few, that is with few, after few osteotomy. You first you do simple thing and then you, yeah, that gives stability. It is stable, you cannot move it, osteotomy. Even on weight bearing, if you do a full weight bearing, we don't allow, but if you, by accident patient can have a full weight bearing, then there will be no movement at osteotomy site.
So you can put in a plate as well? Dual plate as well, you can do?
Yeah, yes, I have done dual plate also. We can have, but advantage of lateral tension band, if we tighten, it will close.
Yeah.
We tighten the SS wire and it will close. So it becomes so stable, after even many times we feel that there is no need of plate. It's so stable after tension band, but we have to put the plate. Any choice, any implant choice, I don't have any choice, but I use Tomofix because of its strength. And they have a property of early weight bearing. That is why I use Tomofix. But initially I have used lateral simple hockey plate and then double plating. Everything I have done because I have started from year 2000, Tibial osteotomy. So,
any question?
Second day, huh? Partial weight bearing second day.
PF. I have done, sir, one case where one side I had done HTO and one side is PFO, and it's just been a 3 years only. Patient is happy both side, but just a 3 years.
No, but
that was also that way, learning way. Card vadu, ma card.
PFO.
I was a ghost surgeon, sir. I went somewhere else and done.
Osteotomy of large bone. Osteotomy of large
Osteotomy of large bone package.
18,000 package.
5 minute no काम. Distal femoral osteotomy. Talk will be given by Dinesh, sir. I request sir to finish it earlier.
As we have learned in exercises that when the deformity is in the femur, we have to do it in the femur. Very fast. We have done this exercise today. Here is the varus of 12 degree. But if we measure the LDF and MPTA, the LDF, this is anatomical. What we have done exercise of mechanical lateral distal femoral angle. Mechanical distal femoral angle is 87 plus or minus 3. And anatomical lateral distal femoral angle is 81 plus or minus 3.
Yes.
Right? There is a difference of 6 degree that we all know. So here LDFA, anatomical LDFA is 92 and MPTA is 87. So 87 is a normal value for MPTA. If you remember the normal figures, MPTA normal is 87. So here the femur. So we have to correct it in the femur. So lateral close wedge was planned like this in a distal femur. This is the wedge which was removed like this, and it was closed with the, after closure we can fix with the there are a plate available of AO, but it is a simple distal femoral locking plate. So that is how we can do distal femoral osteotomy. The important is pre-operative planning. How much weight is to be removed, that is very important. And the Miniaki method for femur will differ. That I will show you. This is the clinical picture of that particular patient. And weight-bearing axis is very well passed. Even little overcorrection we can appreciate. It goes through the lateral tibial spine. Here is the patient, 40-year-old male, pain while walking since 2 to 3 years. On examination, there is some laxity of lateral collateral ligament, and even we can see weight-bearing on weight-bearing X-ray. There is 18 degree of varus and some opening of lateral joint space also. This is weight-bearing X-ray. But if we take the non-weight-bearing X-ray, there is no opening of lateral joint space. This is non-weight-bearing X-ray. On non-weight-bearing X-ray, varus is 13 degree. On weight-bearing, there is 18 degree of varus. So whatever the planning I am doing is in the non-weight-bearing full-length X-ray. So how we plan it? First, we have to measure LDFA and MPTA. Here, mechanical LDFA is 98. So varus is in the femur. And MPTA is 84. So 87 is plus or minus 3 is near normal value. There is a 3 degree of varus. So in that particular patient, I have planned the distal femoral osteotomy. So how we plan? The method will be reverse. First, mechanical line is drawn. Then line 1 represents the planned weight-bearing line. That will be start from ankle. We were starting from the hip in tibia. In femur, we will start from the ankle. So this should pass through the Fujisawa point, and this length of mechanical axis and this length of the planned weight-bearing axis should be same. Then we have to bring this center of femoral head here after. So this is the method. This is the hinge point. From hinge point to the present hip joint, and from hinge point to the future hip joint, where we want to bring center of the hip joint in future. So this is the angle, that is 19 degree comes in this particular patient. And then we have to remove wedge of 19 degree. And this is a clinical picture before surgery. This is on weight-bearing full-length X-ray. After surgery, this is the well-aligned knee. And I usually do double plating nowadays. Initially, I was fixed it with the one plate only. Why double plating? Because only reason to do double plate is my patient wants, I allow the patient weight-bearing on the next day. I don't want to keep him, because my surgery is compared with the total knee replacement at present. So everybody, otherwise, if I don't do surgery, they will go for the total knee replacement. And these replacement people attracts them, only reason is early weight bearing and back to the normal work. So my patient usually goes at the end of 6 weeks, they are doing normal, not as early as total knee replacement. So I fix it in most of the cases with a double plate, but still we can notice on weight bearing, there is no, this is weight bearing X-ray after a few months, and this, there is, after surgery we can see that there is no opening of the lateral joint space on weight bearing. And the patient can even see, he can sit cross-leg and even pray namaz at the end of 6 months. This picture is of at the end of 6 months. Now, again, this is 65-year-old obese lady suffering from pain in her both knees, more in her right knee since more than 10 years. On X-ray, there is a valgus of 10 degree and dynamic valgus is 5 degree. So if on weight bearing valgus is 15 degree and on non-weight bearing it is 10 degree. So we have to, was removed of 17 degree. It was closed like this and was fixed with the plate, and this is the post-operative X-ray. Here we can see that here there is no double plating, so patient was kept and was obese, so she was kept 6 non-weight bearing or partial weight bearing for 6 weeks. So this is how full-length post-operative X-ray shows the weight bearing axis is little medial, little bit of overcorrection. One another patient, valgus knee, medial close wedge high tibial osteotomy. This is again here we can see that weight bearing shows 12 degree of valgus and non-weight bearing shows 8 degree of valgus. If I plan on the weight bearing X-ray, then there will be 4 degree of overcorrection. So it's not acceptable to me at least. So I did on the non-weight bearing X-ray planning. So 14 degree wedge has to be removed from the medial side, and that is after correction and double plating. And this is the clinical picture what we can see after distal femoral osteotomy, right? So this is how the planning of medial closing wedge and lateral closing wedge high tibial osteotomy in distal femur, in distal femoral osteotomy. So this again 35-year-old male patient, came with complaint of pain in both knee joint, more in the right knee while walking since 3 to 4 years. Cannot walk for the long distance. No history of any injury previously. His weight is 109 kg. So we took the X-ray. We can see weight bearing and non-weight bearing. On weight bearing, there is 28 degree of varus and opening of lateral joint space. In non-weight bearing, only 10 degree of varus. So we have to plan according to non-weight bearing. As he was very young, I was very careful to do it as perfect as possible. So I take the, how he was walking. We can see here, there is a opening of lateral joint space on weight bearing. There is a dynamic varus we can see on weight bearing, and planning was done in the non-weight bearing X-ray. And then in non-weight bearing X-ray, anatomical lateral distal femoral is 87, so it should be 81. Normal value is 81, so it's altered obviously. So here MPTA is 83, so is also altered, 87 plus or minus 3. So there is a 4 degree of varus in tibia and 6 degree of varus in femur. So we planned, and JLCA is 18 degree on weight bearing X-ray. So we plan in both, conclusion 6 degree varus, so 8 degree correction in femur was planned and 8 degree correction in tibia was planned, and there was a planning of over correction for 4 to 6 degrees. So we did first in the tibia, and after tibia weight bearing axis was little bit passing through the medial side. So again planning full length X-ray was taken after doing tibial osteotomy, and then we plan it for the femur, and then femur close wedge femoral osteotomy was also done, and how the weight bearing axis was shifted to in the lateral compartment near the Fujisawa point. I understand that it's little over correction as more than expected, but it is okay. And weight bearing X-ray we can see this is weight bearing X-ray, and there is no opening of lateral joint space after realignment surgery. And this is how he was walking before, and after surgery he belongs to Dubai. He came here for surgery only. 35-year-old only, and now on weight bearing we can appreciate that on weight bearing there is no opening of. And one more patient, this is the last patient, polio with laxity of lateral collateral ligament, 49-year-old. On weight bearing there is a opening of lateral joint space here, and recurvatum also. On weight bearing there was a lot of recurvatum because of lax ligaments and polio, because of altered dynamics due to poliomyelitis, and how he was walking before surgery. We can appreciate this, even clinically we can appreciate this, there is an opening of lateral joint space here. This is how he was walking before surgery, and 11 degree of varus, and this planning was to correct the recurvatum and to correct the varus. To correct the recurvatum we need to do altered posterior tibial slope. To increase posterior tibial slope is normal actually here, but I have to increase only to prevent recurvatum. So I planned open wedge weight bearing, and one is weight bearing X-ray. And pre-op we can see that there was opening of joint space in a weight bearing, while post-op there is no opening of lateral joint space after doing proximal tibial and distal femoral osteotomy. And how and recurvatum was also corrected here. On full weight bearing we can see how much it was recurvatum, and after surgery limb become straight. So if we compare the pre-operative and post-operative gait, how he was walking before and after, we can appreciate his gait from gait that knee has become stable now. There is no laxity of only bony correction, no any ligament reconstruction or nothing has been done. Only increased posterior tibial slope and correction of varus has solved problem of this patient. Thank you again. Please don't kill, save knee, and thanks for your kind attention. Thank you. Everybody is tired, I understand, but this is the last talk, so valedictory and vote of thanks from Dr. Ketan bhai. I am very organizers, particularly Rao sir and Ketan sir, for allowing to, as a president and secretary of Gujarat Orthopedic Association, they allowed me to organize this high tibial osteotomy, and there was a lot of efforts from both of them. Accept this program, designing this program.
His determination, dedication and devotion to this specialty branch, I would say, is phenomenal. Big clap for him once again. He traveled right from Kanpur, and it has been an absolute pleasure to have you with us, sir. Dr. Dinesh Thakkar's commitment and the sincerity, the planning and the implementation of the entire program has been, again, wonderful. So, full marks to him, and a big gratitude to him as well for sharing all his slides, especially for me. And our three commanders-in-chief here, Chintan, Vadi, Kuldeep, and Kaushal, you have done a fabulous job, and keep that up. We'll keep on having you in the future programs. Of course, all the other faculties, Dr. Navin Bhai has almost become a family part of Rajkot Orthopedic Society. And being the Secretary General of the Indian Orthopedic Association, his contribution has always been immense. Small little points, guidance is here and there. They are a big help, let me tell you, sir. Samir, a close friend from Baroda, I met him after a long time, but great to have you here, Samir, with your inputs on TCVO. And of course, all the delegates, besides that, of course, and last but not the least, I would also like to thank all the delegates. People have come from Delhi, people have come from Nagpur, people have come from various parts. Again, a big thank to Dinesh Bhai because he had worked on that part. So once again, all the delegates, a big thank you for coming and making this program enlightened as much as it was possible. All the other supporting faculties, the hotel management, the audiovisual team, everybody, I think, deserves a big round of applause. Thank you very much, everybody. And hope to see you soon in some other GOA programs. Thank you very much.